లక్ష్మి మా
just now only, so I mean, not yes. Doctor group doctor Prabhu group medical medical medical
అది సామా స్టార్టింగ్
లేదు లేదు మా వాళ్ళు టాప్
అప్పుడు వస్తాను అదే అనుకున్నాను
అని ఒక తమ్ముళ్ళు చూపిస్తుంది కదా అదేంటండి ఇమేజ్ వస్తుంది కదా అది దీంట్లో సెటప్ చేసిందా ఇమేజ్ వస్తుంది
కొంచెం లేట్
అదేందో ఇమేజ్ మనం చేంజ్ చేయొచ్చా ఇమేజ్ ఇది ఇమేజ్ ఇమేజ్ ఈ వీడియో యూట్యూబ్ లో తర్వాత సేవ్ అవుతుంది సో ఫస్ట్ మేము ఏదైతే క్రియేట్ చేసామో అది కాదు
డైరెక్ట్ యూట్యూబ్
Good morning. Good morning. Good morning. Okay. Thank you. A hearty welcome goes to everyone who are present over here. A special welcome goes to dignitaries who is Dias here. And today we are celebrating World Heart Day program. Now I would like to request Miss Esther Rani Madam to come forward and talk about welcome remarks regarding this program.
Yeah, thank you, Teshu. Good morning, everyone. So I hope everyone knows that why we gathered here, right? Okay, so the World and the World Heart Federation biggest awareness rising platform for CVD. World Heart Day is celebrated every year on 29th September. In May 2012, world leaders committed to reducing the global mortality from non-communicable diseases by 25%, and cardiovascular disease is accountable for nearly half of all non-communicable diseases, making in the world number of the killer. So heart disease and stroke in the world is leading cause of death. So World Heart is a global campaign during which individuals, families, communities, and our governments around the world participate in activities to take the charge of their heart and health of the others. So that this companion, the World Heart Federation unites people from all countries and background in the fight against the CVD burden and inspires and drives the international action to encourage the heart healthy living across the world. So by this word, today I would like to start this program. So before starting this program, we'll start inauguration. So I request Dr. Rakesh Prabhu sir, Group CMO Medicover Hospitals, and I request Dr. Mata Prasad sir, Center Head for Madhapur IP, and I request Ms. Swati ma'am, Group Nursing Head for Medicover Hospitals, and I request Ms. Anusha ma'am, Deputy Medical Superintendent for Madhapur IP, and I request Ms. Bhavani ma'am, Nursing Head for Medicover Women and Child, and I request Ms. Seshamma ma'am, nursing head for Medicover Cancer Institute, and I request Vasumati ma'am, operations. Ma'am, please come. Yeah, thank you. Thank you so much, sir and ma'am. So, Miss Tesha, you can continue now.
Thank you, ma'am and sir, for inaugurating this program. Now we have welcome dance by Miss Anne Maria Jose. Please come forward and perform the dance. Thank you so much, Anne Maria Jose, for your wonderful performance. You have kept your heart and soul while performing this song. Thank you so much, and keep rocking like this. All the best. Now, now we are now. I would like to welcome Dr. Rakesh Prabhu sir, Group CMO Medicore Hospital. Sir will sir please come forward and talk about few words.
Good morning, all. Glad to see a nice gathering of all the nursing leaders. Very happy and enthusiastic faces, both on the screen and off the screen. Happy? Yeah, glad. So I've seen the scientific schedule. The topics are beautifully chosen and tagged with amazing speakers. So do you know what we call the nurses as? If the doctors are the brains for the healthcare, sisters, nurses are the hearts of the healthcare. So to teach these hearts about the hearts, it's quite an interesting topic. Well, without wasting much of your time, I'll leave it to you. I wish you all the very best. Thank you.
So I request Mr. Mata Prasad sir to talk few words about this program.
Good morning, all. Happy World Heart Day to all of you for 2021. As I understand, 2022. As I understand, this time theme is CTVS for cardiovascular surgery procedures. I again once welcome everybody for this event, and please carry on with the work. For tomorrow's, I just want to invite you all for the celebration which we are doing, walkathon tomorrow morning. I think already nursing GB has already told you. So please come everybody and make a great success tomorrow, where we are calling our chief guest, our MLA, Mr. Gandhi. And as already Dr. Rakesh Prabhu said that nurses are heart of the healthcare. So I am agree with that. Please carry on with your work, with your program. Thank you.
Thank you, sir. Thank you so much for your valuable words. Now I request Ms. Anusha ma'am to talk few about this program.
Good morning, one and all. So when the whole world, when all other healthcare organizations, even all the hospitals in our group, they were behind planning World Heart Day celebrations. How do we do it? How do we market the services that we are offering in the hospital? How will the public know what kind of cardiology and CTVS team and the services that we have? So when everyone was running behind it, we uniquely chose to educate and sensitize the internal team about the importance of World Health Day. And I heartfully congratulate and appreciate GB and her team for coming up with this beautiful idea of conducting an academic program for the nursing staff on the occasion of World Health Day. So it is equally important to educate and empower the internal staff, medical, nursing, and everyone about the kind of services that we can offer, we can cater to, and then and we ourselves, after a educative and informative session, will be aware of how big we are and how far we can grow in this regards. So being the cardiology and CTVS being our first and important medical service that we offer. So this is a very encouraging move by all the nursing leaders to come up. And I'm very happy and I'm looking forward to more and more educative sessions that will happen, because you are the core of all kind of healthcare services that anyone can offer. And if you are strong, we are strong as an organization. Congratulations, each and everyone, for this innovative thought, and keep coming. We want more and more of this. Thank you.
Thank you so much, ma'am, for your valuable words. Definitely in future, we will come up this kind of programs. Now I request Ms. Swati, ma'am, to talk few words about this program.
Good morning, everyone. I know we are short of running time. Once again, I wish you World Heart Day. I know this is the greatest occasion and a big celebration. We have seen whole wide country many deaths occurred due to cardiovascular diseases because of poor health lifestyle and lifestyle modifications, and we have a lot of death rate in India. So due to this, I thought this process should be innovative for my nurses, and behind the program, I always encourage my nursing heads to do a lot of educational activity. As a leader, you need to inspire and motivate many people on job training, like what they have to learn and how they have to implement on bedside training. That is very important, and more focus on job training. Wherever you learn theoretically, but until unless if you don't practice, I think these kind of symposiums and workshop will helpful, and it will be motivated, and it will be energized your day-to-day activities. So with this note, I would like to congratulate each and every participant. I think by take-home message, you will be benefited such kind of workshops and symposiums. We never stop. This is just beginning. We will do in future, as Dr. Anusha and Dr. Rakesh sir, and as well as Dr. Matasa represented. And I wholeheartedly thank senior management, especially Dr. Sharath Reddy sir. He is the key person, always inspires and motivates us to do such kind of workshops. And Dr. Rakesh Prabhu, our group CMO, he encourages us to do a lot of academic activities. And Mr. Hari Krishna and Dr. Anil Krishna sir. He is a great, remarkable leader with us to do such kind of activities. Thank you so much, entire Medicover team, to do participate a lot of engaging such kind of events. Thank you so much.
Thank you, ma'am. Thank you so much for your valuable words. Teja, you can take.
Okay. Now I would like to welcome Dr. Lalit Agarwal sir. He is a consultant and interventional cardiologist, and he completed his MBBS and DMB medicine and DMB cardiology. And he is an interventional cardiologist and has experience of 5 years. And he completed MBBS from Usmania Medical College, Hyderabad in 2009, and general medicine in National Board of Examination 2013, and cardiology from National Board of Examination 2017. Now I would like to welcome you, sir, to talk about what is CVD. Then why? Yes. Good morning, sir. We welcome you for this World Heart Day program, sir. Now I would like to welcome Dr. Lalit Agarwal, sir. He's a consultant interventional cardiologist and he completed his MBBS DNB medicine and DMB cardiology. And he is an interventional cardiologist and has experience of 5 years. He completed MBBS from Usmania Medical College, Hyderabad in 2009 and general medicine from National Board of Examination in 2013 and cardiology from National Board of Examination in 2017. Now I would like to welcome you, sir, to talk about what is CVD. Thank you.
So good morning, everyone. Sorry for the delay. So today I'm going to talk briefly about cardiovascular diseases. The cardiovascular diseases is a big spectrum of problems. So in our practice, CVD basically includes multiple things. It's like your heart diseases, all your acute MIs, chest pains, anginas, it's all CVD, and also brain strokes. So in if anyone of you is working in the MICU or the NICUs, you see people with ischemic strokes or hemorrhagic strokes. So it is also a spectrum of cardiovascular diseases. And the third and the important thing is peripheral vascular diseases. So if you are working with the vascular surgeons, they do peripheral intervention, stenting, thrombectomies. So these are the major spectrum of cardiovascular diseases. So I will just briefly discuss today all these things. Why? Because as we are celebrating the Heart Day tomorrow, so today, tomorrow, yeah. So as we're celebrating the Heart Day, the basic etiology of the diseases is the same in all the three diseases. So if you have a basic understanding of these things, it will also help you to enhance the care of the patient. Today I'm discussing the basic things like what are cardiovascular diseases and the basic etiologies. I don't know from nursing perspective how much it is probably going to help you because you are directly involved in the patient care. So this is a different topic for you. It's an offbeat topic. It is directly not going to help you to deliver the proper patient care. Maybe nursing's perspective will be a different thing. Once you go into management of the cardiovascular diseases, those things will help you much. But this is in general basic guideline of cardiovascular diseases. So meanwhile, if anybody who have any questions or any queries, can we discuss anything? So Annapurna is working in cath lab with us. She is in charge of cath lab. If you have any doubts, you can raise. See, from nursing perspective, it's a different ball game. You have different perspective of things. Anything you would like to ask, or any doubts you would like to ask? Any of the nursing staff? Anything you would like to ask regarding whatever difficulties you have in managing our patients? Like you have cardiac patients. Hmm? See, anything you would like to ask? See, I come for rounds in the morning. Many times sisters are confused with so many things. See, obviously they will have a lot of doubts because they may not be knowing these things. So anything you can discuss now. Annapurna, you don't have any doubts? You are very senior. You are almost the in charge of the cath lab, so you will not have any doubt. Amla, everybody is perfect in providing nursing care. See, you can be free. You can discuss any small doubt or any big doubt. It could be even minutest of the doubts. You can freely discuss everything now. Okay. So other groups, if anybody would like to raise any queries or any questions, they have any difficulties in providing nursing care to the patients, so that will be of useful to for everyone. So anyways, meanwhile the slides are ready. We just have to play them. So today our topic was cardiovascular diseases. So we'll go briefly into the anatomy of the cardiovascular diseases. See, the human circulation has basically two parts: the systemic circulation and the pulmonary circulation. In the pulmonary circulation, the blood which is deoxygenated comes basically to the right side of the heart, right ventricle. From right ventricle, the blood goes into the lungs. In the lungs, what happens is you take a lot of air from the atmosphere. So the hemoglobin which has the carbon dioxide is left over in the lungs, and the oxygen is taken up. So all the oxygen is delivered into the hemoglobin. So the oxygenated blood is again given back to the left side of the heart, which is the left atrium. From there, the blood through the aorta goes into the whole of the systemic circulation. So pulmonary circulation is basically the right side of the heart, lungs, left atrium. Remaining is the systemic circulation then. So in the now the important parts of the heart like include atria, ventricles, aorta, and coronary arteries. So basically, where the problems start, it can start anywhere. It can be either in the aorta, coronary arteries, in the myocardium, anywhere the problems can start. So why we would like to discuss about cardiovascular diseases is that cardiovascular diseases are the leading cause of death worldwide. Earlier, it was thought that in countries like USA and Europe, which are developed countries, they had high cause of cardiovascular death. But now, if you see in India, India is also having a very high percentage of people who die with cardiovascular disease, which is basically acute MIs and acute strokes. The deaths are particularly exceptionally more common in people who are very, very young. People less than 40 or 50 years of age die more commonly because people who live long enough will have good collaterals in the heart. And most of these diseases are probably because of a bad lifestyle, which you can control by yourself. So as I was telling you, the cardiovascular system has two basic circulations, pulmonary and systemic circulations. And the heart has, the blood from the superior and inferior vena cava comes to the right atrium. This is all deoxygenated blood. From right atrium goes to the right ventricle, through the pulmonary artery to the lungs. In the lungs, the blood gets oxygenated, coming back to the left side of the heart and then into the body. So what are the major risk factors for cardiovascular diseases? So I have also put diagrams so that it's easy for you to understand. Smoking is one of the major causes currently. Previously, we used to see only males who were smokers, but now in our practice, we see good number of females who are smokers. Along with smoking, various substance abuse is also there. It can be various substance of abuse like cocaine, marijuana, etc. Now, next is obesity. As I was telling, majority of the heart cardiovascular diseases are because of lifestyle. So obesity is something which can be controlled by us. Diabetes, then high cholesterol levels, hypertension, and atherosclerosis. Apart from these, we also have some other factors like genetic factors. If you have a strong family history of cardiovascular diseases, you're likely to have these problems more commonly. And males are more prone. Actually, this advantage of females is only until they're until 50 years of age, until they're having active menses. Until they have the menstrual cycles, they prepare the hormones estrogens and progesterones, which are made cyclically as the cycle goes on. So all the cholesterol is utilized to make the hormones in the females, and it has a productive effect on the various organs of the body. So until 50 years of age or until they have the menses, females have an advantage over the males in terms of not having these problems. But once you cross the menopausal age group, females are probably more prone or as likely as males to have all these problems. So a female also has to take care of her health more aggressively once they cross the menopause. So now tobacco use has become extremely common. It is more common among the males, uh, especially in the young males. So whatever majority of the acute MIs or CVAs we see in the males is probably contributed to the smoking. I mean, the smoking increases the risk of any kind of CVD by multiple times. It has multiple actions on multiple pathways in the body. It reduces the HDL. It causes platelet aggregation. It causes coronary vasospasm. And not only coronary vasospasm, it causes spasm in multiple arteries of the body. It can be in the upper limbs, in the lower limbs. So you see problems not only in the heart, but even in other vessels of the whole body. They have more commonly having peripheral vascular diseases, or they can even have thromboangiitis obliterans, which is obstruction in the upper limb arteries when which more common in smokers. Then it also predisposes to hypertension because smoking abuse causes release of the hormones like epinephrine and norepinephrine in the blood, and it also causes acute thrombosis. So how does hypertension affect your heart and various organs? So what blood pressure does is, see, normally to understand blood pressure, the effect, like for example, if you start going to a gym, your muscle becomes hypertrophied. Okay. So same thing happens to the heart. Normally BP is say 110 by 80, but if your blood pressure is 750 upon 90, so heart has to pump blood against a higher resistance. In turn, it gets hypertrophied. So also to counteract the effects of this high blood pressure, the various arterioles in the body, they get constricted. They have more of muscle developing in that. So the smaller arteries in various organs also get hypertrophied. So because of this, you can have various organ damage, like your brain can get affected. You can have CVAs, you can have hemorrhagic strokes, you can have ischemic strokes. You can also have coronary artery disease, directly and indirectly. Directly because it also causes stress on the coronary arteries, and secondly, it causes hypertrophy of the myocardium. The myocardium becomes hypertrophied. The existing supply may not be sufficient, so the supply has to be augmented probably. Even if you have minor blocks in the arteries, which is 40-50%, they may become significant for a person who is having hypertensive cardiomyopathy. And it also causes the kidneys. Nephropathy is extremely common among hypertensive people. So it has various effects on various organs, directly as well as indirectly. So coming to cholesterol, we all know that cholesterol is not good. So how do you actually make out, I mean, how does this all happen? This is the cross section of a normal artery, which all of us will have at the birth. The whole process of forming blocks starts very early in our lifestyle, in our life. It can be as early as 5 or 10 years of age. Normally, some blocks are formed to all the people. Whenever there is any shade or stress in the body, in any of the arteries, if there is a small tear in the artery wall anywhere, which is because of various factors like oxidative stress or any other free oxygen radical generation, they attract all the cholesterol in the body. It gets deposited. So now this rate of deposition of cholesterol, it is very much fast in people who have blocks. Normally, some kind of cholesterol is deposited in everyone, but it is also taken back by the HDL cholesterol. LDL cholesterol is the bad cholesterol. It deposits the cholesterol in the arteries of the various organs. HDL takes it back to the liver and is excreted from the liver. So this process of forming or deforming the clots is becoming very fast in people who have developed the blocks. So because of all these factors, it's fast in them. So finally, when they have formed a block, one day they will have an acute MI. The acute MI happens when the surface of the plaque is ruptured. Once it gets ruptured, it will expose the fat inside the block, and it will cause a lot of platelet thrombosis and aggregation. That's how they will develop an acute occlusion of the whole artery. So this is most commonly seen in patients with acute MI. Not necessarily they will have major blocks. Even a minor block of 20% may become 100% block once they have an acute MI. That is, they basically need unstable plaques. Unstable plaque is one which has a very thin wall. So we commonly give statins, rosuvastatin, atorvastatin. They help to stabilize the plaque and they help to prevent a patient from having an acute MI. So you commonly in our practice, all diabetics, hypertensives, we try to give all of them statins as a precautionary measure. So physical inactivity. Nowadays, we see a lot of children and kids, or even people of middle age, they enjoy a lot of indoor activities. I mean, sitting inside the house, watching TV, playing video games, etc. This is not a good thing. We should encourage our children, or even our parents, or even our friends or colleagues, to go for more of physical activities. You know, directly go for walking, but you can play sports and games, whatever games you like, table tennis, badminton, etc. There you may enjoy the game as well as you'll be physically more active. So diabetes increases the rate of atherosclerosis. It increases the risk of all the forms of CVD, which is coronary artery disease, cerebral vascular accident, as well as peripheral vascular disease. It is notorious to cause diffuse disease. Diffuse disease means there are blocks everywhere in the arteries of the heart, which is difficult to treat by stenting or bypass surgery. So increased body weight is also a risk factor. So if you have a body weight more than 30% of your anticipated weight, that is more than 30% of your expected weight, that is has, I mean, you come into the category of obesity. It predisposes to high LDL levels. It also predisposes to high blood pressure levels. It causes more of insulin resistance, predisposes you to even diabetes, and the central obesity is more dangerous. Coming to the body mass index, the body mass index for obesity for the Westerners is at 25, but for Asians we take at 23. So even at lower body mass indexes, we come into the category of obesity, and we are more prone to have heart disease as compared to the Europeans. So other contributing factors that can be probably modified include high triglyceride levels. It is related to basically your intake of fatty food, and intake of even a high carbohydrate diet can predispose to high triglyceride levels, because ultimately even if you take more carbohydrates, which are simple, they get converted and stored in the body as triglycerides. Psychosocial factors, like if you are having a very impulsive behavior, aggressive or hostile behavior, or depression and anxiety, these also increase the stress in the body. Social factors like social isolation and low socioeconomic status. People of low socioeconomic status generally don't understand the importance of doing exercise, of not doing, following healthy lifestyle. So that's how they fall into the habit of, sitting sedentary lifestyle, tobacco abuse, etc. And they are more prone to develop heart diseases. So there are many modifiable risk factors for heart diseases, like which we discussed previously, like smoking, sedentary lifestyle, your blood pressure, diabetes. At least to some extent, you can control the levels of BP and sugars. But there are some factors which you can't modify at all. So some of these include hereditary factors. Suppose you have had a very strong family history of heart disease. Your mother, your parents, your grandparents, if all of them have heart diseases at young ages or aggressive diseases, probably even you are likely to have diseases. So we recommend them to undergo yearly checkups at very young ages. If you have any mild symptoms of any kind of thing, go for the health checks, take medicines, and take advice from a professional, medical professionals. And then age. As the age advances, the risk of heart diseases keeps on pounding day by day. Earlier, we used to see heart disease in Indians, like say 30 years back, we used to see in people who were 70 plus or so. But nowadays, surprisingly, we see people who in their 20s and 30s having major heart diseases. Diabetes and hypertension have become extremely common. Even acute MIs have become extremely common. In our cath lab, at least 50% of our MIs are probably 30 years of age. If you come to our cath lab or anybody involved in managing your intervention cases like angiograms, angioplasties, you can just see what is the age of the patients. Many of them are quite young these days. And then sex, the males are more prone as compared to females because of the hormonal balances. Coming to the origin of your country, if you're an African Americans, you have a high risk of having blood pressure, which is probably a bit more resistant. And in Hispanics have high risk of blood pressure and angina. In Asians, it was initially thought that they have a lower risk of CVD, but probably this concept of late has changed now. Especially in Indian population, you see very aggressive disease at very young ages with multiple blocks. You see many people at the age of 30, 35, 40 going for even bypass surgeries. So 30, 40 years back, it was thought that Indians have a low risk, but now it's not so. Probably the reason is there is a rapid urbanization in India. Rapidly, the lifestyle has changed for the people. People have become more affluent, more affordable now. So they are taking more of junk food, more of unhealthy food, and people are not following healthy lifestyle. So these are the reasons which are causing the problems in Indians at very young ages now. So some of the major forms of cardiovascular diseases to discuss. One thing is hypertension. So hypertension can cause damage to various organs of the body. It could be even heart, kidney, or even your brain, even before it is detected. We sit in the OPD these days. I see good number of people who present with very high blood pressures for the first time in their life, and probably they have had either major MIs or heart diseases, or even CKD or even CVS prior to the presentation, or they may present you directly with a CVA or a CKD or an MI. That would be the presenting thing for a hypertensive patient. Atherosclerosis causing narrowing of the blood vessels. Narrowing in the heart will cause CAD. The brain causes CVA, and in the hands and legs causes peripheral vascular diseases. ACS has various forms. It can be acute MIs, stroke. Stroke is basically paralysis kind of stroke. If there is a sudden reduced supply to the brain, it causes ischemic strokes. Then you have congestive cardiac failure, where the pumping of the heart reduces significantly, and they accumulate a lot of fluid in the lungs and various organs of the body, which causes a lot of breathlessness to them. So, how can you go about helping an acute MI patient victim? This is a very simple form of CPR, which anybody can do. The importance of an acute MI is that the patient may suddenly die because of an acute MI, especially a young person who does not have any collateral supply whatsoever. So if you are able to do CPR anywhere, you will not be in the hospital all the time. So I think in many places, institutions now, people are being taught the process of CPR, how it is performed. So you see anybody who is suddenly fainting or has collapsed, you try to shake the person, try to sprinkle water on his face, try to rub his hands and legs, and try to wake him up. If he doesn't wake up, try to call for help, like calling an ambulance or any medical person nearby. Check for his breathing. If you are not able to look at anything, immediately try to lock both your hands, and with your surface of the palm on the center of the chest, on the lower part of the chest, you try to give compressions. Try to exert the full weight of the body on that, because an effective CPR makes a lot of difference. You try to give 2 cycles of CPR in every single second. So at least you try to give 120 uh, cycles in a minute, and in between you also need to give some breaths. Like for every 20 or 30 seconds, you can take some air in your mouth, open the mouth of the person who is involved, try to deliver a brief breath so that some oxygen goes inside his lungs, and he has a better chance of revival then. So in people who have had an acute MI, it also helps sometimes, when you have a lot of thrombus in one of the arteries, the thrombus sometimes may actually get dislodged by this CPR, because you're mechanically compressing the heart. So indirectly it may help to dislodge the thrombus, and some flow may be established in the coronary arteries. This we see very commonly. Once a CPR was done on someone who had had a cardiac arrest, suddenly he revives with a CPR and he goes on well. And when you take up the patient on a cath lab table for an angiogram, you see a dislodged thrombus which is gone distally and the artery is flowing nicely, or at least even the thrombus is already gone. So this simple form of CPR, uh, I mean, anybody can deliver. You don't require anybody else to deliver this kind of CPR. Any one of you can deliver anywhere on the roadside also. And even if the patient didn't have any MI, suppose he had a VT or VF due to any other cause, this also definitely helps him to establish the circulation. And many times the VT will spontaneously terminate. So detecting and treating the heart diseases. So basically, as I discussed, this is the arterial wall. When they have any damage on the endothelium, the cholesterol gets deposited inside. So when the rate of deposit of cholesterol is very, very fast due to various reasons, the lumen of the artery gets narrowed. Over a period of time, what happens is this may convert into acute MI. If this surface of the block, if it becomes unstable and it has a plaque rupture, it predisposes the lipid inside material. If this is exposed to the platelets in the blood, they will stick to it and it will cause an acute thrombosis. It will occlude the complete lumen within few seconds and the whole supply of the blood is completely stopped. And if this happens in a major proximal artery like LAD or proximal RCA, patient can simply have sudden cardiac arrest. So what you do in an angioplasty is you basically you whatever go through the radial or femoral route, you cross the lesion with the wire first, then you put a balloon. This is the balloon angioplasty. So what you do is you try to uh, expand the lumen of the artery. You compress the plaque against the wall, and then you. This is what used to be done previously in the plain old balloon angioplasty, POBA, what you called previously. So it was seen that POBA does not have very good results in the long term. So stunts came into picture. So stunts will be deployed over this. So once you deploy a stunt, the plaque gets compressed between the stunt and the arterial wall. So you get a bigger ultimate lumen. A blockage which is say 90 or 95% becomes only 5%, 10% block. So the blood flow is increased. And this is to sustain the things in the past. So this is some form of treatment. People who don't have major blocks can be just given medicines, or they have multiple blocks can go for bypass surgery also. So strokes or TIAs, they are of two kinds basically. We have ischemic strokes and hemorrhagic strokes. In ischemic stroke, what happens is the artery is suddenly completely occluded. They can be thrombotic or an embolic stroke. Thrombotic means the thrombus is formed in situ in the artery then and there. Embolic means it's cardioembolic stroke generally. You form a clot elsewhere in the body. For example, you have rheumatic heart disease or you have an AF. So a clot is formed inside the heart in the left atrium, which goes through the aorta, then the carotid artery, and then into the brain. So that is an embolic stroke, which usually has a better prognosis compared to thrombotic stroke. And then what you have is a hemorrhagic stroke. In ischemic stroke, the blood supply is reduced. In hemorrhagic stroke, the blood supply is actually much more. Usually, there is a rupture of a vessel wall in one of the hemispheres of the brain on one of the portions. The blood vessel ruptures acutely, and it depends where the blood is extravasating. If it's a huge hemorrhage, patient may die suddenly. If it's a not huge one, he may come to your hospital with various signs and symptoms like headache, diplopia, or loss of consciousness, or loss of vision, or even blurred vision, or they can be various things depending on what organ is involved. So treatment is different for both the kind of strokes. So this is a diagram for an ischemic stroke. So here, because of so this is the carotid artery going inside the brain. So if there is obstruction to one of the vessels, the whole supply is reduced in that area. And hemorrhagic stroke is one where the vessel becomes weak and it completely ruptures, causing a lot of blood extravasation in the segment of the blood brain. So what are the warning signals for the stroke? See, for heart disease, it's very simple. We have either chest pain, left arm pain, back pain, or jaw pains. But in stroke, it's sometimes difficult. Patient may have sudden weakness or numbness on one part of the body. He may have loss of speech. loss of vision, or explain dizziness. So detecting and treating the strokes, you need to go for a CT brain to look for hemorrhagic stroke or MRI for ischemic stroke. You have options like thrombolysis or mechanical thrombectomy. And patient has an evolved stroke, then you have to go for rehabilitation. So congestive cardiac failure, it develops because of various number of cardiac problems. It can be congenital, acquired, so on and so forth. Number of conditions predisposed to that. It has pulmonary edema is the presenting thing. Patient presents to you with breathlessness. He's unable to sleep in the night. When immediately when he lies down, he has severe coughing and breathlessness. He's able to sit and sleep, like he's or rather sleeping with 3 4 pillows on the back. So what happens is in that way, the blood in the lungs is taken away back to the other organs. So he's able to breathe better. So the management includes multidisciplinary things. First, you have medicines. You give diuretics like your your furosemide, torsemide, either in form of injections or tablets. Your Ditor plus laciractone, all are diuretics. You have fluid restriction, salt restriction, devices you may advise like CRTD, CRTP, or ICDs, then physiotherapy. So what are the signs of heart failure and congestive heart failure? So chest pain during exertion, shortness of breath, lightheadedness, swelling of the legs, hands and feet. Very many people miss this as a symptom of heart failure. Sudden weight gain, sudden fatigue or weakness. So how do you protect against the cardiovascular diseases? The fat content of your food should be probably less than 20 or 30%. Now again, there are a lot of change of concept in these things. Earlier, it was thought that having a less content intake of fats is beneficial, but now many people go for weight loss programs. They go for keto diets, where they take almost zero carbs and they take up to 40-50% of only fats, and rest of it is only proteins. So these things can be a bit variable. And while you are on a keto diet, your cholesterol levels may shoot up drastically. But definitely, you take low saturated fats to increase the dietary fiber intake. So where do you get fiber from? It's basically all your vegetables and fruits. All plant-based diets have high fiber content. You have to stop smoking if you are physical activity involved in sports and games which are outdoor related activities. Any sports or games you like is good. If you have blood pressure or diabetes, monitor them regularly. Have a stress-free lifestyle. Try to relax yourself, enjoy yourself. You see people stressing out unnecessarily because of various reasons. Try to enjoy a relaxed and a comfortable lifestyle. Don't try to always be very competitive. Have a company of good friends who can give you good advices, can spend good time with them, spend good time with your family at weekends, go for holidays. Even these things make a difference. And consumption of omega-3 fatty acids. So basically, again, same thing. Reduction of excess calories, increase the intake of fruits, vegetables, whole grains, nuts, legumes, seafood, reduce the intake of alcohol, and then reduce the intake of refined grains, added sugars, trans fats, sodium, and um, processed meats. So what are the drivers of poor diet quality? Lack of knowledge, lack of availability, price of healthy food, time scarcity, social and cultural norms, marketing and branding, taste and flavor. Coming to the price of healthy food, yes, fruits and vegetables are quite expensive to purchase, but they are very good for your body. So primary prevention for the risk factors includes controlling the blood pressure, lipids, and glucose. Secondary prevention includes diet and lifestyle medications. And then if you are following good things, you can have reduced cardiovascular disease and mortality. So in diet, what you can take, a lot of vitamins, omega-3 fatty acids, UFA, minerals, fibers, polyphenols, and lycopene. How do they help you? They reduce the oxidation, because oxidation is one thing which generates free radicals in the body. Free radicals is the one which damages the endothelium, and where all this problem starts basically. They reduce the blood pressure, They reduce your fasting glucose levels. They reduce your body weight. It decreases the risk of inflammation, decreases the LDL, and decreases the risk of your thrombosis. So also try to maintain a healthy weight, take screening tests and stress management. Don't try to take tobacco, limit fat consumption, alcohol consumption, etc. So this is a very brief introduction on cardiovascular diseases. I try to cover a few basic things only in this, and I would like to invite any questions or any queries from the audience now. So from the other centers, any see while you are taking a keto diet, your cholesterol levels will shoot up very much. It was extremely high. It may go up to 250 and 300 also, but it is a temporary phase. It doesn't have any long-term effects on the heart or the disease. See, ultimately, what benefit you drive out of that is you lose so much of weight. You lose the weight, your insulin resistance comes down, your weight comes down, your diabetes levels come down. So a lot of things come down drastically. So ultimately, it has a positive effect on the body, not a negative effect. Because keto diet is being followed and utilized by many people worldwide over now. And while you are following a keto diet, your cholesterol levels will be extremely high because your body is not utilizing carbohydrates anymore. It's just burning out all the fat which is there in the body for all these years. So once the fat is being utilized, everything will shoot up drastically. But once you again go back to a routine normal diet, it again usually subside. It doesn't usually have a great effect on the body. See, keto diet mein what happens is you stop the intake of carbohydrates, you take predominantly proteins and only fats. So the insulin requirement is not there. See, insulin is required if suppose there is glucose in the blood. Insulin will help the glucose to enter the cell. If there is insulin resistance or diabetes, either the insulin in the body comes down or the insulin is becoming resistant. Suppose you had 5 units of insulin required for raising the glucose. Now you may require 10, 20 or 40 units. So that will ultimately reverse because of keto diet. So you are utilizing all the fats, whatever the lipids is stored in the body is being utilized. So it's all coming out as triglycerides and other things. It definitely will be very high for that period of time. And if you continue to follow keto diet for a long time, you're definitely on the higher side. Nothing to worry about that. It doesn't really harm your body by any means. There is no increased risk of any heart disease, CVA or PVD if you are following a keto diet actually. Actually, it has beneficial effects on all the other things. Any queries? Any questions? So shall we close the session? I mean, this current talk.
Anybody is having any question regarding CVD? Sir is here, you can ask him. He will clarify your doubt. Anyone from podium? Thank you so much, sir, for your informative matter regarding CVD. So as a part of nursing care, we'll provide health education for the patients to prevent cardiovascular diseases as regarding stress or reducing alcohol and smoking and diet exercise regarding this, all those things to prevent cardiovascular diseases. Once again, thank you so much, sir. Now I would like to request Nitin Anurup, sir. Now he will come and speak about pre-CAT assessment and risk factors. He is our senior interventional cardiologist, and he finished his MBBS, MD General Medicine, and DM Cardiology. And he is specialized in cardiac care and coronary intervention. He has performed numerous angiograms and interventional procedures, both coronary and non-coronary. He also held expertise in non-invasive cardiology, including echo, trans-esophageal echo, and pediatric echo, and dopamine stress echo. He stood first. He stood state first in MD and DM entrance test, and he received Young Scholar Award Cardiology at national level in 2002. So we would like to welcome sir to speak about pre-CAT assessment.
Good morning, everybody. Yeah. So we are going to discuss about cardiac catheterization and then how to assess before sending a patient for a cardiac catheterization, and then how to identify who are at high risk compared to the routine general population, and then after catheterization, what are the uh, precautions and then management protocols you should follow. So today we are going to cover about just introduction about the cardiac catheterization procedure, and then what are the procedures we will do and indications, and then what are the complications expected, and then how to assess them even before doing the procedure, and then how to deal with those complications. So most of the cath lab staff will be aware of these things, but I think it's a general topic for all nursing staff. Everybody should know this. So cardiac catheterization means just it's an invasive method to investigate that is cardiovascular system. It's not only heart, brain, kidney, and anything. So it's not only territory of cardiologists, even our intervention radiologists, as well as our neuro intervention radiologists. Everybody will do catheterization just to gain access into the heart and other circulatory system, that is called cardiac catheterization. So here we'll introduce a small tube either through the artery or vein to access into the cardiovascular system. So if you introduce into the vein, then finally it goes through right atrium and right ventricle. If you can access right side of the heart, and then if you introduce any catheter into the artery, then you can enter the left system of the heart, that is left ventricle, and then left and aorta, and then all the branches of aorta, and then major arteries. So this is right heart catheterization or left heart catheterization, we say. So he is the first man, Werner Frausmann. So he was the father of this cardiac catheterization. So in 1929, before 1929, there was no cardiac catheterization, and then nobody knows how to access the heart chambers and then other arteries. So then only William Harvey, he has given concept of the circulatory system. But then he himself, he administered some local anesthesia to the left arm, and then through the antecubital vein, a small urinary catheter. He passed through the antecubital vein into the heart, and then he himself took an X-ray. So that is, in spite of his senior authorities suggesting against it and then warning against it, he did, and for which he was almost suspended from his profession. But finally, he got Nobel Prize. That is, it was 1929. But for 30 years, no cardiac catheterization was done. In fact, afterwards, he practiced as a urologist. But then 1950s, then after reading his articles, some other fellows started working upon this one, and then from 1956 onwards, so we are doing this cardiac catheterization, for which he received Nobel Prize in 1956. So this is the cardiac catheterization. You can see either will access the arteries from the one of the limb, either upper limb or lower limb. So usually for most of the 95% of cardiac catheterizations are because of cardiac issues, either coronary angiogram or coronary angioplasty. Less than 5% are for other organs like renal angio and then carotid angio and other things. So usually we gain access at either femoral artery and then radial artery and sometimes even brachial artery, and then we'll pass a small catheter, and then we'll reach the our target vessel or target chamber. So you can see here. So this is here. So then the indications for cardiac catheterizations are either for diagnostic purpose or as therapeutic purpose. The diagnostic purpose, that is called angiogram, that is study of a vessel. It can be done for either coronary, that is called coronary angiogram, and then carotid arteries, carotid angiogram, renal angiogram, and then sometimes even for oncology people, they will be doing splenic and then celiac axis, depending upon the tumor. Even we can do this one, even for a postpartum hemorrhage, we can do for uterus also. So sometimes some people we have postpartum hemorrhage atonic after delivery, There was no contractions at all, heavy bleeding. Sometimes even we'll access this uterine arteries, and then we'll embolize to prevent that that is postpartum hemorrhage. And we did in sunshine for 2-3 people. Just we coil embolize those uterine arteries to save the patient. And then we can do so many. Any artery can be accessed by this cardiac catheterization, and then we can diagnose the what is the problem, and then we can treat. If there is a leak, then we can close it by either coil or putting a stent, or if there is a narrowing, then we can balloon dilatation, and then we can put a stent. So we can seal it as well as open any vessel by doing this current cardiac catheterization. Even we can use venous access, especially for pacemaker. So all the pacemakers we introduce to the subclavian or axillary vein, and then we'll put a pacing lead in the right atrium or right ventricle, and then in CRT we'll put a even some of the coronary veins also. And apart from this studying the vessels, we will do for other purpose also, especially for pediatric age group. So many patients will have a atrial septal defect, and then ventricular septal defect, and then patent ductus arteriosus, or tetralogy of Fallot, any cyanotic or acyanotic congenital heart disease. Many times we'll do cardiac catheterization to assess whether they can be operable or not. Many patients with left to right shunt lesions like ASD, VSD, PDA, if they present in teens, so usually these people will be operated in the childhood, so first decade itself many of the times. But if they present in teens and then 20s, the questionability of the repair, whether still they are repairable or not, that is a question. So because if any patient which have left to right shunt lesion over a period of time, so because pulmonary arteries are exposed to lot of blood flow, so all left to right shunt lesions, the pulmonary blood flow will be more. So because usually right-sided chambers receiving normal blood flow from SVC, IVC, as well as because of the shunt at either atrial septal defect or ventricular septal defect or anywhere, so even from left chambers are also shunting into right chambers. Finally, that is going into pulmonary artery. So pulmonary artery are exposed to lot of pressure over a period of time, then the flow will be reversed. So because of the increased pulmonary vascular resistance, the flow will become right to left. So till now, that is deoxygenated blood, oxygenated blood is mixing with the deoxygenated blood, so no cyanosis. But once the shunt reverses, so then they will become cyanosed. At that time, we cannot close. So because if you close that defect, then RV will go into failure. So because there is a severe pulmonary arterial hypertension, so then it will give away. So at that time, it's irreversible. So for that reason also, we will do cardiac catheterization. One thing is to take the pressures in each chamber, like right atrium, right ventricle, pulmonary artery, and even left atrium, left ventricle, all the intracardiac chambers, and as well as great vessels, we'll take pressures. And then we'll take samples for our ABG samples to see for the saturation. Depending upon that, we'll calculate cardiac output. What is the cardiac output on left side? What is the cardiac output on right side? That is pulmonary blood flow, aortic blood flow. Depending upon that, we'll calculate pulmonary vascular resistance. Because of these values, we can say whether the patient is operable or not. And then even we'll do ventriculogram. Just we'll do angio of the cardiac chambers to see for the anatomy. So some complex congenital heart diseases, it's very difficult to identify. So sometimes say transposition of great arteries, in that case, sometimes right-sided chambers will be on left, left-sided chambers will be on right. So in those cases, how to identify, so which is right ventricle? Sometimes the right-sided chamber may be morphologically left ventricle. Though it's sitting on the right side, probably it is a left ventricle. So to know the correct idea of the cardiac chambers, we'll introduce a pictorial, and then we'll give injection, and then we'll see. So these are the indications, diagnostic indications. Apart from routine coronary angiogram, we'll do these things. Even nowadays, we are doing ventricular assist device for heart failure. So all advanced heart failure patients, if they want to go for a transplant or LVAD, The cardiac catheterization is compulsory to see whether the patient will tolerate the procedure or not, or they are the right candidates or not. Then more therapeutic indications for cardiac catheterizations, that is angioplasty, that is repairing the blood vessel, that is by putting a stent. Coronary angioplasty or carotid angioplasty, renal angioplasty, and then pacemaker implantation. This is one of the therapeutic indications. And then our electrophysiologists will do radio frequency ablation. There also they will use femoral approach to go into the right atrium and then AV node. And then balloon valvuloplasty, like percutaneous mitral balloon valvuloplasty or iotoplasty or TAVR. So all these are all the indications to do cardiac catheterization. And even to seal the leakages. So many patients, suppose uh, pulmonary hemorrhage, patient present with post-tuberculosis, bronchiectasis, patient will present with hemoptysis. Then also we'll do bronchial artery embolization. And then, as I said, uterine artery embolizations for postpartum hemorrhage, as well as fibroids also. So uterine fibroid, one of the indication, just we can identify the the artery which is supplying the fibroid, and then we can coil close so that the fibroid will regress. So there are very few rare indications, but we do a lot of embolization procedures, especially some cases, any iatrogenic injury to the vessel, like while doing renal biopsy, sometimes renal artery may be injured. There we'll go and then we'll do coil embolization. So these are all the interventional procedures we do, uh, and for which the cardiac catheterization is important. So this is the process. Usually we'll take the access at one, we'll choose the blood vessel through which we have to gain the access. Most commonly it's radial, but for some scenarios femoral. First we'll puncture with a needle, and then we'll pass a small guide wire, and then over which we'll pass the sheath with a dilator, and then through that sheath we send all the hardware which is used for these procedures. So this is a routine coronary angiography. You can see. First, we'll introduce a sheath, and then here the diagram shows it's a femoral approach. Then we'll pass a pre-shaped catheter. In cath lab, we can see there are pre-shaped catheters. Some catheter will be used for right coronary artery, some catheters for left coronary artery, and some can be used for both. They are called multi-purpose, a tiger catheter. And then we select the catheter depending upon the patient's height and weight, and then we'll pass the catheter, and then we'll manipulate there so that it sits into the coronary ostium, and then we inject a contrast. Without contrast, the blood vessels will not be visible. And then once you give a contrast, then if you do fluoroscopy and if you pass X-ray, then that will be seen as a black color this thing. And then with that, you can assess the coronary artery anatomy. So whether they are normal or is there any narrowing, and if there is a narrowing, even we can quantify what is the severity of the narrowing. So this is coronary angiogram. And then what are the complications we expect? Once you enter the vessel, once you disturb the vessel, there are chances, most of the complications are because of the vascular access site complications. So most commonly, you'll have a skin rash because of that is latex allergy or something, and then bleeding complications, and then there will be swelling of the vascular access site. And then second thing is we are giving a contrast agent which contains iodine molecule. So many patients will be having allergy to the contrast. Most are benign. Just the patient will have some chills and then rash at the access site, and then patient may have accelerated hypertension, and the worst complication is contrast-induced nephropathy. So this contrast, while passing through the kidneys, it may damage the kidney nephrons, and that leads to the contrast-induced nephropathy. Many times it's going to be detrimental and it's going to be permanent. And then other complication is hypotension. So once you do any cardiac catheterization procedures, hypotension are because of many things. The most common thing Once the patient complains hypotension, we need to check his access site. So one of the easily treatable and then most common complication is because of hematoma. Especially it is more common with femoral. Radial is very, very rare, but once groin puncture is done, you have to see so many times, then will be invisible hematoma in the thigh planes that can cause hypotension. The second thing is heart failure. You have to check for the 2D echo report. If the patient is having severe dysfunction before, then probably it's because of contrast can cause myocardial depression. During the contrast injection, it for some time, the already failed heart, it may go into myocardial depression that can cause heart failure. Here the treatment is different. Here we have to give diuretic. If it's because of bleeding, we have to substitute volume. And then if it is because of heart failure, we have to give diuretic. And then sometimes it may be because of the procedure related. Many times coronary angiogram and angioplasty, especially coronary angioplasty, sometimes the coronary artery may be perforated after stenting and while because of either stent or balloon or because of wire induced perforation that can cause slowly pericardial tamponade, that is pericardial effusion, that can also cause hypertension. So all these things are the possible diagnosis. And then one more thing is vasovagal episode. So that we will discuss again. And then patient may complain breathing difficulty because of the heart failure. And even after angioplasty, some patient may develop arrhythmia. So those you have to take, that's the reason why you have to take ECG and then regularly monitor the vitals. And then rarely infection. Nowadays, because of the sterile precautions we take, infection is very, very rare, but it's one of the complication noticed after cardiac catheterization. So then if you want to, you know that these are the complications expected, and then as a treating nurse, then how to assess for these risk factors, and then how to identify who is at high risk compared to the the other person. One thing is age. As the age advances, one thing, the blood vessels will become stiffer and stiffer. There is more arteriosclerosis, that is thickening of the arteries, as well as the calcium deposition. That is the reason why. So then usually after inserting any catheter and those things, and after removing the sheath, within few minutes, then whatever the puncture site or hole is there, that will be clotted with thrombus formation will be there. And then even the vessel also, because of elasticity, is collapsed. So then after sheath removal, usually there won't be any bleeding. That is because of two mechanisms. One thing is elasticity of the heart, elasticity of artery. So then it will retract. And second thing is there is a thrombus formation. So but in with age, the arteries will become stiffer. So then there won't be elasticity. So then the hole, whatever the hole is there, that will persist. That is the reason why for these people we have to apply manual compression for more time. And then usually these people will have hypertension as well. So for untreated hypertension, so then the vessel is it's exposed to more blood pressure, the high chance of bleeding. So age is one of the risk factors for the bleeding, as well as these patients will have diabetes as well as CKD. So then all the complications with the procedures are more with age. So once the patient is more than 70 years, by means that he is very high risk for these procedures. He will have some complications. You have to be very careful. Second thing is gender. So though CAD is more common in males, and then once female develops CAD, with or without treatment, the mortality is more in females compared to the male. Any untreated MI, anything, the females will fare bad compared to the males. All the procedure complications are more in females compared to males. And then you have to take history and what are the presenting complaints for which patient was admitted and for which the procedure was indicated. If the patient is having ongoing chest pain and ongoing breathing difficulty, and then the patient carries high risk compared to the elective and then very much stable patient. And then you have to take history of hypertension, uncontrolled hypertension, that is one of the risk factor. All the complications will be increased. And then second thing is some medication adjustments are required, especially if you have to see for AC inhibitors like enalapril and ramipril, and then ARB, angiotensin receptor blockers. They are telmisartan, olmesartan, losartan, and those. So ideally, we need to stop this medication 48 hours before any angiogram and angioplasty. So because if you continue to use these medicines, they have some nephrotoxicity. Whenever there is some hemodynamic instability like hypotension or hypertension, then these things may predispose to contrast-induced nephropathy. So usually we'll try to stop at least on the day these ACE inhibitors and ARBs. And second thing is, if the patient is having beta blockers, just check what is the pulse rate. These beta blockers will cause bradycardia. So sometimes even during procedure also patient will have some bradycardia. So then these two things we have to keep in mind. So hypertension, ACE inhibitors, if ARBs are there, just hold it on that day. But you have to give other antihypertensives as a routine. Don't stop even though patient is on fasting or nil by mouth. Please continue antihypertensives. And then if the patient is receiving ACE inhibitor and ARB, just you can inform the treating doctor saying that can we give other medicines like calcium channel blockers, amlodipine is supposed to be very, very safe. So that those things you can give. And diuretics. So many of the patients will be on diuretics, but usually unless the patient is having congestive heart failure, we'll hold the diuretics. So because to prevent any renal injury because of contrast, in fact, patient has to be hydrated. So these diuretics will cause dehydration and it may cause acute kidney injury. For that day, you can hold the diuretics. But if the patient is having heart failure, then we'll continue. Regarding diabetes. So diabetes is one of the most important risk factor deciding whether the patient will have some contrast-related kidney injury or not. And then any hyperglycemia, uncontrolled diabetes is one of the predisposing factors. So because that increased glucose levels can cause relative uh, hypovolemia. And then check HbA1c levels, and metformin should be stopped at least 24 hours before any cath procedure because metformin causes lactic acidosis. So if the patient develops contrast-induced nephropathy or kidney injury, so then patient will do bad. So because kidney kidney failure causes lactic acidosis, and in that situation, metformin worsens the situation. That's the reason why usually we'll stop metformin. And then if the patient is admitted one day before, long-acting insulin like Lantus or Glargine, if they are there, because they'll act for 24 hours. So the after cath procedure, many usually we'll restart feeds after few hours, especially if there is PCI is done, that is like angioplasty. After sheath removal only, we'll allow orally. So, but till that time, patient may develop hypoglycemia. That is the reason why if the patient is having Glargine or Lantus, that is nighttime OD insulin, better it should be stopped one day before. And if the patient is taking short acting, like Actrapid, and then at least a morning dose should be given half. Rather than whatever the prescribed dose, you can straight away you can reduce by half. And then oral hypoglycemics like sulfonylureas, glimepiride, gliclazide, and those things should be held on the morning of the procedure. So once the procedure is done, anyway we can reinitiate with a short-acting insulin, and then next day we can restart all the drugs. Then you have to inquire about smoking history and then any COPD or bronchial asthma before. So because this is going to have impact if if minimal contrast-induced myocardial depression, then patient will develop breathing difficulty and saturations will go down. And these patients may require oxygen support during procedure. Even some people may require NIV support. So if the patient is having known history of COPD or is a smoker, better to get it done chest X-ray. I don't know whether it is covered in our routine cath profile or not, but if it is not, then get a chest X-ray done and then document the saturation. And then in the history of CKD, we have to inquire about the reports So previously any procedure is done or not, and then any creatinine is elevated or not, and if any history of CKD in the past, even though creatinine is within normal limits now, any history of AKI in the past, then serum creatinine is not a reliable test to indicate whether patient is having CKD or not. So because the EGFR is better, till the EGFR comes to 60, our total, our kidney function, put two kidneys put together, until it reduces by 50% overall, creatinine will be normal. So normal creatinine doesn't rule out the existing uh, kidney involvement. So in these cases, EGFR is better. Any EGFR below 60 is one of the risk factor for contrast-induced nephropathy. And in these cases, it's better to do a CEG and then ultrasound abdomen. And then these patients require sufficient hydration. We have to ask about drug allergies. So mainly, if a patient underwent any CT angiogram or contrast exposure before, if the patient is having any allergy to the contrast, still we can do, but usually we'll give it some pre-medication. So we can administer Avil and hydrocortisone on the table, and then still we can do, and then we'll try to do with a non-ionic contrast media like VC-pack rather than routine Omnipack. And you have to assess for the bleeding risk. All the patients who are undergoing for angioplasty, they are going to be on antiplatelet, at least dual antiplatelets drugs, minimum 6 months, and in ideal world, it's a 1 year. So till that time, they have to be on medicine. Once you have placed angioplasty, there is stent, and you can't stop those medicines because that causes more risk of stent thrombus and those things. So even before doing procedure, you have to assess what risk he is at. Like any upper GI bleed or lower GI bleed in the past. That means with antiplatelets, it may trigger and it may recur again. In these cases, usually we'll take gastroenterologist opinion, and then after optimization only, we can do if it is elective PCI. If the primary PCI, that is different. And then any IC bleed. This is also we need to again inquire. And then some patients will be on oral anticoagulant drugs, especially if the patient already had DVT or AF, the patients will be on anticoagulant. Or patient underwent any mitral valve repair or valve replacement surgery. So in these cases, check PT-INR, and then ideally, if the patient is having acetrom or warfarin, before the procedure, especially for femoral artery, radial artery, we are not worried, so because it is easy to compress, so we can prevent the bleeding by manual compression. But in femoral artery, it's very deep-seated, so it's a very difficult to apply manual compression if it is bleeding. So INR should be less than 1.8 on the day of the procedure. Then only we can do. And with the if suppose patient is taking other anticoagulants like dabigatran, rivaroxaban, apixaban, these things should be stopped at least 48 hours before, 24 to 48 hours before the procedure for femoral procedure. And even for all neurological, even neurological procedures also, we have to stop these things. For radial art procedures, because now 90% of the procedures are radial artery. For radial artery procedures, usually these things doesn't matter. So then we have to assess the patient situation. Nutritional assessment is important. If malnourished, BMI of less than 18, you have to calculate the BMI. So if BMI is below 18, they will have a lot of side effects and a lot of complications. At the other extreme, if BMI is more than 30. So ideally, normal BMI is 18 to 25. So 25 to 30 is called overweight, more than 30 is obesity. So you have to take the height and weight, and then if below 18 BMI and then BMI of more than 30, they will have a lot of complications. And then hydration status, we need to see. If the patient is dehydrated, we have to administer IV fluids. And then you have to check all the arterial pulses if possible. If suppose one of the arterial pulse is missing, that indicates that it's a peripheral arterial disease. That means, so other arterial bed is also involved. More the number of arterial beds are involved, more the risk of procedure. Like you are doing an angioplasty, that means coronary arteries are involved. In addition to that, if peripheral artery is also affected because there is no pulse in the lower limb, that indicates that second arterial bed is also involved. So that is the risk is a double. And then you have to check blood pressure and then saturation. Investigations routinely we will do CBP and a special focus on hemoglobin. So PCV less than 39 for male and PCV pack hematocrit, and then PCV of less than 36 for female, one of the risk factor, and then the chance risk is more. And the renal function test we need to do, and ideally even EGFR also you need to do, and then CEG, ECG, and 2D echo. Just to check once regarding EF. So EF is normal versus a low EF. There is a lot of difference. The patient, once EF is low means that the patient is high risk, and then X-ray and viral screenings are important. And apart from these, cardiac enzymes. So many times, so we advise cardiac enzymes, TROP-T and CPKMB. If TROP-T is elevated, the mortality will be more with the procedure. And then PT-APTT, not for all, but for some people, if the patient is having altered liver function as well as patient is taking oral anticoagulants, these things have to be done, and then lipid profile. Then how to prepare the patient before any angiogram? Keep NBM, but nowadays it's not absolute mandatory. So for diagnostic purposes, usually we'll allow just 2 hours of fasting. But most of the interventions, at least patient should be NBM for clear liquids for 2 hours and then for solids for 6 hours. So this is mandatory. Why this thing? So because one thing, even though patient is having low risk, sometimes contrast may cause issues. The contrast reaction causes vomiting, and then vomiting during procedure. So sometimes they may develop aspiration. And the second thing is any complication like heart failure, then patient may require intubation. And during intubation also they'll develop aspiration. To prevent these aspiration episodes, we need to keep NBM. And then patient has to be counseled regarding the procedure. And then access site to be prepared, groin and radials. And then consent is a must. And then pre-medication. Continue antihypertensives except ACE inhibitors and ARBs. And then patient should be hydrated, and then antiplatelet loading should be given. Most of the times for angioplasty, will administer loading dosages. If the patient is already on DAPT, dual antiplatelet drugs, suppose sometimes we do staged PTCA. For second PTCA, usually we may not give loading dose, but in ideal world scenario, usually we'll give loading dosages. We should know about the loading dose dosages. Ecosprin 325 mg, usually it has to be given a chewable tablet. Along with that, either of these three, clopidogrel sometimes we'll give 300 mg loading or sometimes 600 mg. So if you give 600 mg, its effect will start within 30 minutes. And if you give 300 mg, it will take 2 hours. That is the reason why for primary angioplasty, we'll give 600 mg. And for elective angioplasty, who is taking already clopidogrel in ward even one day before, usually we'll give 300 mg. And then ticagrelor 180 mg. The tablet comes in 90 mg, so 2 tablets should be given at the same time. And then prasugrel, it is a 10 mg tablet is available. We have to load with 6 tablets, so 60 mg. So these are the loading doses we have to check before shifting to cath lab whether the loading doses given or not. So because after shifting to cath lab, just we will be in a hurry to start with the procedure, and then to come into effect these medicines, it will take 15 minutes to 30 minutes for ticagrelor and prasugrel, and then for clopidogrel sometimes 2 hours. If sufficient loading was not given, in spite of having a good result with angioplasty, still the patient may develop stent thrombosis. So this is important. And then after procedure, once shifted to ICCU or ward, then you have to check neurological status. Especially this is important for carotid angioplasty. So carotid angioplasty or sometimes PBMV also, the patient may develop embolic stroke. So small emboli may go into the cerebral circulation, and then patient may develop some CVA. Sometimes it may not be dense hemiplegia, but some subtle, like some people will have only aphasia, some speech disturbance. They will find some difficulty in finding words. And then some people will be little agitated and then irritable. So these things you have to look for, but this is very less common with our routine cardiac angioplasties. And then you have to continuously monitor the vitals, and then temperature should be checked. Many people, because of contrast, will have some transient elevation of temperature, and then they'll settle down afterwards. And patient should be done, the ECG should be done after the procedure to check for any fresh changes. Then we have to check the puncture site. These are things we are doing routinely, but I think we are lacking here. After doing especially femoral procedure, you have to assess the puncture site 30 minutely for 4 hours, every half an hour. And then for hourly till patient is ambulated. So after sheath removal and until ambulation time. And reassess site after first ambulation. And then minimum of 4 hours prior to discharge. So before sending patient to the home, again we have to check at least 4 hours before the discharge. So these are the timing intervals where you used to check the puncture site. And then he has to be on bed rest. If especially for a diagnostic angiogram, femoral, 4 hours, and then for a interventional procedure, 6 hours, he should be absolutely on bed. But he can move side by side, especially even though femoral is done. So then you can limit the movement at the hip region, or thigh region, but otherwise he can move from side to side so that patient will feel comfortable. So many times we strictly say that don't move at all, and then patient will complain a lot of back pain and those things. And then strict fluid balance, and then especially urine output. The first 48 hours urine output is more important. You have to check for urine output. Otherwise, if he's not producing sufficient urine, we ask them to take more and more oral fluids. But all the patients, whoever we are doing femoral, usually they are little hesitant to take fluids because there is an issue with passing urination. But you have to motivate them, because that is the only way we can prevent contrast-induced nephropathy. And then bleeding, we have to check pressure dressing for any oozing or bleeding from the puncture site. And if there is any bleeding, you have to mark it, and then you have to assess whether it's increasing or not. So if it is increasing, then it definitely requires attention. If it is not increasing much, usually it will subside. And especially after coughing and vomiting, if patient had multiple vomiting and then he is persistently coughing, that may dislodge whatever the thrombus formed at the venous puncture site. And then at any time, patient may develop hematoma or pseudoaneurysm. So if patient is having these complaints, repeatedly we have to check after the episode. So this is the hematoma. Usually hand hematoma, we are not worried. It's a very, very rare, and then usually it won't cause much issue. Usually only some pressure application and then limb elevation, that will be sufficient. And then, but we have to control the blood pressure. And if there is any blood thinness like heparin and those things, we have to stop. But the more we are worried about is regarding femoral. So because femoral hematoma, usually we underestimate. So because of thigh being a very huge tissue, and then in between muscle planes, there is a lot of hematoma will be there. And then if you only examine from superficially, usually will underestimate. We have to palpate it. So then by palpation, we can assess what is the size of hematoma. So if there is a hematoma, first thing is we have to apply manual compression and stop any heparin infusion or Clexane infusion is there, Clexane injection is there, and then assess for any volume depletion. If there is any hypotension, and then even you have to repeat hemoglobin. So if it is more than 2 grams hemoglobin drop, then that is a major bleeding. Then we have to address, we have to fluid replace, and then we have to stop this hematoma. And then even you can auscultate. So there are two things, hematoma versus pseudoaneurysm. Hematoma means there is a blood accumulation in the soft tissues, but there is no communication from that bleeding to the puncture site. That whatever the hole we created, that is sealed, but some amount of blood seepaged, and then it formed hematoma. And then pseudoaneurysm means still there is a communication. So some blood is coming in and out of that puncture site into that is hematoma. That is called pseudoaneurysm. So if you auscultate there, you can listen a murmur, a sound if there is a pseudoaneurysm, just like a pulse. You can hear that pseudoaneurysm. If there is pseudoaneurysm, it requires immediate attention. So because we need to seal that hole, otherwise sometimes suddenly it may rupture and that causes calamity. So this is pseudoaneurysm. So here you can have, there is a puncture site and then there is a hematoma and there is a still, there is a to and fro communication between the hematoma as well as this. So you can see here, there is blood, there is going away is blue and coming towards is red. It's just a swelling in the pseudoaneurysm cavity. So this site, usually this happens if the puncture is low. So femoral puncture, if you do on lower side, so usually we will do here. That is a common femoral artery. But if you do a femoral puncture at superficial femoral artery on lower side, usually superficial femoral artery size will be less compared to the common femoral artery. And then usually we can't apply much pressure. Usually the ideal site of the puncture should be just above the, that is the femoral head. Okay, so that we can apply the pressure, we can compress the artery between our skin and then a bone, that is the head of the femur. But if you do lower, you can't apply much pressure, so it won't be sealed off and then it continues to bleed. So if you lower puncture, the more chance of pseudoaneurysm. But here the treatment should be, we have to compress its neck. Usually we'll do ultrasound, we'll identify the neck and the neck will apply the pressure. So if you apply manual compression, many times that will be sealed off. If that is not there, so then we have to put a covered stent across that hole. So then while applying a manual compression, especially whenever you see some hematoma or bleeding from the puncture access site, you will call some cath lab technician. But before he comes, what should we do? You have to apply manual pressure, but you have to be careful. You should apply at least 2 centimeter or 1 inch above that puncture site, not at puncture site, because usually we'll take angled puncture. So usually the superficial, this is the sheath site and this is where we are puncturing the vessel. So there is almost 2 centimeter gap between actual puncture site, which is visible, and then the vessel puncture site. That is the reason why at least 2 centimeters above, you have to apply pressure. If you apply pressure here, it won't be effective. One of the other complication is retroperitoneal bleeding. Sometimes if you take little higher puncture, like above inguinal ligament, so then the whatever the bleeding is not in thigh, is in abdomen. So usually it's a retroperitoneal. So retroperitoneal space, you can see. So usually this is the inguinal ligament. If you puncture above, so then you can't apply pressure. So because usually we will be applying pressure on the femoral head, and then it leaks into the retroperitoneal space, that is back. And then these patients will have a lot of hypotension and patient will present with shock. And but you will be seeing puncture site, no hematoma, and then ECG will be normal, 2D echo will be normal, and then there is no bradycardia. Echo wise, no, there is no pericardial effusion. Everything is fine, but the patient is pressures are dropping. And then if you see hemoglobin, there is a drastic drop in the blood pressure. So here, usually the patient will complain some flank back pain or flank pain, and then sometimes even skin discoloration will be there in this inguinal region. So then we have to see, we have to do CT angiogram for the quantification. And then once CT angiogram is quantified, then we have to replace, stop the anticoagulants and then give blood. And then usually we'll do sometimes because of the tamponade effect. Because once retroperitoneal space is completely filled and then because of outside pressure, sometimes it may stop by itself. But if it is not stopping, usually we will do again do angiogram. We'll try to identify where it's leaking, and then we'll do either coil or we can put covered stent. So this is one of the worst complication with a higher puncture. So then who are at high bleeding risk? So these patients, instead of taking a proper puncture, if it's a too low, the patient may develop hematoma and pseudoaneurysm. Puncture is too high, retroperitoneal bleeding. But even in spite of taking all precautions, these people will carry very high risk of bleeding. One thing is more than 75 years because of the stiff arteries, it's difficult to compress. And then renal arterial disease, any hepatic dysfunction, it will cause bleeding tendency, active carcinoma, anemia, and then low platelet count, previous history of stroke, or that means any other peripheral arterial disease, and bleeding manifestations, and then patient previously taking any painkillers and then oral anticoagulants. These patients will have more bleeding chances. Apart from that, even procedure also, if the body surface area is too high or too low, very short statured people, they will have high bleeding chance. And then sheet size also. If you put a 5 French sheet, less bleeding chance, we are creating a small hole. If you are putting a bigger sheet, there's chance of bleeding are more. That is the reason why if you see impella, if you use more rota ablation and those things, the procedure complication will be more. Usually for diagnostic coronary angiogram, we'll use only 5 French. So where usually the bleeding chance will be very less. Usually this is the femoral, when to remove the femoral sheath, that is the protocol. Usually this is for cath lab technician, but from the time of femoral sheath, when patient can be allowed to ambulate. Many patients will complain that the moment they remove the sheath, they want to stand and then they want to pass urine and then they want early mobilization. So then usually we will be using 5 French for the diagnostic, where 2 hours should be fine after removal. And many that interventions, we use either 6 French or 7 French, minimum 3 to 4 hours after the femoral sheath, then you can have to, they can be mobilized. So then how to apply manual compression? As I told, so then palpate the pulse and then at least 2 centimeter above the this one, the actual puncture site, we have to apply compression. And then if the arterial sheath and femoral sheath both are there, it's better to remove arterial sheath first, then remove femoral sheath. Because many times, once you remove arterial sheath, either there may be bleeding, second times patient will go into vasovagal episode. So I think you encountered vasovagal episodes many times if you're dealt with this patient. So because of the neuro stimulatory response, the patient will have sudden hypotension. If that is there, so with the femoral that sheath, we can give fluids. It gives some time to resuscitate. And then while removing sheath, don't milk it. So sometimes it may remove the whatever the clot formed at the puncture hole. Usually we have to apply the pressure for 20 minutes before removing the sheath. Most of them are not related to cath lab, I think, but usually 20 minutes pressure application, 5 minutes full application until the bleeding stops. 5 minutes, just a 3/4 application of the same force which applied. 5 minutes, half of the pressure, whatever you applied. And the next 25%, and then you have to remove that manual compression. So then only that is correct. Otherwise, if you won't wait for time, instead of applying manual compression for 20 minutes, if you apply only for 10 minutes, sometimes it may not bleed immediately, but afterwards it may bleed. And this is very rare. Usually we won't expect these thrombotic complications, but very rarely, sometimes we may inject some thrombus through the sheath and patient may develop, that is action pulses. If it is artery, if it is a vein, patient may have DVT. But rather than this one, many times, sometimes we may injure the vessel wall and that can cause some ischemia. That is the reason why always we have to check for the distal pulse. So whatever the limb we did, we have to check for the distal pulses. If there is no pulse, I think we need to intervene. So this is vasovagal reaction. This is very, very common during sheath removal and with femoral sheath. So because of the pain causes activation of the parasympathetic system that causes hypotension. So patient usually have typical symptoms. He will become pale, profuse sweating, and then he'll yawning, repeated yawning, and then sphincters will be released. So he wants to defecate and then he wants to pass urine. These are the typical complaint because of the parasympathetic or vagal stimulation. So the usually patient will be having bradycardia also. So it may have three presentations. It may classical presentation is patient will have hypotension as well as bradycardia. If that is there, this is the only condition. All other hypotension, if it is because of bleeding, heart failure, tamponade, whatever it may be, there will be tachycardia. So as a compensation, if the patient is having hypotension with bradycardia, that is definite vasovagal. So then the treatment will be completely different. He won't improve with narrate. But sometimes patient may have only hypotension with a normal heart rate, or sometimes patient may have only bradycardia with normal blood pressure. But only thing is usually there won't be tachycardia. So we have to identify these patients. The treatment will be simple. Then leg and elevation, that is Trendelenburg position. And then you have to give IV fluids. This is because of severe vasodilatation. Even if you give NORAD, vasopressin, he won't improve at all. And then give atropine. So you by these things, usually the patient will improve within 10-15 minutes. Sometimes patient may have multiple episodes also. So usually once sheath is removed, the vasovagal episodes will come down. Then contrast-induced nephropathy. This is the one thing. The definition wise, from the baseline, more than 25% raise in creatinine or absolute value of 0.5 mg per deciliter increase. If that is there after 48 hours. So usually contrast-induced nephropathy won't develop immediately. So usually from 48 hours onwards, the creatinine will increase. The peak will be around 72 hours, and then usually it will settle from 5th day onwards. So these are the how to identify contrast-induced nephropathy. So these are the risk calculator. You can see the patient is having hypertension. There is very high risk, and then any heart failure, age more than 75, diabetes, anemia, and then EGFR. So EGFR less than 20 is very high risk, and then for even 40 to 60 is also risk. And then it depends upon the contrast used. For every 100 ml of contrast, 1 point. You can calculate the risk score. It gives what is the risk. So you can see for a 75-year-old diabetic, chronic heart failure, EGFR 60 means almost creatinine will be normal. And then contrast, usually in angioplasty, we'll use 100 to 200 ml. So 16 risk, that means very high risk. So this patient may require dialysis around 10% around. So in these cases, you have to be very careful. So then diabetes has to be controlled, blood pressure has to be controlled, ACE inhibitors you need stop, and then even you have to give fluids. To prevent, the only thing is hydration. Usually we'll give Bronac or NSL cysteine. There is no much evidence, but still we'll give NSL cysteine Bronac routinely. But IV fluids is the main thing. So once, if you're suspecting patient is having high risk for contrast-induced nephropathy, you can give fluids. That is 1 to 1.5 ml per kg. That means almost 50 to 70 ml per kg per hour if the patient is hospitalized. Hospitalized for MI, just you can start 12 hours before. And if the patient is admitted for daycare angiogram, just you can give in within 1 hour 3 ml per kg. Almost maybe around 200 ml per hour you can give. That is 500 ml within 3 hours. Then you can do an angioplasty. And then after angioplasty also, if the patient is hospitalized, and then for a MI and angioplasty, we have to continue these fluids for 12 to 24 hours. If there is a daycare patient, you have to give for 6 hours. So then you have to see whether the patient improved or not. So this is to prevent contrast-induced nephropathy. And there is some risk calculators are there. These things we'll use for the data. You have to collect these things like age, height, weight, diabetes, and these things. This will give correct what is the mortality, what is the mortality of this patient, what is the requirement of blood transfusion for this patient, and as well as what is the risk of kidney injury with this patient. These all algorithms, by using whatever the investigations we did, you can even estimate even before. And then you have to check for the treatment chart also. Then after all angioplasty patients, please, these are the routine protocols. Dual antiplatelet therapy, minimum of 6 months, and then usually we'll give up to 1 year. Ecosprin 150 mg, with clopidogrel 75 mg twice day or prasugrel 10 mg. So if clopidogrel or prasugrel are there, then we usually will go ecosprin 150. But with ticagrelor, we use ecosprin 75. And then we have to see that these dual antiplatelets and statins are there in the treatment or not. So this is to conclude. So this is more of practical topic. So usually cardiac catheterization is very, very safe. 0.08% risk of mortality with the diagnostic procedures. And then most of the cardiac interventional, the risk is only 2%. 98% are very, very safe. But you have to identify those patients, whoever is having high risk for the procedure. And then by implementing these protocols and then by optimizing these patients, we can improve their outcomes. And then in this regard, usually we that these things, risk assessment in protocols and these things are our headache. But I think usually you should know, you should identify that among all the patients who is at high risk, so that you can cater more time with them. And then instead of giving same care for all the people. So if the low risk patients, you can allot less time. And then where high risk patients, you can allot more time. And then frequent monitoring is required. So these things you should know. Thank you. So on this World Heart Day,
Anybody is having any doubts regarding pre-cath assessment? No, sir. We interested. Anybody is having question? Yes, sir. You can ask the question. Yes, she's having.
usually here we'll use glue. So, but usually again over a period of time.
Thank you, sister. Thank you so much, sir, for giving brief information regarding pre-cath assessment. Because we understood how to follow, how to take history from the patients, like examples like COPD and CKD patients, and which medications we supposed to give for the patient and which medication we supposed to not to give at the care time, and like nutritional status and hydration and everything will follow, sir, and our cath lab people and nurses will follow such kind of things, and we also came to know which things we're supposed to follow, and we'll do our best for giving care for the patient after procedure, pre and post procedure, and we'll do check for the bleeding and hematoma also. So thank you for your brief explanation regarding pre-cath assessment.
Maybe suppose patient post angioplasty, patient developed hypotension. How will you approach? What will you do? Patient, I did angioplasty, and then patient developed hypotension. So what steps you will take in ICCU? Anybody? Okay. So out of four differential diagnosis, first thing is vasovagal. So if there is hypotension, bradycardia, so then it's mostly benign. So nothing to worry much. So then you can give just a head low position, and then IV fluids, and then atropine. So, but there is a tachycardia. The tachycardia hypotension, that is because of either hypovolemia bleeding loss or heart failure, or something went wrong with the procedure, maybe some coronary rupture or something. So in that case, first resuscitate, take one ECG, and sometimes it may be stent thrombus also. So you have to compare. So previous ECG was pre-procedural ECG, post-procedural ECG. Okay. Even it may be VT also. VT can also cause hypotension. So then check the monitor. So no arrhythmia, no VT. And then take ECG. If there are ST elevations, new changes, That means there is some issue with stent thrombosis. Primary concern should be informed, and while you have to resuscitate, you have to give inotropes and then fluids, and then meanwhile this is the algorithm. So then even you have to take 2D call.
Now we are having tea break. Please have it. Yes. Yes. If if anybody is having any questions regarding any topic, you can chat on chat board. Thank you. Offline viewers and the online viewers.
So welcome back to everyone. So before start the session, I would like to request Dr. Satish sir, emergency HOD, for all the Medicover group to give few words about this program.
Good morning, all. I'm very happy to be here. We are celebrating this World Heart Day program here in the Blue Planet. And this is very important that everyone should know how to take care of the heart and how to educate people about how to take care of the heart. So today, I think you are having a fantastic lectures about the basics, how to take care of a cardiac patient in the hospital, starting from emergency department to the cath lab or ward or ICU and pre-cath and the OT, whatever. So these lectures definitely will help you to train, educate, and uh, increase your knowledge in your daily work. And this, I think, this year theme is like use heart to give a heart or what? Use heart for every heart. So I think everyone in this regard, I request everyone should know the basics of chest compression, CPR, so that we can train more people. It can happen, cardiac arrest can happen at anywhere, not just in the hospital. So that if we healthcare professionals knows about CPR, chest compression, if we can, the lay people, family members, lay people, so that I think they can give a heart for every heart actually. So I think you people are going to do a mock on chest compressions and cardiac arrest. So I'm very happy that you are you are here to gain knowledge and increase your knowledge. So all the very best for you for today's program. All the very best. Thank you very much.
Thank you so much, sir, for your valuable words. Over to you, Teju.
Now we are having role play by nursing in charges. I would like to welcome you all for role play. I would like to request everybody to give them a big round of applause.
as a BLS and ACLS providers, we can save many lives with cardiac arrest. Use heart for every heart. Thank you, one and all.
Wow. Thank you so much, guys. You people rocked it. Thank you. The way you performed, we can save the patient's life, and outside also we can save the person's life. The way you projected, people will understand. Thank you. Thank you each and everyone.
Yeah, dear audience, online and offline, if you have any queries, because till now we had a sessions with what is CVD and what is the pre-cath and post-cath assessment, right? So I request you all the participants who have joined through online and offline. So if you have any doubts and if you have any queries about this program, so can you ask us right now, or you can text me in the mailbox. So which one is suitable for you, you can do it. So I'm requesting all the participants. So if you have any queries about these topics, about what is CVD and what is pre-cath assessment, so you can directly post in a mailbox. So we are ready to answer your questions also. Online. Can anyone can respond? No? At least one person. No one is online. So you can directly in mailbox. So we are ready to answer your questions. So offline participants who are all seated here. So if you have any queries about this class or sessions, so you can ask us, because doctors are here to share your doubts and problems and your queries also. Because next session we are going to discuss about approach to tachycardia. So I over to you, Teju. You just introduce about consulting.
Now I would like to call upon Dr. Kumar Narayanan sir. Now sir will talk about approach to tachycardia, and sir completed his MD and DM cardiology, FHRS, CEPS, and he is a consultant electrophysiologist, and he's having 9 years of experience. Now, and he completed his ACGME, accredited fellowship in cardiac electrophysiology from USA, and he certified by the International Board of Heart Rhythm Examiner along with the clinical work. And he also interested in primary prevention of ICD utilization, epidemiology of atrial fibrillation, and Rheumatic Heart Diseases Research, and he collaborated with the Paris University and European hospitals, and he got awards like Chair Asia Pacific Heart Rhythm Society Young AP Subcommittee, Best Outgoing Student in MBBS and DM, A.V. Gandhi awarded in Excellency in Cardiology, Thomas Peter International Mentorship in Cardiac Electrophysiology, James Wilner's Award in Cardiovascular Medicine. I would like to welcome you, sir, to talk about approach to tachycardia.
Thank you very much for the very kind introduction, and I'm very happy to be here and again, go back to the basics, which we all need to do once in a while. So I'm not going to, though I'm an electrophysiologist now, obviously I should not talk at the electrophysiology level. I should see that you get a basic approach to what to do when you initially see a patient with cardiac arrhythmia. Because when you are nurses, definitely many times you're the first point of contact. If you're in the ER or in the ICU, before the doctor comes in, you will suddenly be faced with an arrhythmia which you're seeing on the monitor. So it's important not to panic and then to know what are the initial things to do, and at least try to make a provisional reasonable diagnosis, even if you can't make exactly a perfect diagnosis. Many times for your initial management, you don't have to go down to the EP or the cellular level or anything like that. What I always emphasize to whether they are duty doctors or nurses is to try to get a basic diagnosis of what's going on and know what is the basic approaches you should do to stabilize the patient. That is what will be most important. Rest of the things can always be seen at a later point of time. Good. So I'll just start with a couple of scenarios which anybody of us can come across in ER or in the ICU. So let's say it's a 65-year-old gentleman. You're the ER nurse who's there, and he's complaining of palpitations and dizziness. And you check the vitals, the heart rate is 200 beats per minute, and the blood pressure is about 90/60. And either on the monitor or when you quickly take a 12-lead ECG, this is the kind of rhythm which you're seeing. It's a very realistic, possible scenario which can happen. And, this kind of scenario often happens. Or you may have another scenario exactly the opposite. A 72-year-old lady comes into ER, or she has been admitted with a history of syncope. Initially, she was doing okay. Now, after admission in the ward, suddenly you're seeing the heart rate is only 35 beats per minute. So one of the things to remember about arrhythmias is they are not always constant. They can come and go. So the patient might have been perfectly okay when he or she was admitted and got admitted routinely to the ward saying, okay, some dizziness or syncope for evaluation. You're there on duty in the ward. And suddenly at 12 o'clock in the night, when nobody is around, you find that the heart rate is 35 and you take an ECG, and this is the kind of ECG which you find. So what happens, with the arrhythmias is that they can come suddenly, okay? Not necessarily that, it will happen right in the middle of the day when everybody is around. And that's why often people panic when they see an arrhythmia. When there is a very fast heart rate or a very slow heart rate, immediately some sense of panic comes. Or what should I do? How do I diagnose? And what should I do immediately? What is going to happen to this patient? Is just we have to give some medicines, or is the patient going to need some kind of an invasive procedure? So all these things, come up to your mind. That's why it's important to have a systematic approach and then analyze it in a stepwise manner. And then, of course, the major task for you, especially when if you're the one facing the problem, is to see what is needed to be done immediately. Okay, so instead of getting very anxious, what is the immediate thing which I can do to try and stabilize this patient? So some of the arrhythmias, of course, can be life-threatening. So that is why it's important to be able to recognize the issues promptly and at least start off the basic appropriate management which is needed to be done. So before we go to arrhythmias, all of you should know to recognize what is normal sinus rhythm. And it's not very complicated. You don't need some PhD in ECG in order to be able to diagnose that. There are a few simple rules which you should be looking at. Generally, if you're saying normal sinus rhythm, we are not even talking about sinus tachycardia. We're just talking about normal sinus rhythm. First thing to see is the rate.
right? Even before you analyze the pattern of the ECG, anything, the first question always is, what is the rate of what is the heart rate? That's very simple. And often I tell people, do not over rely on the cardiac monitors and the machines which are there. In fact, on my rounds, I don't know, some of you might have been there. Sometimes I have pointed out to you how pulse oximeters and cardiac monitors can go wrong. So remember, machines are always prone to error. So when in doubt, please go back to your good old pulse. Do not forget the art of pulse taking. Sometimes I feel it's getting to be a lost art now. So on rounds, it's okay. I'm not saying it's wrong, but it's kind of becoming fashionable to put the pulse oximeter rather than actually checking the pulse. Again, we are good. We are automating. We are having NIBP in the wards and ICU and everything. But again, sometimes NIBP can be prone to error because of cuff size, because of air leak. There are so many reasons why it can go wrong. We are not biomedical engineers. The only thing which we can do is to see if it makes clinical sense. So the patient is, totally comfortable, happily talking, and the NIBP is showing a reading of 60 by 40. You're not going to blindly believe that, right? You should ask yourself, it doesn't make sense. The patient is looking quite comfortable. He's happily talking to me. He's not complaining of any dizziness. He's not drowsy. Is it possible that the blood pressure is actually 60 systolic? So let me recheck that. So that's when you must go back to your manual skills, right? So that's the first message I want to give you. Whenever you're looking at very basic vitals, whether it's pulse or whether it's blood pressure, it's good that we have machines. Machines are correct. Let us say, to be fair to the machines, they are correct most of the time, but not all of the time. So whenever there is a possibility of artifact, you have to be aware of it, correlate using your clinical knowledge, and then recheck it for yourself. So even a couple of days back, got a call from the first floor ward saying, "Sir, please come immediately. The patient's heart rate is 200." So I said, "How is the patient looking?" "She's comfortable." So I said, "The first thing you do is send me a snapshot of the cardiac monitor." Probably I should have put it up here, but it was a complete artifact. There was some external noise which was interfering it, and obviously the monitor is going to display a heart rate of 200. So this is why I say that when it doesn't make sense, please take the pulse rate and you'll immediately know it's not 200, right? Even if you know what is before you know what is the actual pulse rate, you should be having in your mind, I know that this rate cannot be 200, right? So that will come, that kind of experience will come only if you make it a habit to do this kind of clinical examination regularly. Otherwise, that kind of intuitive sense will not come to you. When I check the pulse of a patient, I can immediately say, this is, not going to be 200 or this is not going to be 40. Both ways we can say, and that again is not a great science. You just have to do it on a regular basis. So the first thing is to know the rate, but make sure you're picking up the rate accurately. So normal heart rates are between 60 and 100. That's the definition. There is a wide variation in them. Children, the heart rate can be much faster. So if I see a 3-year-old, I'm not going to use this cutoff of 100. Children, naturally, the heart rate is faster. As you even go younger in infants and neonates, it's much more faster. So then you have to know the age appropriateness of the rate. But most of the time, let's say you're dealing with the usual adults. The normal heart rate is between 60 and 100. If it's going to go below 60 or above 100, that's the first thing you're going to see. The rate is slightly off. Then comes the question of what is the rhythm. Once you have seen, okay, the rate looks normal, but let me see what is the rhythm. Does a normal rate rule out an arrhythmia? No. There are so many other nuances to diagnosing an arrhythmia. So the rate is only that much information. If the rate is high or low, does it necessarily indicate an arrhythmia and it's not sinus rhythm? Again, not universally the case, because you can have the simple entities of sinus bradycardia and sinus tachycardia, where the rhythm is normal, but just your rate has gone off a little bit. So let's look at the simple rules to know that this is sinus rhythm. So you need regular P waves, where you can see I'm pointing out with my arrow. Okay, you need regular P waves. Then you need regular QRS complexes. Okay, so both of these must be coming at a regular wave. Then every P wave should be followed by a QRS. Okay, and then the interval from the onset of the P wave to the onset of the R wave, we call this the PR interval. That should be normal. Now, the normal PR interval, without going into the issue of milliseconds and all that, it's between 120 and 200 milliseconds. So how is the easy way for you to know it? Each small box on the ECG, the tiny box, not the big one, not this one. But within this each big box, there are 5 small squares which you can see. Each of those small squares is 40 milliseconds. So somewhere between 3 to 5 small boxes from the onset of the P wave to the onset of the QRS, then you know the PR interval is neither short nor long. So a normal regular P waves, regular QRS, normal PR interval with a heart rate between 60 and 100. And lastly, we talk about something called the normal P wave axis, where we are trying to say that the origin of this rhythm is from the sinus node. So the simple way to understand that is your sinus node is situated, if you recollect the anatomy, in the upper right atrium. So when the activation comes from top to down, 2, 3, and AVF, these are known as the inferior leads. You know, you would have all connected ECGs. You'll see that you connect lead 2 and lead 3 below on the legs, isn't it? So they are the inferior leads, and the activation comes from top to down. Therefore, the P waves are going to be positive in that. Another very important lead, what is often known as the orphan lead, because nobody bothers to look at it, is AVR. So AVR is representing the activation as seen from the right shoulder. So when the sinus activation goes away from it, the P wave in AVR will be negative. So using these simple rules, look at the inferior leads, look at AVR, and then you can see that this rhythm is coming from the sinus. Then you can say that, okay, the rhythm looks like sinus. So, but of course, if you don't have the 12 lead ECG, if you're just having a monitor, you can look at least the rest of the criteria other than looking at the P wave morphology. You can look at the rest of the things. You can look at rate, you can look at regularity, you can look at every P wave being followed by a QRS, and you can see that there is not too much delay between the P wave and the onset of the QRS. So then you can say that, okay, this rhythm looks like sinus rhythm to me. So having understood what is normal sinus rhythm, then you can approach the classification of arrhythmia. At a basic level, the classification is not too complex. If the heart rate is too fast, if it's more than 100, we're going to call it a tachycardia or a tachyarrhythmia. And then if the heart rate is below 60, if it's too slow, we are going to call it a bradycardia or a bradyarrhythmia. Now for bradyarrhythmias, there are mainly only two pathophysiological bases. Either there is a problem with the sinus node where the impulse is originating, or there is a problem at the AV node or the AV junction, which is supposed to conduct the impulse from atrium to ventricle. At a pathophysiologic basis, it has to be one of these two. The etiology of that, there can be so many different things. If you just give a drug which suppresses the sinus node, the heart rate can come down. The sinus node itself is okay. The problem is iatrogenic. Some drug has been given which is slowing down the sinus node. Similarly, if you give a drug or if there is a metabolic abnormality which causes a slowing of the conduction in the AV node, then you're going to have varying degrees of AV block. Or it can be a problem with the intrinsic conduction system itself. The most common reason is age. With age, the conduction system is going to develop fibrosis and the heart rates can slow down because of that. So that's as far as bradyarrhythmias are concerned. But today, what we are mainly going to discuss, we are going to discuss tachycardias, where the heart rate exceeds 100 beats per minute. Now, again, we have to see how do I approach this whenever a patient is having a tachycardia. How can I at least approach to a basic extent to see what the rhythm might be? So, two things which straight away what can strike you in the eye, even if you're just having a monitor, even if you don't have a 12 lead ECG. The first thing you can see is this pattern regular or irregular? So it's the cadence, like a drum beat. Okay, is the QRS complexes? And when we talk now about regularity or irregularity, remember on the monitor we are talking about QRS. Why is that? That is ventricular depolarization. That is what gives rise to your pulse, right? Your atrium, the way it is going, you can of course make it out in an ECG, but it doesn't reflect the atrial depolarization or the atrial contraction doesn't reflect directly on your pulse rate. What gives rise to your pulse rate is ventricular contraction. So everything which we will talk about in terms of regularity and rate, everything will be referring to the ventricular rate. That's understood by default on the ECG. If I say the rate is 110, I am referring to the ventricular rate unless I'm specifying, okay, I'm talking about the atrial rate. So when we say regular or irregular, we are going to look at the QRS complex. That's the biggest complex on the monitor. You can see, is it coming very regularly? It's fast, but it's coming very regularly, or it's kind of irregular. You know, suddenly it's on and off. This is one of the important reasons where a monitor or a pulse oximeter can go wrong. So often I get a call from ICU or ward, whether it's from nurses or whether it's from duty doctors. They say, "Sir, the heart rate is fluctuating wildly. It's fluctuating too much. Suddenly it's 50 and suddenly it's 150. Now, if you think about it intuitively, it's very difficult for the heart rate to fluctuate too much like that in actual terms. What is happening most likely is that the rhythm has become very irregular. So between consecutive RR complexes, the interval is varying wildly, and how this will affect the monitor, I'll tell you. The second thing which can straight away strike your eye is how is the QRS looking? Is it looking very skinny? Is it looking thin? Or is it looking fat? So that is your narrow QRS, skinny QRS versus a broad QRS or a fat QRS. Generally, you can take it as a broad rule, but not always true that a fat QRS may be potentially more dangerous because mostly ventricular tachycardias or VTs have a broad or a fat QRS. Supraventricular tachycardias, which are generally better tolerated by the patient, they usually do not cause immediate hemodynamic compromise. They are characterized by a thin or a narrow QRS. So that's again something you can straight away learn to recognize. You repeatedly look at rhythms, monitors, and ECGs. So whenever ECGs are done, just run your eye through it. You don't have to spend a lot of time trying to completely interpret it, but at least your eyes will get accustomed to how a normal. When you'll take a lot of normal ECGs in your wards. So look at all of them, understand. Okay, this is how a normal QRS looks. And then when you come across a broad QRS, you'll immediately recognize, okay, this is looking much more fatter than what I usually see. And that will help you again to make a preliminary impression on the tachycardia. So we already said that tachyarrhythmias, how do we define them? Now, how to develop an organized approach to the diagnosis? The first thing I want, again, for people to try and understand is don't just focus on the tachycardia ECG alone. But if you have another ECG which was taken when the patient was normal, at a normal rhythm, that will help you as well. A very simple thing, for example, if you're having a doubt, is it really broad QRS? You can quickly go back to the baseline ECG. If that was normal QRS, the contrast will be obvious to you. Okay, now there is a broad QRS tachycardia going on. This is not the usual QRS of the patient. Then, when you want to recognize an arrhythmia, this is again sometimes often, I tell the other beauty doctors or other cardiology trainees, everything. Sometimes we just forget the history, we forget the clinical context of the patient. That should never happen. A simple example of that would be if the patient has had an MI or he's had an old MI, he's had a bypass, all of these issues, and the patient is having a tachycardia, the likelihood that its VT is higher. On the other hand, if it's a young patient, no heart disease was there, nothing known previously, it's now having a tachycardia, the chances of it being a VT are less. So remember, all clinical rules are broad rules. They're never going to be 100%, but you need some kind of a guidance to approach the patient. So what are the different parameters we can use to classify a tachycardia? The number one, which is the most obvious thing, we have the information immediately, is the rate. Is the rate 150? Is it 160? Is it 180? It's very obvious, immediately available. But based on the rate, can you really make a or get a good guidance to diagnosis? Not really, because the rate of a tachyarrhythmia really depends on a lot of factors. It depends very importantly on age. For example, if a 10-year-old has a SVT or a supraventricular tachycardia, the rate can easily be 250, 260. Can look frightening, but that's mainly because of the young age where intrinsic heart rates itself are high. The same SVT, if it's happening in a 70-year-old, it may be only 150 beats per minute or 160 beats per minute. So it's going to vary a lot depending on age, depending on what drugs the patient is taking, depending on the current state of the patient. If the patient is very frightened, very nervous to be in the hospital, the tachycardia rate may go up immediately. Whereas the patient is in a comfortable situation at home, the same SVT, the tachycardia rate may be slow. So it's not very useful. The second way we mostly classify is based on the site of origin. And this is a term you would have heard. Is it supraventricular tachycardia, SVT, or ventricular tachycardia, VT? So you would have heard this term many times. We'll see what it is. Then regularity of rhythm we already talked about. You can make out by looking at the pattern. Is it regular? Is it irregular? Another very simple skill which you can all develop is if you have a paper ECG in front of you, you can just take a small piece of paper, you can mark, you can just keep it on one QRS to the next, just mark the two lines. Then march it through and see if all the QRSs nicely fall on the two lines which you have marked, which means the rhythm is very regular. It's coming at the same time. But if it's going all over the place, it's not matching at all the lines which you're marking, then the rhythm is irregular. This is very useful, especially when the rate is fast. The faster the rate becomes, the more difficult it is for the eye to discern a pattern. So you'll start getting confused. Is it really regular? Is it irregular? So this is something which you can very simply do. And we already talked about broad QRS versus narrow QRS. So let's define what is SVT. What do we mean by supraventricular tachycardia? So you're all familiar with the anatomy of the heart. You have the two atria. This place between the atrium and the ventricle is broadly referred to as the AV junction, where you have the AV valves. You also have important components of the conduction system, AV node, his bundle. And then the way we define supraventricular tachycardia is if the tachycardia involves any part of the heart above the AV junction, then it is known as a SVT. Why do we not say simply that originating from? Why am I saying involving rather than? I can simply say if it originates from, right? The reason is that we all think of tachycardias as one focus in the heart which is firing very rapidly, like one pinpoint focus. Actually, the dominant mechanism of tachycardias is not that. The dominant mechanism of tachycardias is something known as re-entry. So what do we mean by re-entry is that there is no one spot where the tachycardia is starting. Rather, it's like an electrical circuit which is going round and round the heart. An electrical circuit is a circle. So what is the beginning of the circle and what is the end of the circle? We don't know, right? There is no beginning or an end of a circle. So many times re-entrant tachycardias are like this. There'll be a circuit which is going around the atrium, coming down to the ventricle, going up again into the atrium. So this is something called as re-entry or circus movement tachycardia. This is the most common mechanism of tachycardia. Focal firing, what we are able to easily imagine, that is a much lesser mechanism of tachycardia. So that is why if a reentrant tachycardia, the circle necessarily involves any tissue above the AV junction, we call it supraventricular tachycardia. Now, usually SVTs are narrow or skinny QRS, as I said. The reason is most of the time SVTs go down to the ventricle via the normal conduction system. They use our own conduction system, AV node, his bundle, and everything. And what is important to remember is that normal conduction system represents the most efficient way to activate the ventricle. It activates the ventricles in the fastest possible time. It's the beautiful normal mechanism of activation. So the ventricles get activated very synchronously, very fast, very smoothly. The QRS is very narrow, quick activation. So usually SVTs are narrow QRS or skinny QRS, but there can be an exception to this if the conduction system is not conducting in the usual way. It's taking some delay. That is known as aberrance. So you all know bundle branch block, right bundle branch block, left bundle branch block. Those are situations where the conduction system is conducting a little slower, so the QRS can get a little broad. But more often the SVTs will be narrow QRS. What about VT? VT is a situation where the abnormal rhythm is arising completely from the ventricles. So it's not at all involving any tissue above the AV junction. So most often what you see, the focus is going to be either re-entry or a focal origin in the ventricular myocardium itself. So a diseased ventricular muscle is developing abnormal electrical activity, firing very rapidly, and you're going to have a VT or a ventricular tachycardia. So here what's going to happen, the ventricle is going to get activated in a very bizarre fashion. Say the focus is sitting somewhere in the left ventricle, right? It's going to start from here and through muscle to muscle activation, it's going to activate the rest of the ventricles. That is not an efficient way to activate the ventricles. The QRS is going to be longer duration of broad, bizarre looking QRS. So that is VT. So let's look at the point of regularity. Now we all learned from a very early days that if it's an irregularly irregular rhythm, then it's going to be atrial fibrillation. It's AF. A very closely linked rhythm to that is called multifocal atrial tachycardia. You don't have to worry about it. If you call an irregularly irregular rhythm, you recognize it as AF, I'll be happy. So this is a very classical example of an AF. So this is what I was talking about. Look at this R wave to this R wave. Okay, little long. This is slightly shorter. This is a little more longer. This is very short. This is slightly longer. This is slightly longer. This is very long. Again, suddenly becomes short. So you see, there is no pattern at all. It's all over the place. You can see very obviously at first look that this RR is extremely irregular. And here you'll be able to understand why this problem of wildly fluctuating heart rates comes. How does a monitor or a pulse oximeter read the heart rate of a patient? Have you ever thought about it? What does it do? It simply measures the time duration from one R wave to the next R wave. Okay, and it says it is taking this much time, and then it says if this is what the time going to take from one beat to the next beat, then in 60 seconds what will be the heart rate? We can extrapolate, right? Suppose from one beat to the next beat took 1 second, then you will say, well, in 60 seconds it's going to be 60. That is what the monitor does. Okay, and of course the monitor is a calculator, it can do it very fast. So what it does, it takes this QRS to this QRS and it gives you a heart rate. Now what is happening? Let's take these two beats. This to this, there is a short interval. So it correspondingly, the heart rate is calculated as higher. This to this, suddenly the RR became prolonged. Immediately it extrapolates it to 1 minute and the heart rate sharply drops. Then it goes back to this, which is even shorter. Suddenly the heart rate is again high. So you understand the reason why this question of wildly fluctuating heart rates comes. Whereas the true heart rate of the patient is neither this, nor this, nor this. It's an average of this entire duration. That is why you have to understand that the moment the rhythm is irregular, you cannot rely on the beat to beat heart rate variation which the monitor detects. Do you understand now what is the meaning of beat to beat heart rate variation? That is how a cardiac monitor works. That is how a pulse oximeter also works. So you should not be fooled by it. The same problem can come up if there are frequent ectopics or PVCs. Again, it calculates beat to beat, and then your heart rate will wildly vary from one beat to the next. So whenever you see an irregular RR, do not rely on the monitor anymore. Take the pulse for 30 seconds, average it, and then say that is the heart rate of the patient. So this is an example of AF. Now we said irregularly irregular, and then we use another term called regularly irregular. So what do we mean by that? The previous ECG you saw, you couldn't make out any pattern. It was all over the place. Now this ECG, if you see, again, you can see that the RR interval is not regular. Okay. It's suddenly coming close. It's suddenly coming apart. Again, it's coming close. So it's not regular. It's irregular. But here, if you see, there is what I call a method to the madness, or there is a pattern. Look at this. There is a group of two. Again, there is a group of two. Again, there is a group of two. And this kind of pattern is going to repeat. So whenever you see a repetitive pattern like this, then you can understand that there is a regularly irregular rhythm going on. Most of the time, this happens with atrial tachycardias, which are not conducting in a fixed pattern to the ventricle. So that is a concept you need not necessarily remember, but I just want you to kind of understand that, okay, this is a regularly irregular rhythm. Some kind of a pattern is repeating. Sometimes it can be 2-2-2, sometimes it can be 3-3-3, sometimes it can be 2-3-2-3, whatever. You can see some kind of a phenomenon called group beating which is going on. Your QRS comes in bunches, groups of two, groups of three, groups of two and three alternating, whatever it is. Whereas in the previous ECG, there is no such pattern you can make out. It's all over the place. There is no grouping phenomenon which you can find. So when you see group beating, think of regularly irregular. Now, narrow or broad QRS, again, I told you the importance of visually analyzing. Look at a lot of ECGs, recognize thin QRS versus fat QRS. But if you want to know the definition, the measurement, the QRS duration, if it's less than 120 milliseconds, we call it a narrow QRS. As far as tachycardias are concerned, this is not for normal ECG interpretation. This is for tachycardia. If it's more than 120 milliseconds, we're going to call it a broad QRS. We already talked about the reason. What does a normal QRS or a narrow QRS tell you? It tells you that the ventricular ventricle is getting activated along the normal conduction system which we have. A broad QRS is some disruption is going on. Either the conduction system is not conducting properly, there's a bundle branch block, or the rhythm itself is coming from the ventricle where a VT is going on. So I don't think this is play, but this is just to show you the visual, just to keep in your mind. The rhythm originates from the sinus node here at the junction of SVC and right atrium. Then it depolarizes both atria, comes to the AV node here. There is some delay, and then goes down the His bundle, both bundle branches, and then here synchronously both ventricles are activated. That is why the QRS is very narrow in the usual way. Let's tackle now the two main things which you see. If you see a broad QRS tachycardia, what are the possibilities? There are really only two possibilities, I would say. You're not even three. It's either an SVT with aberrant conduction or it's a VT. This pre-excited tachycardia, which is basically, an accessory pathway, it's also a type of SVT. So maybe I'll show you a visual impression of each of these. So let's look at this pre-excitation or pre-excited tachycardia, which is also a type of supraventricular tachycardia. What happens in this is, other than the usual conduction system, there is an extra pathway or an accessory pathway which is connecting the atrium and the ventricle. This is usually a congenital condition. People are born with it. Sometimes these accessory pathways can be totally silent. They may not cause any trouble in life. At other times, they can suddenly start conducting from the atrium to the ventricle in an alternative fashion other than the AV node. So what will happen is whenever that happens, this ventricle, depending on where this accessory pathway is located, it can be located anywhere in the right or left. Depending on that, the ventricle is going to start getting activated in a different and bizarre way, not from the usual conduction system. So your QRS is going to become a little fat. This phenomenon where the ventricle gets pre-excited by an extra accessory pathway is known as the pre-excitation syndrome. Sometimes it's also called the WPW syndrome or the Wolff-Parkinson-White syndrome, which is named after the three scientists who originally described it. So how can this give rise to trouble? Because again, it's just for you to, understand a little bit and get, a little interested in how arrhythmias actually occur. There are two ways this accessory pathway can cause trouble in people. So here where it's labeled AP, that's the accessory pathway. This thing with the round thing, AV node and the conduction system, this is the usual way of activation. So remember, so this is what I was talking to you about re-entry or a circle. This is an example of that. What can happen is under the right circumstances, when an SVT is triggered, what starts happening is that the impulse goes from the atrium to the ventricle, the usual conduction system. But instead of, just finishing the cardiac cycle there, it re-enters via the accessory pathway from ventricle to atrium. Then it becomes a continuous circle which starts going very fast. So what happens? The heart rate suddenly shoots up. This is an example of an SVT. Why? Because the circuit involves tissue above the AV junction. Without this tissue, this tachycardia cannot survive. So if this accessory pathway works in this way, in a ulta way, it is helping to pass the current from ventricle to atrium, which usually shouldn't happen. So what is going to happen? Your ventricles are getting activated in the normal way, so thin QRS, skinny QRS, but there is a hidden circuit which is going on, which you cannot see on the surface ECG, but this is what is happening inside the heart. So here the accessory pathway is going to give rise to a narrow QRS tachycardia. It's an SVT, a narrow QRS tachycardia. The mechanism is that this accessory pathway is silently sitting inside and helping to make a circular movement tachycardia by doing a ventricle to atrium conduction, which shouldn't usually happen. But sometimes the accessory pathway can get even more bizarre. What will happen is, under the right conditions, the accessory pathway will start conducting straight from atrium to ventricle, and then our own conduction system will end up completing the circuit. So again, this is a circular tachycardia, but here the ventricle is getting activated from the accessory pathway, not from the AV node. So it becomes totally bizarre. The QRS becomes extremely broad, and this is another way a tachycardia can happen. So this is what we call a pre-excited tachycardia or a broad QRS tachycardia. One of the mechanisms can be the presence of an accessory pathway. Sometimes this accessory pathway can give rise to a sudden danger. When a patient with an accessory pathway develops an atrial fibrillation, because of the accessory pathway, the impulses can conduct very rapidly to the ventricle, and you can have an extremely fast and bizarre looking rhythm like this, where the QRS is irregularly irregular because it's AF which is going on, but at the same time, it's extremely broad and bizarre because the accessory pathway is conducting the impulses very fast. This can be sometimes life-threatening for the patient. So whenever a patient has an accessory pathway capable of causing pre-excitation, your baseline QRS itself will usually be broad, and this pattern is known as pre-excitation. So when you see a pre-excitation at the baseline, that's why I said when you have a baseline ECG, very useful to look at. If you have a pre-excitation on the baseline ECG, then the patient is coming with a broad QRS tachycardia, immediately you must think, okay, this must be pre-excitation which is going on during the tachycardia as well. What about the other thing, BT? We already talked about the other possibility of SVT with aberrancy. One reason can be pre-excitation, which we talked about. The other reason can be simply that one of the bundles is not conducting fast enough. That is what is known as a bundle branch block. Because of that, again, there is a delay in activation of the ventricle. The QRS becomes a little broad. So often this dilemma comes up. Patient is having a fast, broad QRS tachycardia going on. What is it? Is it VT? A VT is potentially more dangerous, or is it SVT with aberrancy? So this is where, before analysis of the ECG, as I said, your clinical scenario is very important. The patient has had prior MI, the patient has had prior bypass, some kind of a cardiac surgery. The chances are more that it is VT. On the other hand, the patient has a structurally normal heart, never had any MI, never had any surgery. The chances are more that it is SVT with aberrancy. Then, based on the ECG clues, there are certain diagnoses which you can make. We will not go into the details of that because that's a little too complex to remember at this stage. And then there are certain clues which we use in the ECG. We see, is there a typical bundle branch block pattern that may more suggest an SVT of the aberrancy? On the other hand, the QRS is looking completely bizarre, doesn't fit into any bundle branch block pattern. Then we say that is more likely to be VT. So again, a comparison with the baseline ECG, very useful. So this is just an example for you to understand. This is on the left is an SVT with aberrancy. Again, you can see the QRS is a little fat looking, but you can see how clean this activation is looking. It's a very typical left bundle branch block pattern. So this is more likely to be SVT with aberrancy. On the right side, you can see again, the QRS looks like a left bundle pattern, but when we look at the criteria for left bundle branch block, doesn't satisfy it at all. The QRS looks very bizarre. This is more likely to be VT. So this is just for you to have a basic sense of what we do. Then we come to the next situation, which is a little more common, which is narrow QRS tachycardia. So here you see on the monitor, the QRS is, there is a rapid tachycardia going on. The QRS is looking very thin. The first thing you're going to see is it irregular or regular? If it's irregular and all over the place, we already said most likely it's going to be atrial fibrillation. Okay. What if it's very regular? A regular narrow QRS tachycardia. That is your classical SVT or supraventricular tachycardia. So again, at a basic level, you can make a diagnosis. This is a narrow QRS tachycardia going on. To me, it looks very regular. I think this is an SVT. Okay. So SVT, there are again various mechanisms. It's not important to go into the the mechanisms of how these happen. Most of them, as I said, again, are some kind of re-entry within the heart. The re-entry can be within the AV node. We call it AV nodal re-entry. It can be what I just showed you with an accessory pathway between the atrium and the ventricle. There is a circle going on. We call it AVRT or atrioventricular reentrant tachycardia. Sometimes it can be a focal spot in the atrium which is firing very fast and conducting to the ventricle. That we call it atrial tachycardia, or we can also have something called atrial flutter. So this is how an example of an SVT looks. Look, there is a tachycardia going on fast. The RR interval looks very regular and the QRS is very thin and skinny. You can appreciate that, isn't it? So this is how a classical SVT looks. This is another example, an atrial flutter where you find sawtooth-like waves on the ECG, and then you have a tachycardia going on. So we'll not go about the special situation of narrow QRS VT or left fascicular VT and all. Let's come to what to do. So you have seen the monitor, you have taken the heart rate and everything. You know there is a tachycardia going on. So made, let's say, a provisional diagnosis. I think it's AF or I think it's ST. Question is what to do now? What do we do immediately? Patient's heart rate is 180, 19. So what do I do? What is the first thing I need to do? The first thing is not to make a diagnosis immediately. That's not the first thing which you want to do. The first thing you need to see is the patient hemodynamically stable or not? That doesn't require ECG knowledge. That doesn't require even to see whether it's regular, irregular, nothing. The patient is having an ongoing tachycardia. If you call me for an arrhythmia, there are only two things I want to know from you. So you can check it right away before you call anyone. Number one, what is the blood pressure of the patient? Okay. Doesn't matter if the heart rate is 200. The blood pressure is 120 by 80. You can take a few deep breaths and calm down yourself. But if the heart rate is 150, but the patient's blood pressure is 60 systolic, that's not a good situation. So before you analyze anything, before you want to make a diagnose anything, the first thing I want to know is what is the hemodynamic stability of the patient? And closely related to that is how is the patient looking? The patient is having a tachycardia going on, patient is drowsy, is looking dizzy, he's sweating all over, not a good situation. The patient is having a heart rate of 220, the patient is comfortably sitting, he's telling you, yes, I'm having palpitations, I'm feeling a little uncomfortable, but otherwise I'm okay. So again, you can take a few deep breaths and calm down. So the first thing doesn't really depend on your knowledge of ECG or your some complicated analysis or anything. The first thing is simple clinical sense. So I want to know what is the blood pressure of the patient. I want to know how the patient is looking. Is he talking? Is he conscious? Is this thing? So if the patient had a heart rate of 200, the patient is flat on the bed, unconscious, not responding, that is a dire situation. It doesn't matter what the rhythm is. Whatever the rhythm is, it's bad enough. That is what you need to know. So the first question which often comes up in the ER or in the ICU or in the ward situation is there is a rapid tachycardia going on. Do I need to shock the patient? All of you have seen cardioversion, defibrillation being given. When is it necessary? It's something very dramatic which is done. When is it necessary? It is necessary if the tachycardia is causing immediate hemodynamic compromise. Okay. So then you don't have a time to take an ECG, you don't have a time to do a detailed analysis and all that. If you believe this tachycardia has caused the patient to collapse, if it's caused hypotension, then take the paddles, shock. What I'd, however, tell you to do in this situation is one more person is there, quickly take a snapshot or quickly take a video of the arrhythmia on the monitor. So that's the advantage. We all have smartphones now, we can do that. Or if the rhythm strip is working, please press the rhythm strip as you're going ahead and giving your DC shock or whatever you're doing. Why? Because the arrhythmia, as much as possible, we should try to document. If we blindly shocked it, we got the normal rhythm fine, but we have lost a valuable opportunity to know what arrhythmia happened. What did the patient have and why is that important? Fine, you shocked and got the patient out of the acute crisis, but it can come back. So you need to know what is the underlying situation. What did the patient have? Was it a VT? Was it a very bad SVT which caused a drop in blood pressure? So to further manage the patient, to prevent this arrhythmia from coming back, you need the diagnosis. That is why I always say, if the patient is hemodynamically stable, do not panic and rush to give drugs or shock or whatever. Take the time, quickly get a 12 lead ECG. You're watching the patient all the time, blood pressure is fine, patient is looking okay. Quickly get the 12 lead ECG. Then you do whatever you need to. The patient is unstable, you don't have time to go and get the ECG machine and all. Immediately try to convert the rhythm, but try to take a rhythm strip at least if possible. What are hemodynamic instabilities? Number one, low blood pressure. Two other equivalents are severe heart failure or pulmonary edema. The patient was looking fine. Suddenly, a rapid tachycardia has started. The patient becomes very breathless. Saturation has fallen. That's again a hemodynamic instability, even if the blood pressure is okay. Or the patient complains of severe angina. These are the situations where you want to promptly convert the rhythm. If it's hemodynamically stable, please document. Try to make a provisional diagnosis. Is it SVT? Is it VT? Is it some AF? Okay. These broad three categories at least you can make. So when it is SVT, you might have seen us sometimes doing these maneuvers. We do something called vagal maneuver. They are very useful. Some patient has SVT at home also, you can teach them that. What are the common vagal maneuvers we do? And what is the meaning of a vagal maneuver? A vagal maneuver means any kind of thing which you do in order to stimulate the vagus or the parasympathetic nerve. Parasympathetics, if you recall the physiology, slow the heart rate down. They have slowing down effect on both the sinus node and the AV node. Why does it work? Because most SVTs are in some way dependent on AV nodal conduction. So if you abruptly slow down AV nodal conduction, you will terminate the tachycardia. So you might have seen it happening in the ER. Sometimes we give a carotid massage. The carotid has some baroreceptors near it. If you stimulate that, you will stimulate the parasympathetics. You can break the tachycardia. Sometimes we can ask the patient to wash the face in cold water. Again, it stimulates the vagal nerve. Sometimes you can ask them to do Valsalva maneuver, such as blowing into a syringe. So all of these can terminate SVT. Other than that, the commonest drug we use, you might have seen again in ER, is adenosine. The important thing about adenosine is its half-life is extremely short. It's a few seconds. That is why you need to have a good IV line. You need to give it very rapid push with a large saline bolus. Otherwise, before it reaches the heart, adenosine will get metabolized. It won't work. If you give it very slowly, it won't work. Okay, so there are certain drugs which need to be given very slow. Adenosine is the exact exception to it. You need to give it extremely fast. The only relative adenosine is safe in most of the situations. Only relative contraindication is a severe wheezing. Adenosine can worsen bronchospasm. Pre-excited tachycardia you very rarely see. So most of the times, if you have SVT, adenosine is a safe choice to give. The other drugs which you can use are calcium channel blockers like verapamil and diltiazem. These need to be given slow IV push. Why? Very rapid push of calcium channel blockers will cause hypotension. And the other thing to remember is generally calcium channel blockers are not used in children, with very rare exception. So as I said, if you're doing something very fast, get a rhythm strip. It's also very useful to get a rhythm strip when you are giving the medication. You want to see how the tachycardia terminates. This again is something doctors and electrophysiologists will thank you if you get a rhythm strip during the administration of the drug, because it can give us a valuable information about what is the mechanism of the arrhythmia. Long-term management, again, not very important, but then just for you to have a broad idea, can be drugs. It can be the avoidance of precipitating factors which triggers the arrhythmia. Somebody tells you, whenever I take coffee, I'm getting triggered palpitation. Please tell them, cut down your coffee or avoid it. Alcohol is a very important trigger of many arrhythmias, especially atrial fibrillation. So we should not forget these simple things. Rather than, of course, we need to give drugs or go for some complex treatment sometimes. But sometimes the solution will be in the hands of the patient. Whenever the patient is having a binge of alcohol, he develops AF. So if he wants, he can solve the problem without taking any drugs or without going for any complex solution. So, but otherwise, we use again drugs which mostly affect the AV node or they affect arrhythmia circuits, such as beta blockers and other drugs. Then catheter ablation, of course, is there, especially for SVT, where we can aim to completely cure. So this is an example of how catheter ablation works. So for example, let us say in a patient, this accessory pathway is what is causing repeated SVT. So what do? Using the percutaneous route, we put some catheters into the heart, which have electrodes, which can measure the electrical signals or record the electrical signals from within the heart. So we can get an exact idea of how the tachycardia circuit is going. And then we use a special catheter which can deliver radio frequency energy there. And with exactly that precision, that area, that few millimeters, we are going to ablate, just take care of the accessory pathway. So this is one of the few situations in clinical medicine where you can completely cure something. So otherwise, we can very rarely use the word cure, but arrhythmias are a situation where sometimes you can completely cure and get rid of the problem for life. And this we often do in young patients who are having SVT rather than telling them to take lifelong medication. What about VT or VF? It is more likely to be hemodynamically unstable. So we may need a prompt defibrillation. The general drugs we use are intravenous lidocaine or Xylocard, then intravenous amiodarone. Beta blockers, especially coronary artery disease, is the underlying situation. One thing, again, I would like you to recognize is the situation of what we call tossards or polymorphic VT. This is a unique pattern you may see sometimes happening in the ward or in the ICU. What I want you to focus is the way the QRS is twisting like this. Suddenly it is big, suddenly it is becoming flat, again it is becoming big. It looks like a rope is being twisted around the axis. And this is known as tossard de point. Literally, it means twisting of the points in Latin. Okay. So why I want you to see this, in this particular situation, you should not use amiodarone. Amiodarone is a very favorite in the ward. Okay. But this tossard de point, this specific arrhythmia is caused by an underlying substrate where the QT interval is very long Amiodarone further prolongs the QT interval and it's probably the worst agent you can give in this situation. What is the drug of choice if you see TDP? It is intravenous magnesium. 2 grams of magnesium can help you terminate. But of course, most of the times this rhythm is extremely unstable. Most of the time you'll have to shock. But after shocking, you should not give amiodarone. That's important. I don't know if any of the ICCU nurses are here, but last month we had a young male who came with exactly this rhythm. Unfortunately, he received 450 mg of amiodarone before I saw him. The next 2 days, he required 15 shocks because he kept going into recurrent TDP because amiodarone had further prolonged the QT and worsened the problem. So amiodarone is a good drug in a lot of situations, but there are some exceptions you must remember. Then we look for identifying and treating any precipitating factors which may be triggering the arrhythmia. What are the common ones? Acute ischemia is important. Yes. Electrolytes are very important. So whenever you see a patient with arrhythmia, please send off the electrolytes even before the doctor asks you. What are the important electrolyte abnormalities which can trigger arrhythmia? Hypokalemia usually triggers tachyarrhythmia. Low triggers high. Hyperkalemia usually triggers bradyarrhythmia. High triggers low. That's important. So potassium is very crucial. Little potassium is unforgiving. Okay, a little this way, that way, and it will start triggering arrhythmia. So that's why potassium we are always very first about. Hypocalcemia again usually triggers tachyarrhythmia. Hypomagnesemia usually triggers tachyarrhythmia. So these are the common electrolyte imbalances. Acute ischemia, of course, is very important. Any patient comes with unexplained VF, we shock. The first thing we are worried about is it an acute MI? Okay. Drug toxicity, very important. One of the common examples is digoxin toxicity or a very high dose of beta blockers causing AV block. Hyper or hypothyroidism, usually for tachyarrhythmias, we're worried about hyperthyroid state. So sometimes you will see that I ask to send the thyroid profile. So identify and treat precipitants, give the drugs according to the choice of the arrhythmia. And then some patients who are at risk of having recurrent VT or VF, we may implant a implantable defibrillator so that in the future, if an emergency VT or VF happens, this device automatically diagnoses the arrhythmia and it delivers a intracardiac shock. So this is called an implantable defibrillator or ICD, and this we put for patients who are at risk of recurrence. A brief mention about AF. Again, AF, if it's hemodynamically unstable, you would shock it. But otherwise, you try to bring down the rate by using some rate control agents like beta blockers, calcium channel blockers, digoxin. In order to try and convert the rhythm in an organized way, you use antiarrhythmic drugs. The commonly used drugs are amiodarone and flecainide. Flecainide, we don't have the intravenous preparation. So when we are trying to convert it leisurely, we can use oral flecainide. One important thing to remember about atrial fibrillation is it poses a risk of ischemic stroke. So whenever a patient has atrial fibrillation, ask the question, where is the anticoagulation? So you can ask the doctor on rounds. So this patient is having AF, but I don't see any heparin or anticoagulation written. Why is that? So unless there is a contraindication or a bleeding risk, all patients on atrial fibrillation should be getting anticoagulation. Of course, there are certain scores we look at to calculate the risk of stroke. So some patients may not need anticoagulation. But from your point of view, I want you to remember when you see AF, think anticoagulation. Why is the patient on anticoagulation? No. You can ask why is the reason why the patient is not put on anticoagulation. AF is often triggered by a lot of underlying systemic conditions, so we address those risk factors. So to finally summarize, tachyarrhythmias can sometimes cause a panic, but what I want you to do is not to panic. The first thing is not to go for some exotic diagnosis or try to analyze the ECG. The first thing is to look at the clinical status of the patient. That is what is most important at your level. So next time when you see a tachyarrhythmia, already before calling somebody, you have seen how the patient is looking, you have seen how the blood pressure is, and you're able to say the patient is having a heart rate of 180, the blood pressure is 130 over 80, the patient is conscious, he's talking fine, he's not sweating, he's not looking distressed, he's not looking, he's not having a low saturation or he's not breathless. So this conveys a much better information which you can get in 1 minute rather than just saying, oh, the monitor is showing 180. So that is, you have not done the complete analysis at a basic level. So look at the clinical situation. If the hemodynamic instability is there, most of the time we need to get rid of the arrhythmia quickly. Again, I would say beware of artifact. Don't over rely on monitors. Whenever in doubt, go back to your good old traditional pulse taking, traditional blood pressure measurement. And if it is hemodynamically unstable, we need to take a quick action. But if it is stable, please take the opportunity to immediately get a 12 lead ECG. And whenever you're giving some drug or doing some maneuver to break the tachycardia, try to get a rhythm strip as it is happening. So probably one request I can make to the nursing in charge is to see that there is a manual BP apparatus in each ward. Okay, so it's good to have NIBP, but for two reasons. One, they should not forget how to take BP. You leave it all in NIBP. After some time, they'll say, "What is manual BP? How do I auscultate?" Right? It will happen. The second reason is to see that we do not get sometimes misdiagnosis based on a monitor error or a cuff error. So with this, I'll stop. So if you have any questions, I'll be happy to.
Is that anybody is having questions regarding approach to tachycardia? Yes.
So the question is, can you use adenosine even if there is hemodynamic instability? So I would say that in most situations of hemodynamic instability, you would most likely go for a shock. So, sometimes, see, remember the clinical situation is like a continuum. It's not like a yes or no situation. Sometimes you're seeing the blood pressure is 90, 60, just about borderline, and patient is saying, I'm feeling dizzy, but not so bad. Maybe you have a minute or two. So there is no harm. If you believe it's an SVT, adenosine terminates more than 95% of SVTs if you give it in the proper way. So you can say, okay, he's a little unstable, but it's not too bad. Let me quickly try an adenosine. Because the shock is always traumatic. So that's the only reason. But if the patient is grossly unstable, I would say don't go for a drug because you're not sure the drug will terminate. It takes some time to get the ampule to load, however fast you are, it's going to take 2 to 3 minutes. So if there is a gross instability, patient is 60 systolic, he's looking like this, or almost collapsing, heavily sweating, don't take a chance. Get the bed flat, get your paddles, shock, get the patient out of the rhythm. But if not, you have maybe a couple of minutes, you can always try to give adenosine if you think that what is going on is an ST. No, not necessarily. So the question is, does every SVT mean that an accessory pathway is present? So I briefly mentioned the three broad mechanisms of SVT. The first most common one, close to 80% of SVTs are what is called AVNRT, AV nodal reentrant tachycardia. There is no accessory pathway there. Due to certain cellular mechanisms within the AV node itself, there is a reentry which starts happening. So these patients have their normal AV node only, but still they get a reentry. That is called AVNRT. It is the most common of the SVTs. There is no accessory pathway. The second most common mechanism of SVT is presence of an accessory pathway. The accessory pathway need not cause always this WPW pattern in the ECG. Many times the accessory pathway is hidden. It conducts only from B to A. So you see no obvious manifestation on the surface ECG. We call it a concealed accessory pathway, but it can cause an SVT in the right situation. That is the second most common mechanism of SVT. The third most common mechanism of SVT, accounting for 5 to 7%, are what are known as atrial tachycardia. AVNRT and AVRT, which is the accessory pathway mediated tachycardia, both will respond to adenosine because one arm of the reentrant circuit is the AV node. That is why both will respond to adenosine. Whereas the atrial tachycardias are less likely to respond to adenosine, only some of them will respond. So when you have a SVT going on, it's a good bet to give adenosine because 90% of SVTs we expect to terminate with adenosine. They are either AVNRT or they are AVR. A small fraction, atrial tachycardias will trouble you, they won't terminate with adenosine. I can, but it would be better to have the picture of it. Let me see if I have it, because without showing the ECG, it doesn't make sense to just talk about it. Sure, I have. Okay. Maybe I can go on to right one. So it's connected. Already it's connected. Okay, so this is an example of a right bundle branch block. Okay, so the simple way for you to remember. So what is right bundle branch block? Is a either a complete block or a very slowing of conduction along the right bundle. So because of that, the right ventricle is going to get activated late because it has to go through the left bundle, and slowly from LV late it has to go and activate the right ventricle. So what are the main findings? I think this ECG you can focus on here. I think it's fairly okay for you to see. So here you can see two main things. One is there is a dominant R wave in V1. Usually you don't find that. If you take the contrast to the normal ECGs which I showed you, the wave in V1 is usually dominantly negative because V1 is a right-sided lead. You place it on the right of the sternum. Your big chamber or the powerful chamber is your left ventricle, the thick chamber. So most of the activation is going away from V1. Okay. So that's why normally your V1 is a dominantly negative QRS complex. In right bundle branch block, because the right bundle is blocked, the LV will get activated first, then very late the activation will come back towards the RV. So that will cause a late positivity in V1. We call it the R prime. So usually what you will find is you'll find a small R wave initially, then you will find a S, then you will find a R prime or a terminal R wave in V1. This is one thing for right bundle branch block. Similarly, the opposite will happen in the left-sided leads. So in right-sided leads, for example, in V1 as well as in AVR, you will find one terminal R wave or R prime. In the opposite way, in the left-sided leads, in V5, and you can see that better in this ECG here. In V5 and V6, what will happen is, because finally the last activation is going towards the RV, this side, the left-sided leads will record negative deflection, S wave. So you can find deep S waves in V5 and V6, which you'll again normally not find in a normal pattern. You'll find it mainly positive in V5 and V6. So two main things which you can remember for diagnosing RBBB. Number one, the QRS will be little broad because the conduction is delayed. Number two, terminal R wave or R prime in V1 and AVR. Number three, terminal S wave in left-sided leads, namely V5 and V6. With these three criteria, if you can remember, you can diagnose the right bundle branch block. Let's look at left bundle. So here you can see, probably this one you can focus. This is V1, V2, V3, V4, V5, V6. This is the left bundle branch block ECG. So here what's happening? The left bundle is blocked. So normally the left bundle ECG looks much more bizarre than right bundle, because normally the major appearance of the QRS is because of LV depolarization. The LV is the thick chamber as compared to the RV, much higher voltage. So the normal appearance of QRS in ECG is mainly because of LV activation, left ventricle activation. If that gets disrupted by left bundle branch block, the whole ECG becomes broad and bizarre. So here what's happening is that the LV is going to get activated much later towards the ends by slow activation from the RV. So what's going to happen is the right-sided leads are therefore going to record the very deep negative waves. So the QRS becomes broadened. The right-sided leads V1 and V2 become predominantly negative and broad. And the opposite happens in the left-sided leads, that is V5, V6, 1 and AVL. They become completely positive and very broad. Another thing, a little more nuance, which is important to diagnose left bundle branch block is, normally you will see a tiny R wave in V1 to start with, and a tiny Q wave in V5 and V6. That is a negative deflection to start. This is something known as the septal depolarization, which is a part of the normal activation. That gets disturbed in left bundle branch block. So you will have complete negativity in V1, no small R wave initially. You will have complete positivity in V5 and V6, no small Q wave initially. So these points again you can remember for LBBB. For any bundle branch block, look that the QRS is a little broad than normal because conduction has slowed down. One bundle is not conducting. Second thing, if it's a left bundle branch block, the V1, V2 became totally negative. The V5, V6, 1 AVL became totally positive. The initial R in V1 is lost. The initial Q in the left-sided leads is lost. So the first impression when you look at V1, if it's a dominant negative complex, initially think of LBBB, look at whether the rest of the criteria satisfy. If it's mainly a dominant positive R wave, terminal R wave in V1, think of RBBB, see if the rest of the criteria satisfy. Hope it was not too complicated to understand.
Give Omicron loading dose to children. Is it suggestible be given in atrial flutter and atrial filter? Usually I have seen in my experience.
So Amir, the question is, can you give amiodarone for AF or atrial flutter? Definitely you can, instead of cardioversion. So definitely you can give. So amiodarone, why you see it being used so often? Every time you'll see some arrhythmia, amiodarone. The reason for that is amiodarone is an extremely broad spectrum antiarrhythmic. So it has multiple mechanisms of actions. So it's like a big giant which you can use to crush most of the things. But with some exceptions. One of the things I showed you is prostans. So the good thing about amiodarone is that it has a very broad spectrum of action. You can use it for VT, you can use it for atrial tachycardia, atrial flutter, atrial fibrillation. Most of these arrhythmias it can help. There are certain disadvantages of amiodarone. Number one, it's rather slow acting. It's not like adenosine. Adenosine, you give a bolus, the STT will break. Many times you give, I mean, that's why we give a bolus, then we start on infusion. Many times you'll see after 6, 7, 8 hours, slowly the rhythm will come back to normal. So can we give amiodarone instead of cardioversion? It depends on the hemodynamic stability. So even AF can sometimes be unstable. So a patient comes with very rapid AF, heart rate is 180, 190. The patient is either hypotense or the patient is in gross heart failure, and you feel the AF is the reason why the patient has suddenly gone into heart failure. It's better to stop because amiodarone can take time. It's not a very rapidly acting agent. But on the other hand, if you feel okay, the patient has AF, but it's not so bad, and BP is okay, patient is clinically relatively okay, you don't want to shock, you can start with the amiodarone. You'll have to give an initial bolus, start with the infusion. Sometimes it may revert relatively faster in a few minutes, it may revert sometimes it will take a long time. We have another agent called ibutylite. It's called Fibricor. It's also a class 3 antiarrhythmic agent like amiodarone. We use it again. There are certain indications and contraindications you should be aware, but ibutylite is a very good agent in correct circumstances because it's much faster acting as compared to amiodarone. So we use it often for atrial fibrillation. Ibutylite, there is a certain special protocol you need to follow and certain special monitoring you need to do because ibutylite, or for that matter, any antiarrhythmic can be proarrhythmic. It can also trigger arrhythmias. So whenever you give an antiarrhythmic, make sure the patient is on monitoring. Somebody is watching the rhythm. And patient is not left unmonitored. So amiodarone you can give for a lot of arrhythmias, and if the patient is hemodynamically stable, it's reasonable to use it for atrial fibrillation of blood.
The cardiologist preferably they say cardioversion you could have been given instead of amiodarone first of all. This is the reason I just.
Yeah, I think that would totally depend on the clinical situation of the patient. But I think the good rule of thumb for you to remember is about stability. If the patient is unstable, then it's difficult to wait for drugs to act. All drugs will take some time to act. So in that situation, you want a sure shot therapy which works. And DC cardioversion again will terminate, most vast majority of arrhythmias. Whatever the arrhythmia is, you shock it 95, 97% of the time you're going to terminate it. The exceptions are some chronic atrial fibrillation, chronic atrial flutter. Even if you give a shock, it will either not terminate or it will briefly revert to sinus rhythm and immediately flip back into atrial fibrillation. Other than that, want a sure shot thing which works, DC shock. The disadvantages are traumatic, can be painful. You have to give some sedation, and again for the bystanders or relatives who are watching, also it's a little traumatic. So when you're giving DC shock, whenever possible, quickly sedate the patient, unless it's really a dire emergency. Patient has VTBF, he has collapsed, you don't have time to do anything. Just shock and get the patient out.
Thank you so much, sir, for your brief explanation regarding how to approach tachycardia. Now, everybody understood how to approach tachycardia patient? What sir told? We should panic? No. Then what we should do? Yes, we should not panic, and we should see the stability of a patient, and we should check manually. Then only we can inform to the doctor. Okay. Now onwards, we'll follow this one, and manually we'll check BP and pulse also. And thank you, sir, for your nice explanation, and give him a big round of applause. Thank you. Okay, for offline and online, anybody is having question? Charts? Yeah. So one more question. One more question.
मीन्स 5-6 years से उसको हाइपरटेंशन होता है, तो 5-6 years से हाइपरटेंशन है, बट 2 years से उनको मीन्स जो हार्ट बीट रहता है, तो कंप्लेनिंग है, हार्ट बीट रहता है बहुत ज़्यादा होता है, तो वो कभी कभी 1 hour के लिए भी रहता है, कभी 20 minutes में भी ठीक होता है, कभी 24 hours भी रहता है। तो उनका कंप्लेन है जब ऐसा बीट होता है उसको नोजिया होता है, वीकनेस होता है, गिडनेस होता है, बट बात कर सकते हैं, ही स्टेबल। तो एट ए टाइम उन्होंने कहा पल्स भी चेक किया, दैट इज ऑल्सो नॉर्मल, बीपी भी नॉर्मल ही है, तो सर वो हम टेकिकार्डिया बोल सकते हैं या फिर वो एट ए टाइम ईसीजी भी लिया, ईसीजी भी नॉर्मल है, इको एवरीथिंग, होल्टर टेस्ट एवरीथिंग नॉर्मल है, तो वो एटलीस्ट मीन्स क्या हो सकता है सर?
So, what she's describing is actually a common scenario we encounter in the OPD. So here we are moving to a different thing, because when we say tachyarrhythmias, I'm saying the diagnosis is not in doubt. You have seen the tachycardia. This is a patient coming with palpitations. Okay, palpitations, as you know, it's not the presence of a tachycardia. Palpitations is what the patient is feeling. He says, I feel my heart is racing, or it's uncomfortable, or whatever. So palpitations, there can be two possibilities. Either there is a true arrhythmia going on, or it's not an arrhythmia, but it's related to either anxiety or some other issues. And one of the important ways to differentiate that is to do exactly what she said. When the patient is having symptoms, try to get an ECG. When the patient is having symptoms. Why? Because arrhythmias can be intermittent. So if the patient had palpitations today morning from 8 to 8:30 a.m., now the patient is not actively having palpitations. You take an ECG, it's normal, it doesn't rule out an arrhythmia. You have to catch the event when it happens. So nowadays, thanks to post-COVID and also thanks to a lot of Fitbit and wearable sensors, a lot of patients are already doing that. They are saying, I had palpitations, I checked my pulse oximeter, the heart rate was 84. Or they will say, I looked at my Apple Watch at the time, it said atrial fibrillation. So yes, it's definitely possible. So there it is helpful, but again, I'll put a note of caution. Before relying on the machine, make sure you can see, can you counter check it. So sometimes if some patient comes to me and says, I had palpitations, at the time I took the pulse oximeter, the heart rate was showing 200, I say, did you take a video of the pulse oximeter? If you took it, can you show me? Because by looking at the waveforms on the pulse oximeter, you can be sure that it actually correctly diagnosed the heart rate, or whether there was some poor signal, the pulse oximeter got misled. Similarly, if they have some kind of a Fitbit or some kind of a watch ECG, I would actually want to see the strip and not just believe what the Apple Watch said. So in this particular case, if the patient recording was very correct, okay, if you can verify whichever way he took, whether he took a clinical pulse, whether he took a pulse oximeter, whether he took an ECG at that time, if you can actually see and verify that the rate and the rhythm is normal, then you can rule out a tachycardia. You can say, when you are having the symptoms, we have seen the ECG, we have seen the pulse oximeter, उसमें कुछ rhythm abnormality नहीं है, then you can say it is not a tachycardia. But if the recording was not done exactly when he was having symptoms, he had the symptoms, by the time he came to hospital, he was okay. At that time, he took the ECG, it was normal, we still cannot rule out a tachycardia. So here is where Holter monitoring is important. And nowadays we have these newer Holter recordings and patch monitors where you have the option to actually press a button or denote on your smartphone when you're having the symptoms. So that's very useful. So you put a patch monitor for 3 days, the patient can say, oh, now I'm having palpitations. He's going to press a button and it gets denoted on the Holter, and it takes a 15 seconds before that, 15 seconds after that. You can see exactly what happened when the patient had the palpitation. So it's important to correlate what is happening during the symptoms before you can diagnose. Is it actually a tachycardia? It is not a tachycardia. All right, thank you.
Thank you so much, sir. Now So now I would like to request Dr. Bharat Reddy sir to come forward and speak about primary angioplasty nursing perspective. He is a consultant and interventional cardiologist, and he finished his MD/DM in Amrita Institution of Medical Sciences, and he has been providing dedicated services from the past 7 years as a cardiologist and currently working as a consultant interventional cardiologist, and he is expertised in primary coronary angioplasty, coronary imaging, structural heart diseases, emergency cardiac care, and CT coronary angiography, balloon valvoplasty. And he awarded as gold medal during SSLC for the securing second in the district, seventh in the state. And secured in the second at the district is a Danvangier in the pre-university exam. And he's a part of heart transplantation team for the first TAVR program done in Amrut Institution of Medical Sciences in Kochi. Thank you, sir.
You all. Thank you for the warm introduction. So, being the lunchtime, I won't take a much longer. I'll be finishing it quick. 20 because it is a primary pre-say. The motive is quick in, quick out. So we'll be finishing the topic quickly. Okay. So basically, I'll be talking about primary pre-say, what it has to be done when the patient comes to the ER, what has to be done in the cath lab, and what has to be done in the ICU. So basically, 3 steps: ER, cath lab, and ICU. So basically in acute coronary syndrome, you can see this is a normal vessel where it is lumen is clear, no plaque. You can see that lumen is clear. So if there is a blockage, there will be cholesterol deposition and patient can have effort angina. In an ST elevation MI, where there is a blockage, there is a rupture of the blockage and that can causing thrombus and the flow to the artery is completely occluded. So it is something like this, where there is a cholesterol blockage, the blockage gets ruptured and there is a thrombus and there is a complete occlusion of the blood flow. So in unstable angina and non-ST elevation MI, there will be some flow. However, there won't be any complete occlusion. So ST elevation MI is a medical emergency. It has to be treated in time because the more you delay, that will translate into more mortality and morbidity to the patient. So in acute coronary syndrome, so basically you see three subsets. One is unstable angina, second is non-ST elevation MI, and third is ST elevation MI. In ST elevation MI, as already described, there will be plaque and the plaque gets ruptured, there will be thrombus and there will be complete occlusion of the blood flow. And here there will be ST elevation and troponin is elevated because of the muscle injury. So in non-ST elevation MI, there will be plaque rupture, there will be thrombus. However, there won't be an 100% occlusion, there will be some antegrade flow, but troponin is elevated because of subendocardial ischemia and injury. In unstable angina, there will be plaque rupture, there will be clot. However, the myocardium is not damaged, so troponin is not elevated. You see ECG changes. Basically, in unstable angina and non-ST elevation MI, you see ECG changes, no trop elevation in non-ST elevation MI and no non-elevation in unstable angina. So basically, when you look at the ECG, if at all you see a convex ST elevations in 2 leads beyond 1 millimeter, that is ST elevation with a history of chest pain. So once the patient comes to the ER with chest pain, what are the things you have to look for? So someone coming holding here, that means it is a chest pain. So usually we have the out of 10 patients, 5 patients come with a very typical chest pain. So other 5 will be having a non-specific symptoms or something like atypical presentation. Usually they can have some nausea, vomiting, diaphoresis, basically sweating, giddiness, falls. So some atypical presentation other than chest pain. So 50% of the patients can have such symptoms. So whenever the patient has chest pain or an atypical symptoms, within less than 5 minutes, the first thing it has to be done is take the vitals, do an ECG. That is the first thing that has to be done. So once you take the ECG, then you understand what it is, whether it is a heart-related thing or a non-heart related. If it's a heart-related thing, then you get a diagnosis whether it's a ST elevation MI or a non-ST elevation MI. So if it is an ST elevation MI, then you have to alert the entire ER team, the cardiologist, and the cath lab team. So first thing you'll be doing is you shift the patient to the P1 bed, so connect the patient to the monitor, connect to the defibrillator, because young patients can have a VTVF and the patient can just succumb in front of you with an VTVF with a cardiac arrest. So if at all you can defibrillate him in time, that you can save a life. Then secure IV cannula. So one cannula at least 18 gauge is mandatory. So if the patient is going for a primary PCA, two cannulas of 18 gauge is mandatory. So always make sure you secure the cannula on the left side, not on the right side, because we'll be doing the procedures on the right side. So if at all you don't get a cannula, don't waste much time. Call the help, take the help of the doctor in the ER, and you could secure a EJV. Or else sometimes even if EJV is cannot be secured, call the doctor and secure IJV. So cannula is important. Why? Because two things. Once the patient gets arrested, you have to do CPR, you have to achieve the ROS. How do you achieve ROS? One is mechanical compression, second is the pharmacological therapy that has to be delivered. You can deliver the pharmacological therapy only if at all you have an access. Once the patient gets arrested, you cannot secure the IV access. Why? Because patient will be in hypertension. Second, you will be under tremendous stress. Then the doctor will take a decision whether the patient is going for angioplasty or a thrombolysis. So then the plan will be taken whether the patient will be shifted to cath lab or the patient will be going thrombolysis in the ER. So, however, today's my topic of interest is primary PCA because that is a gold standard of therapy. So that is what I'll be discussing. So once the decision of angioplasty is taken, the loading doses are to be given as per the advice of the treating doctor. So the aspirin 325 mg and the T2 white was either ticagrelor or that is Brilinta or prasugrel or clopidogrel based upon the patient age, history of bleeding, risk of bleeding, that will be decided by the treating doctor. And parts preparation that has to be done mandatorily, both groins and both right wrist. Usually there will be delays at this point of junction because of the logistic reasons. So once we make a STEMI call, then with our therapy, our main aim is open the blood vessel. How do you want to open the blood vessel? So either you can give medicines, that is thrombolysis. However, the gold standard of therapy is primary PCA, where you go, put a wire, open the vessel. Either you can stunt, you may not stunt, but it has to be done quickly so that the myocardium, the muscle that has been damaged, is very limited, and you can secure the patient becoming unsick. So what is the importance of time window for STEMI reperfusion? Because we always, the doctors come to the ER and tells, please make it quick, please shift the patient fast, please hurry up. Why? You can see. So the 30-day mortality, there is a 51% increase in mortality if at all it is done within less than 90 minutes when compared to more than 150 minutes. That means if at all the therapy is delivered within 90 minutes, that is 1.5 hours, when compared to more than 2 hours, there will be a 50% difference whether the patient survives or the patient doesn't survive. So that is the difference. So that is why we are on our heels. Though we like it, we don't like it, we'll be behind you. Please make it quick. Please make it fast. So that translates into the mortality benefit, that is whether the patient is living or not. So that is the only thing that we are behind you. So make it quick. So I'm quite sure we have a very phenomenal time guidelines. Yesterday we did a primary PCI. The patient reported to ER by 2:25. Patient was out of cath lab by 3:05. Within 1 hour, patient came to ER, procedure done, shifted out of it. So we have such high standard of quality of care right now in our ER. So we do feel that this has to be translated into other hospitals across Medicover, so the standard of care has to be given uniformly, so that that is translates into the more benefit to the patient, and that brings a good vibe to the institute also. So basically, then coming to the loading doses. So if the patient is conscious, you can give the tablets as such. If the patient is say, drowsy or not so conscious, you have to secure a Riles tube, crush the tablet, mix it with water, and we have to give in the Riles tube. Or else you can give the tablets with a few sips of water. If it is a Brilinta 180 mg, if it is clopidogrel 300 to 600 mg based upon the operator's choice. If it is prasugrel, it is 60 mg. So aspirin 325 tablets, ideally achievable tablets to be given. However, because of non-availability, we give a entry coded tablet. So this one, either the patient, we can ask the patient to chew, or you can give the tablet as. Few operators do feel they can give heparin in ER, but few operators, they don't believe in giving heparin in ER. It all depends upon the doctor's choice. So once the loading doses are given, the parts preparation, so by both femorals and right radial, usually the choice of approach will be radial artery. So that is the choice of approach. However, in such certain sick patients where we cannot get a radial access, or we want to use a bigger size sheets, we go with a femoral approach. Or else, if at all the patient is too sick, then we may need to take a support device such as IABP or impeller. Then we may need to go with a femoral approach. So we need the parts prepared both radially and femorally. And make sure you are not securing, putting any cannula or doing any ABGs on the right radial. So as soon as you secure the cannula, you please draw the blood, 3 to 4 samples. You can take an extra sample and keep it if required. That can be used and send for all the routines. And if the patient is sick requiring oxygen, please do send a ABG. That adds tremendous value how the patient prognostication is done. So once we establish the diagnosis, once the decision has to be is made, then we have to deliver the message to the patient, patient and patient family. So this is very critical. Why? Because unlike a stable condition, here the patient has just walked in with a chest pain. So if at all you tell you have a heart attack, the patient will be usually in a denial mode. Either the patient or the patient family, they are quite denial. I am normal. I was absolutely okay. I played football yesterday morning. I went for a movie. I was okay. I just came in walking. I had some gas-like pain. So that is the usual conversation that do happen. Yes, the doctors do their part. The meanwhile, the nursing care also should be reassuring, should be soothing. There should be some empathy to the patient. So during this period of time, there will be discussion regarding the therapy with the patient family that has to be conveyed in a subtle way to the patient, so that the patient is prepared for that procedure. Then regarding the complications peritherapy, usually the doctors will discuss with the family. However, with the patient, we do always tell them you are okay. You will be reassuring them. However, we do always believe in a professional behavior from the nursing and paramedical staff with the patient and the patient family, because that takes an extra mile at that and that is how the patient family sees, because whether they are in secure hands or unsecure hands, it is all professionalism. It is more more off late, the hospital industry has become more of a hospitality industry. So there should be hospitality. Patient should be greeted with a smile. There should be some sympathy, there should be some empathy. If at all we can add those things into our care, standard of care, our care system becomes more standard. So nursing care pre-PCI, so before shifting the patient, if possible, height and weight can be taken. If not, at least you can ask them what is your height and weight. You can add, put in the case sheet. So if possible, why? Because the height and weight decides how much heparin we have to give. The height decides what is the curve of the catheter we have to use. Then history collection, if the patient was on any blood thinner or like antiplatelet or oral anticoagulation, any previous brain issues he had, those are the two brief things that is required. If at all you can add, if at all the doctor has not taken that history, this history will be helping the doctor. Once the patient is then we swiftly shift the patient to the cath lab with a defibrillator. So then the point comes to cath lab handing over. The patient is on the trolley. The people will be giving handing over. That is not how it has to be done. The patient is the priority. Attending the patient is the priority. If patient has to go on the cath lab, the draping has to be done. If required, the attending nurse has to be helped by the accompanying nurse who has come from the ER. But usually what happens is the accompanying nurse will be waiting to give the handing over. The other nurse will be running around, no help in the middle of the night. So patient is a priority. So whenever there is a cath lab handing over, it is the priority is not to giving the handing over. The priority is helping the patient to settle on the cath lab table, drape the patient, then the handing over happens. Handing over, usually we ask for very few things, whether antiplatelets given or not, what is the dose, whether heparin given in ER or not, what is the dose if given, what are the number, how many cannulas are there, 1, 2, are they working or not, whether consent taken, what was the food that was, when was the last meal the patient had. These are the 5 simple things that has to be given. So we don't want all the history. So we don't want when the patient had chest pain, because doctor would be already knowing. So these are the 5 quick things if you can put on paper, and or else if you write on a board. So that will be more than useful for the doctor to attend the patient whenever you are doing a primary research, because we don't want more details. Antiplatelets, what antiplatelet, how much, heparin, yes, no, cannulas working, not, consent, NBM. These are things. Then check the, once the patient comes into the cath lab, I make a rule that the patency of the IV cannula has to be checked, because there are certain times we had IV cannulas had been secured elsewhere. Once the patient, either during transportation or the patient is too flimsy, the cannulas are occluded. Once your patient becomes sick, you are giving emergency drugs and the drugs are not working. So always we check the patency of the cath lab once the patient is inside the cath lab before starting the procedure. Then once we do the angiogram, the rest you can give the handing over, take your time and give the handing over. So handing over is the last thing. Our thing is patient priority, patient safety, doing the procedure as quickly as possible, telling the critical handing over things. The rest of the handing over things can be happen at later point of time. That is the point of emphasis in this slide. So whenever you come for a handing over, you please make sure the points like antiplatelets, heparin, cannulas, consent, and VM. And that is important rather than the whole story of writing, signing, and other. Then coming to the primary angioplasty, this is the doctor's work where the artery is completely occluded. So we go radial or femorally, we open it with a stent, and we achieve the patency. Once it is done, then comes the, that is what the primary PCI is. So unlike the routine cases, these are emergency cases. So even doctors are not prepared, the nursing staff is not prepared, looking at what the anatomy is. Because based on the anatomy, you have to take the decisions whether it's a simple case, complex case, how sick the patient is going to behave. Because patient can suddenly become sick, so it is always good to have a second nurse to help the patient, the attending nurse. So there will be apprehension, anxiety, and fear with the patient and the family that has to be taken care. So as I told, off late it is more. We are moving into the 21st century. The hospitality care has to be amalgamated with the hospital care. So otherwise, the hospital, just hospital care won't be helping the patient and the patient family. So there should be empathy and sympathy towards the patient and to the family, and there should be total professionalism either from the doctor, the nurse, or the paramedical staff attending the patient. Then once the PCI is done, the patient is shifted to the ICU. So from here, it is all the routine. Check the vitals, check the ECG, take the ECG, because we want to see how is the ECG post PCI. So if at all the patient has any chest pain post PCI ECG, then we can reassess and compare. So then we have to, during the meanwhile, we can reassure the patient that everything is done, you are fine, because the word of reassurance takes a great help to the patient, that to soothe him, to calm him, that everything is fine, he is okay, and then he can talk to the family and so on and so forth. So nursing care of post PCI, basically we have 2 things that can happen, whether the patient becomes unconscious or the patient can become breathless. So or the BP falls. These are 3 things. So you have to be ready to and be prepared to deal these things. So because in the ICU, usually the patient nursing ratio is usually 1:3 or 1:4. If the patient becomes sick, so you need to have a code H. So I think I emphasized code H even in my last talk. So code H means code health. So this, you need not alert a code blue alarm. This is code H alarm, where you are alerting the ICU doctor, you are alerting your fellow nurse within the ICU, so that they all rush and help you when the patient becomes sick. This is something called as code H. If at all you can develop in cardiac ICU or non-cardiac ICU, this is going to be of help, and you can put a standard protocol of guidelines. With the patient in the cardiac ICU, the patient has a VTVF. What is the standard protocol, so that even the junior nurse or the junior staff that comes in, they can follow that protocol, and that becomes standard of practice across all the ICUs. It is not like each nurse is an expert in certain things. I'm not sure. I'm quite sure even doctors are expert in certain things. So if at all you put a standard protocol, the standard of therapy is same. So usually in ICU post procedure, you see only three things. One is the chest pain. Second is the is the VTVF. Third is the patient becomes unconscious. If you can deal these three things, you alert code H. One is the doctor of the ICU. Second, the nursing staff, the senior nursing staff, and two junior nursing staff. If they can attend the patient, the things are sorted very swiftly and they are sorted in a very methodical way. So the patient is on a defib. So if at all the patient has a VTVF, we know that a patient requires a cardioversion. And regarding the medicines, the doctor, I'm quite sure they'd be taking care of. I don't want to emphasize on the medication. So basically, then the routine PCI, post PCI care, the puncture site has to be monitored and managed. If it is a radial axis that has been taken, so inflation of the BP cuff has to be done, and put the pulse oximeter on the same limb, same arm. Otherwise, you can end up in ischemia, gangrene, and hematoma, and so on and so forth. Then femoral artery axis, the patient has to keep the leg immobilized for at least 12 to 18 hours. So encourage the patient to move the toes, encourage the patient to move the feet, so, but not at the groin. So inspect the groin every 15 minutes for first 2 hours, after which you can inspect for every half an hour or so. So if at all there is some hematoma, alert the doctor. You can keep a sandbag, but whenever you are keeping a sandbag, be sensitive, especially in elderly females. The patient can have vasovagal symptoms, especially patient starts with a yawning, then have a brady, then the patient suddenly becomes unresponsive. So whenever you see a patient yawning, who was already awake, that means that was the first sign of vasovagal attack that patient is going to have. Be alert, keep your atropine ready, give IV fluids. That is how you have to manage. Then coming to the hematoma, if at all you don't manage, patient can have a big hematoma, or the patient can have a pseudoaneurysm. So both can be treated, but however, we do want to avoid such complications. So I think already I discussed regarding the how to deal with the femoral axis. So where the third important part is when how to remove a femoral axis. So before removing a femoral axis, keep the patient NBM, keep IV fluid running, keep atropine ready, because you most usually you can have a vasovagal syncope. If at all patient has a hypotension brady, usual first sign is yawning that starts. Then the heart rate usually from 80 it goes to 70, 60, and suddenly blood pressure falls and the patient becomes unresponsive. If you see a yawning, run IV fluid. If the heart rate is coming down, you give atropine. Then and there, the things are settled, rather than patient sinking in and becoming difficult to manage the patient. So the vasovagal attack I already discussed about. So how to treat vasovagal attack? First is IV fluid, elevation of limbs, and atropine, and required inotrope. If the patient if the patient goes for an arrest, then the standard CPR protocol has to be followed. So then the arrhythmias. So have a watchful eye. I think Dr. Kumar Narayan has elaborately discussed with you how to see a VT, VF, LVVB, or NSVT. Basically, if at all you see a first ECG, if you see anything different than the first ECG, you alert the doctor. That's it. Second, if the heart rate is beyond 100, you please alert the doctor. That's it. So if the saturations are going down, you please alert the doctor. So meanwhile, you can, if you at all, you can put a code H in place. So you have a standard protocol, standard practices. So you can manage the patient yourself under the monitoring and vision of the doctor. So at the end, once the patient is fine, going home, always take a feedback. The feedback doesn't tell how we have treated. The feedback helps you in improving yourself, helping you, improving the system, helping you, the doctor to improve if at all there is something lacuna that has to be there. And always thank them for the feedback and for the services we have offered. So the cardiac catheterization or the cardiac primary PCI care is incomplete without the help of nursing care, incomplete without the help of the ER team, incomplete without the help of the cath lab team, incomplete without the help of anesthesia team. The doctor is just a part of the team. You have to believe, you have to see that you are the part of the primary PCI care. You are as equally important as the doctor in taking care of the patient, because the doctor comes and attends for 10 minutes, 15 minutes, 20 minutes, or a half an hour, if it is based on the consultant. It is you who are taking care of the patient day in, day out after primary PCI. So it is you who are spending. So if at all you can show the empathy and sympathy, that will translate into a more happy patient, a more satisfied patient, more healthy patient that we can come across. So use, and I would thank Team Medico nursing team for giving this opportunity, and today's World Heart Day. And use your heart to every heart to share nature, to preserve nature, to share humanity, and taking care of yourself and the family. Thank you. I would be happy to take any questions if there are. I believe I'm swift. 20 minutes.
So thank you, sir. It's really an informative session. So you have any queries, online and offline? So sir is ready to answer your questions. Anyone? If you are keeping silence means you understood the topic or you did not understood the topic. So no queries.
I won't be scolding.
Okay, fine. Yeah, thank you, sir. Thank you so much. So program is not going to be end. Still, we have 3 more sessions. But now I'm going to wind up for lunch break. So all will go for the lunch. So it's already 2 o'clock. We'll gather at sharp 2:30 p.m. here. Thank you. Good afternoon, everyone. So, can you please log in, everyone who is attending in online? So, within few minutes, we are going to start the session. So, a very good afternoon to everyone. So, we don't want to waste your time and our time also, right? It's going to delay. So, I would like to request next speaker, Dr. K. Sridhar sir. He's MTP, MIAP, and PD, GCR, and HOD, and consultant physiotherapist at Medicare Hospitals. He's going to take the session about cardiac rehabilitation.
Good afternoon, everyone. Had your lunch? No? Okay. Sleepy? Okay. I'll start the session. We'll discuss about the cardiac rehab program. We'll tell you the briefly about this one. Before this one, we have to what are the rehab program for this one? In cardiac rehab, main is to definition wise is a coordinated, multifaceted interventional design to optimize a cardiac patient's physical, psychological, and social functioning. In this one, we have to take the physical therapy and psychologically and social functioning of the patients has to be. We have to mention that one. Main our goals is to reduce the pathophysiology and psychological effects of the heart disease, limit the risk for the reinfraction and sudden death, and reverse the cardiac symptoms, reverse the atherosclerotic changes, reintegrate the heart disease patients into a successful functional status into their family and in the society also. What are the benefits for the cardiac rehab program? Main is to enable the patients to return to the activities of daily living. Ultimately, patients need that one only. Activities of daily living has to be improved and reduce the cardiovascular rate and mortality rate and improves the myocardial perfusion. In this one, in cardiac rehab program, the indications are these are the following indications, and this acute myocardial infarction, coronary artery bypass grafting, angioplasty, valve replacement, heart transplants, surgery involving the great vessels, congestive heart failure, and stable angina pectoris. In cardiac rehab program, we have the contraindications. Many of the contraindications also be there. Unstable angina and uncontrolled arrhythmias, and the systolic blood pressure greater than 200 and diastolic blood pressure greater than 100, and resting embolism, and moderate to severe aortic stenosis, and poorly uncontrolled hypertension, and patients will unwilling to exercise also. See, if the patient is not willing to do any exercise, it is also be a contraindicated for the patient. The main core components in this one, in the
cardiac rehab program, we have to mention the following things also. Patient-wise assessment we have to take in, and nutrition counseling to the patient, and weight management. What are the programs for the reduction of the weight, and blood pressure management, management, diabetic, tobacco cessation, and exercise training program, psychological activity counseling, physical activity counseling. With the great rehab program, we can drastically reduce the lipid profiles. That is, we have proved that one. Significantly reduction of the total cholesterol, LDL cholesterol, and triglycerides with the exercise, and it also improves the HDL cholesterol with the training. With the rehab program, we can drastically increase the blood flow to every part of the body also. Because with the regular exercise helps to keep arteries in the flexible states. Because of that one, the blood flow to the every part will be get increase, because of resulting the reduction of the blood BP. It is proved that after the cardiac rehab program, it is BP has to be reduced to minimum of 10 to 20 mmHg in hypertension patients. Along with that one, with the glucose intolerance means, if you take the rehab, that means exercise programs to the every patients, the insulin levels after training has been gradually lower down, because of sensitivity has increased with the what sensitivity, the insulin sensitivity at the cellular level has increased, so that the glucose level has decreased in serum glycerides also at the and fatty levels also. We'll start with the what are to be exercise to be done by for the rehab program. It's not more than that. Actually, cardiac rehab program has divided into 4 phases. Phase 1 at the hospital level, and phase 2 at the once discharge from the discharge time to up to 6 weeks, and phase 3 is 6 weeks to 8 weeks, and phase 4 is further than that one. We'll start with phase 1. In phase 1, it is up to in patient is in hospital level. That means 5 to 7 days is there. In this one, we have to stabilize the patients with what are the main components means by the medical evaluation, reassurance, and education of the patient, correction of the correction of cardiac misconception, and risk factor assessments, early individual mobilization, and then afterwards discharge planning. In the hospital levels, we have to set for certain goals only. These are main assessment of hemodynamic responses to the self-care patient, and progressive ambulation activities, determination of the effectiveness of the patient's medications in controlling abnormal responses to the activity, establishment of clinical data that will more helpful in patient's prognosis, and thus optimize the medical management. Early behavioral modifications and risk reduction along with the family education. These are the set of goals we have to set in the hospital level. These are the main criteria. Once the patient is in coronary care unit, then stabilize the patient, self-care evaluation, and monitor along with monitoring, ambulation has to be done, and low level exercise and discharge. These are the steps to slowly we can increase the patient's endurance and exercise program. In this one, start with the PROMs, that is passive range of motion exercises. Slowly upper limbs movement and lower limb activities has to be increased. Along with that one, ask the patient to do ankle 2 movements whenever he is in bed and free time, and make him to self-feeding and little bit orientation of program. Next to that one is, along with the above step 1 conditions, we have to take the leg dancing at the side of the bed. That means make the patients to sit in the side of the bed and do the leg movements. And then afterwards, it's come to the AAROM, that is active assisted ROM exercise. It means therapist or someone has to attenders has to assist the movements, upper limb movements and lower limb movements within the bed only. Then make them to slowly sit in into the chair, bedside commode we have provided, and light ADL activities, and make them patient to walk. After the step, we have to follow these stepwise only. Then the only patient will recover fast. Then with the minimal resistance, that means we can use the TheraBand exercise, the light TheraBand exercise we can use. Simple half kg, 1 kg dumbbells like that. With very small minimal exercise, we can do the patients along with, and we have to increase the sitting time and increase independent ADL activities of daily living, and walking for the more time. Then once the patient is reached the all 4 steps, then we can proceed to the next level. That is with the moderate resistance, doing activities of daily living, and he has to make him to sit for long time, and for the dinner or lunch time in sitting position only, and make make the patient to continuous education of the patient. Definitely it will improve the condition of the patient. Then along with the increased resistance, make the patients to slowly walk for more long time, and taking to the bathroom, stair climbings, and standing activities, standing ADL activities, and along with the group members and his family members eating something. Then 7th and 8th steps are the more related to the further steps. That means he has to come to the society, and he has to go mingle with the other people and do the activities what they are doing, and home exercise program also in this one included. In phase 2, once patient is discharged from the hospital, we have to take the phase 2. Where starts the phase 2. It is from up to 6 weeks is there. Main is components of this is to tell him to the health condition of the patient to attenders and himself also, and do it some exercise. Whatever the previously we were taught about 1, 2, 3 steps, we have to follow this one, then 4, 5 steps. And stress management like deep breathings and yoga, some little bit, somewhat what patient can do. Main goals is to improve and maintain the physical fitness, provide professional supervision for the exercise, continue with the educational and behavioral program. Same. In phase 2, the frequency has to be increased from first initially in a day more 1 or 2 times. Then we have to increase slowly to 3 to 4, 5 times a week. And intensity wise also we can do the activities with the resting heart rate plus 20 beats per minute. And that means we can up to 90 beats per minute like that. And his med values also reach the 4 levels. Means you can sit for long time also. Then it is main exercise is to up to 5 to 30 minutes with regular intervals. It is that means sitting for long time, standing activities, and ROM exercise and walking. Phase 3, it is from the 6th week onwards up to 12 weeks. Begins with the symptoms like exercise tolerance test. We conducted our levels. Physiotherapist has to do exercise tolerance test, and according to that exercise tolerance test, we target the exercise, and depending on the heart rate and everything, we'll regularize what therapist sorry, what patients has to do, what type of exercise he can continue with that one. In this also goals are the same thing. We have to improve. Ultimately, our goal is to improve our patients' physical activity, physical fitness. Continue the educational program and behavioral program also. In exercise training, three types of training will be there. That it means one is the steady state training. That means in this one, sustained activity where the workload and heart rate maintained at a constant submaximal intensity. That means patient is has to do his activity continuously for long time. That means example wise you can take long distance walking, jogging, stepping, and cycling. Second one is the interval training. That means we have to take rest in between the training sessions. Exercise followed by the rest intervals. That means that it is less demanding than the continuous. Highly incentive work can be achieved at there is a appropriate spacing and work relief intervals. Third one is circuit training. That means in this one we can in the name itself related to circuit wise. That means a series of exercise activities at the end of the last activity. Again, it will starts. Individual starts from the beginning and again move through the series. Improves all these to improve the strength and endurance by stressing both aerobic and anaerobic systems. For every activities, that means rehab program, exercise, warm up is to be necessary mainly to increase the muscle temperature. If they increase the muscle temperature means the oxygen need of oxygen to the muscular will be definitely increased, and muscle get more blood supply. And with this one, the dilatation of the capillaries will be happen, increase dilatation of the capillaries will be definitely increase the circulation, decrease susceptibility of the musculoskeletal system injury at increased flexibility. That means almost when the circulation is increased remains, the muscular systems will be relaxed in condition. In this one, same thing. We are in third phase, 3 to 4 times a week, and the heart rate has to 40 to 60% has to increase than the minimal, and up to he has to do the exercise up to 20 to 60 minutes. Warm up periods and cool down periods also be there. Main thing is aerobic exercise, endurance training exercise. Cool down period to prevent the pooling of the blood in the extremities by continuing to use muscle to maintain venous system. Is almost preventing the pooling of the blood is needed for the cool down period. Phase 4 is after that actually in after 12 weeks patient get fit to every do activity, can do any activities, and further precautions he has to continue his workouts, and he eat healthy foods, and he has to quit the smoking. In phase 4 also our goal is to he can maintain the self exercise level, long term behavioral modification he has to maintain, and it is no need of any supervision of by therapist or someone. Family members is necessary for them. And session is to up to per day is necessary, or one session per day or 3 to 4 days in a week. Slowly it has to increase to 30 to 60 minutes continuous workout. Like examples are dancing, hill walking, and resistance exercise with the theravents and heavy weights and everything. Thank you.
Thank you, sir, for informative session. Any queries? Online and offline? So we'll move on to the next session. I'm requesting Ms. Srilata ma'am, MST RD Chief Dietitian at Medicover Hospital. Yeah, sorry. So ma'am is a little bit delay. So we'll move on to the next session. So I request audience, any questions? Still we have done with CVD and pre-cat assessment, then approach to tachycardia and pre and post PTCA care and finally cardiac rehabilitation, right? So I hope most of my junior nurses got information about what is CVD, then what is the importance of BLS, ACLS to save person's life into the hospital, even out of the hospital also, right? Uh, even morning we have seen the mega code. So it's very fantastic. Yes or no? It's very fantastic and it's very informative role play to understand the importance of the BLS and ACLS, how it will work in our personal life and professional, and even like even we can save the any victim. If we will come to know that if person is unresponsive, that we can immediately act on BLS and we can immediately act on the ACLS who can be certified. Yes or no? So offline audience, from your end, any queries? Who are all sitting at Blue Planet? Do you have any queries? Now I'm requesting a Dozy company. Mr. Uma Mahesh and his team to take the session about the your device.
Hello, everyone. Yes. Hi, everyone. I'm Dr. Faraz. First of all, I thank you all for giving us an opportunity today to come and present about our device. So I'm the regional head for DOSI. I handle the states of Andhra and Telangana. So we are a health tech company based out of Bangalore. So we are into this remote patient monitoring space, and so we are in the and we are working with different companies, different hospitals like Apollo and etc. So here we are conducting also a demo at the different wards in the hospital. So today I would like to bring this concept in front of a larger audience so that you can get to know the importance of the remote patient monitoring. So first of all, why do we need this remote patient monitoring? As you all are aware, and even in the talks that we heard before the lunch, right, from the doctors we have heard. So I myself am a doctor. I understand, the things that the doctors were discussing. So especially in terms of the hemodynamic stability and the measurement of the BP and all those things, right, in for tachycardia patients, etc. So in all these cases, as doctor was mentioning that you need documentation. So he was mentioning that to take a snapshot of the vitals and all those things. So now, thanks to the innovations, right, the technology, the AI, and all those things, we have come up with such platforms where you don't need to do these things manually. So we have a system that will do the work for you, so that you can focus on the other things of, deciding the other treatment plans, right? So, so what is this device? So first of all, to give a little background as to why we, entered this space. So in India, if we see, there are about 2 million beds, hospital beds, if we see. So out of which the monitoring happens on only 1.5 million. That are the beds with the monitors. The remaining beds, so either they can comprise the beds of the wards and the non-monitored beds. So these are the places where the code blues they happen, right? Also in the wards. So I'm sure you must all agree. So when a bed is monitored, it is easy to find out when any such event is about to happen, right? So when, especially during the night time, when the nurses, they find it difficult, right, to go and monitor the patients, and especially the patients are asleep, they feel disturbed and angered by the continuous picking up for the monitoring of the patients. So there's a high possibility that during these times, the events can happen, right? So now to prevent these events, what do you do? Is you need to have a system in place wherein you can monitor the patient 24/7, right? Even remotely. So even when you are not near the patient, the device is doing the job for you. To put it in even a more funny way, you can actually monitor your patients from a different country. So that's how our device is designed. Okay, to go inside it. So why do we need and wherein all we can use? So there are different use cases that our device fits in. The first and foremost is now, as I told, the unmonitored section of beds, right? So unmonitored section of beds, now ICUs, we are not into ICUs because already ICUs has the entire, medical equipment, biomedical equipment where you need to see its utilization as well. So there are the other beds, so wherein our device will come in handy, especially at HDUs or wards, VIP rooms, right? And in these places, the monitors that are present. So normally, our device, to be precise, is not exactly a monitor. So it will monitor the vitals, but it is much more than that. So I'll come to the difference between how our device differentiates itself from the monitor. So these are the few places where our device can set in, like the HDUs, the step-down ICUs, VIP rooms, and infection wards. So why infectious wards? Because especially in infectious diseases, especially we have seen the COVID happening, right? So wherein we have seen how it was spreading, and not only in COVID, there are many other infectious diseases also. So wherein the patients are kept in the isolation rooms, right? So at all such places, the contact that happens, yeah, more frequently is by the nurses, right? Because you have to go in multiple times to collect the vitals or take samples or whatever it is. So all these things, if they can be reduced, right? If a machine is doing this for you, so this will enable your safety, right? This will help you be more safe and also get the job done. So, so as I was mentioning, why is DOSI important? The outside, why it is beyond ICU, right? So that is the explanation that I gave. That it will help you prevent. So there are multiple benefits that our device. So we in a moment we'll show you the device as well. So there are multiple benefits. So first is the clinical benefits. So if I talk about the clinical, so normally what happens is that now in hospitals in general, I'm talking about spot checks happen, right? But there are certain situations, especially when the patient is immunosuppressive, or in chemotherapy cases, or during transplant cases, where the immunity of the patient is compromised. In such cases, any event can happen at any point of time, right? So here, especially between the two spot checks, normally if you take 24-hour duration, right? Normally 4 to 6 times is what the spot check happens. So between that duration, what is happening with the patient? That data. Now this is the age of data, right? That we have information technology. The decisions are being made upon the data. Now, how to get this data is where we come in, right? So actually, being a doctor, this was also fascinating for me. So I was associated before with home care and all these companies, but when I came into this company, when I saw the scale of it being used, and it's really fascinating, and I'm sure you will also find it fascinating. So we are, so as I told, there are 20 lakh beds. So this is the main, story behind why we need devices. So actually, doctor before the lunch, he was mentioning about patch type devices, right? So wherein you can have that, especially during the tachycardia, to find out the rhythms and all those things. So all these, now this is the era of devices, IoT, which we call Internet of Things. So these are the devices which are very good, soon replacing many things. So among that is our device as well. So as I told, so these are the spot checks, right? So spot checks obviously have their limitations. So between the two durations, the deterioration of the patient cannot be, there's a chance of getting missed. And based on that, if you don't have the data, then, to take proper decisions will be hampered. So that's why we have introduced this device. So wherein actually you can see, Uma, show the device over there. So we have a device which works on the principle of ballistocardiography. So what is this ballistocardiography? So I'm sure you must all have heard about ECG, right? Electrocardiography. So ballistocardiography is also a technique that had come actually before ECG. So it had come by the era of 1885. ECG had come during 1905, 1907 at that time. But at that time, so what is this ballistocardiography? Ballistocardiography, it records the vibrations. So our body produces vibrations. Now there are multiple organs beating inside our body, right? Heart, the body movements, the respiratory movements, diaphragm movements, all those things. Even person turning on the bed. So what happens is that every valve that is beating inside produces micro vibrations. These micro vibrations, the recording of these micro vibrations and the working on that data is called as ballistocardiography. So at that time in 1885, when this ballistocardiography technique was introduced, it didn't click that much because at that time the AI was lagging. There was a lot of noise that was being captured, right? When it works on this principle of vibrations and sounds, there should be a technique wherein you remove all that excess sounds. So that was lacking at that time, and that is the reason the technique, didn't pick up much. And again, ECG came in 1905, and this technique became redundant. But thanks to the AI that is present now, and I'm sure you must have seen all very AI fiction movies, right? So how AI, so yeah, that might be a little exaggeration of the AI, but AI has its practical uses in many places. So we are able to identify, we have developed biomarkers. These biomarkers, what they do is that they identify the vibrations, the sound, the noise that is coming in from the heart, respiration, different places, and we process that data.
how that thing happens. So as you can see, there are the sensor sheets, so which go below the mattress. So this device, so there are two components to it. One is the bedside component, and one is a central monitoring component. So bedside component, as you can see, the person holding over there, this sheet, there are two sheets. So they have piezoelectric sensors inside it. These sheets, they record the micro vibration. They're so sensitive that even the heart valve opening and closing vibrations can be recorded from that sheet. So it goes below the mattress. The mattress thickness can be anything up to 18 inches. It can be water mattress, air mattress, ortho mattress, any mattress. And once the data is collected, there are two sheets. One is a thoracic, it goes in thoracic region. One is at the abdomen region, it goes. So after that, after the data is collected, there is a data pod that the person is showing over there. So that data pod is Wi-Fi enabled. So all the data that is being captured by that sheet is sent to that data pod. So from there, it goes to a server wherein we have algorithms. We have the AI doing its job, right? So that AI will process the data. So this will, the waves that you have seen, right? The PQRS wave. So it will be also similar to that, right? The BCG waves. So it is more of a sound wave, right? It is electric signals that you get in ECG. This is more of a sound wave. So that data that goes, will come back after processing it. It happens all in the matter of seconds. So the data going and then coming back. So there are centralized dashboards. That is the second component. So wherein the nurses will be able to see what is happening with the patient. I'll show you the dashboard in just a minute. So this is the total setup. So as you can see on the screen, so this is just a glimpse of dashboard. I'll show you the dashboard I have logged in. So as you can see, the sheet being placed right below the mattress. So these are the sensor sheets they collect, and we give different vitals. Now, what this? Okay, so why do we need? So let me tell you about a third-party study that we have done. Right, so we have installations in money at different places. Right, in all across Apollos, we have Continental in all these places, and many government organizations also we work with. So we have done a third-party study as an impact. As actual, is DOSI actually impacting, actually saving lives, or is just some story that we're making up? So this is what they have come up with. So as you can see, now if we calculate right on a general basis, the time taken for spot checks, right? Even if we take one to do one spot check, it can take around 6 to 8 minutes to have all the vitals that I'm going to show you. So now if you do that, multiplying that into 6 times, and again, for all the different patients, it comes up to a big, larger volume, right? So with the help of DOSI, we are able to reduce that to 80% less. We can reduce that by 80%. So you just need to spend 20% of the time that you are doing. Also, now one of the main use, also apart from that, vitals, is that it helps you transfer the patients right from the ICUs to the HDUs very quickly. Normally, the average length of stays in the ICUs is around 5 to 7 days, right? In major of the hospitals. So that is also a quality indicator, right? I have also done hospital administration, so a little bit of knowledge I have on that part as well. So that is also a quality indicator, right? So which hospitals try to reduce and try to maintain. So our device helps in that, right? So normally the patient becomes stable by around third day. But even then, the patients are kept in the ICU so that you can have extra monitoring and see things don't get out of hand, right, on the fourth and the fifth day. So what you can do, you can step down the patients after third day, and we were successful in reducing that average length of stay by 1.3. If it is 5 in 4.5 days, 3.5 days, you can step down. So for every 100 devices being used, we were able to save 144 lives. And the financial impact, obviously, you can see for every 100 devices, we were able to save, because again, that has all the other things. Now I'll not be going into the financial aspect. Let us focus more on the clinical aspect. So, okay. So different vitals. So what are the different vitals that you can get from this? There are two types. One is the contactless vitals that you get from the sheet that was shown just now. So the other are the accessory. Now every device has its limitations, right? Every device cannot do everything. So the contactless vitals that you get, the heart rate, respiration, and for the first time in the world, we have developed something called as contactless blood pressure. So this contactless blood pressure, you don't need any cuff, you don't need any apparatus. You just put the device, you will get it from that sheet itself. So this is our patent, the first of its kind in the entire world, actually. So apart from that, you get heart rate variability, stress levels, sleep-related all parameters, apnea, hypopnea index, and snoring index, duration of sleep, episodes, REM, all these things you get from that. Now, there are accessories also that we provide, since our device obviously cannot do everything that it has. We provide temperature. We provide NIBP also as an option. So wherein, an oxygen saturation, and we have ECG as well. So I'm going to show you a roadmap. For current, what we do is that we give a 12-lead ECG. So wherein you can have that ECG. So basically our device, you can see that by now, I'm sure you can tell that, it is a place where you can have all the data, right? So because this is covering almost everything, right? Except from, okay, PCO2 and all that, I agree. That's not here. But apart from that, everything, you are getting over here for a fraction of cost, right? So here, we have 12-lead ECG as well. So especially during, in hospitals, 12-lead ECG is more required. At home, you can use single-lead ECG or a patch. But here, since as doctor was also mentioning, right, especially during arrhythmias and tachycardias and all that, you need to see the rhythm, right? So in that cases, you can use this thing. So these are different vitals. So the waves, they look similar like this. So this is how the waves they look like. So as you can see, there is no much difference, right? So like how you see the PQRS waves of the ECG, so similarly it is also it comes in that way as well. So there is one more thing to this system, that is so in hospitals you do mu scoring, right? Mu scoring you do. So that is normally done manually, and it is a time-taking process. So what we have done is we are able to automate that. Since you're getting everything over here, the mu scoring is like a combination of all the vitals, and then you get a score based on that, wherein you can triage the patient, right? High risk, moderate risk, low risk, and based on that. So we are doing that work for you. So that is one way by which you can get the alerts, right? The mu scoring. The other thing is we have conditional alerts. So I'll show these alerts also in a quick look in the dashboard. So how these alerts work, I'll let you know. So actually these alerts, we have multiple stories, wherein we have saved many lives, right? Especially, let me tell you one incident in Apollo Hyderabad, wherein we placed our devices. So on the first day itself, there were certain alerts that were coming in, right, for a drop of the SpO2. Now the patient was, according to the hospital, the patient was fine. The patient was post-op, and the patient was shifted to the ward, and everything was okay, supposedly. But this drop that happened, right, it took the patient, into a critical situation. So then and again, even it was cross-checked by the hospital, and it was found to be accurate, and then proper care was given. So we have like that multiple stories wherein we have saved the lives of mothers at home who are living alone, right? Especially their children outside. So there are multiple stories of our success. So we also give reports on a daily basis. Since now this charting also that you do, right? The nurses especially, they do this charting, right? You have charting, okay, kaun sa time pe kitna vital tha. So all these things will be done automatic, right? So you don't need to do anything. There'll be a charting being done. You'll be getting a ward report. So all these things will be done automatically by the device. You just need to put it over there and start using it. That's all. So yes, so where and all you can use. So these are all the places where you can use. So you can use in general wards, VIPs, HTUs, right? So that is the overall how it works, right? It collects the data, it goes to Dosi AI, and then it comes back to the dashboards. So here there is one more thing called as command centers. Now once you start automating things, right? There will be alerts coming in. And now you might question, okay, do we have to keep running for all these alerts? And yes, so now the point is, how do you tackle this thing? So we have the concept of command centers.
So this command center can be either run by the hospital itself, or we can also do that for the hospitals. So here at the command centers, we have certain doctors and so watching the alerts that coming in, and we create an escalation matrix. So based on which these alerts are escalated to the hospital, to the nurses, and based on their action, the alerts can be switched off. Like if you have taken an action after an alert has come, so that thing can be switched off, right? So that is the command centers. These command centers can be at different level. It can be at the city level or state level, right? You can have a central command. Like Medicover has many branches, right? So we can you can have your Hyderabad this thing at level, and also at different city level in the top management can have an overall view of what is happening. So these are all the hospitals we are present at all these places. And yeah, so yeah, one more case study, right, before going on. So this is in IGGMC Nagpur. Actually, this was our first installation in Nagpur. And here we have been using devices, and as you can see, the letter that is signed. So we were successful, in doing 800 plus successful ICU transfers, especially, preventing code blues and all those things. So that is how our device can save the lives of the patients. So we are also working with the army hospitals, so across the country. So this is just a glimpse of different people talking about different nurses and yeah. So the last thing is that the home care. So apart from the hospital, the other place that is required is home, right? Normally, you all might agree with me that once you put in a lot of work, right, for getting the patient onto the heels. Sometimes they go home, they collapse, right, and they come back. So that is a saddening part, not only for the patient party but also for the healthcare providers, right? I myself being a healthcare provider, if a patient goes back and comes back again, so that is something that we all want to prevent, so that a patient can also have a healthy life and lead a happy life. So how to do this? We have a solution. Like, we have a device. This is a home care device, right? So you can put this at the home. You can monitor your loved ones at the home. There are applications as well. So at doctor level access and patient level access. So multiple accesses are there. So wherein you can monitor, and you can call the patients if there is any. So actually, it creates something called as the health cards, right? So so health cards, if the patient vitals. So how that device functions in home is that, so it studies the patient for 4 to 5 days. So after studying, it creates a baseline. Okay, this is the daily range of the heart rate that the patient's heart rate is moving into. So based on, if the vitals go out of that baseline, then the health cards are generated. So if the vitals are going out of the range for 1 day or 3 days or 5 days, based on the red, orange, and yellow, so then this will help you triage also, right? Especially in home care departments, right? So I feel there is also home care also for medical, right? So you can triage the patients based on that, and you can call the patients back to the hospital based on the cards. So that's about the device. So yeah, one last thing before showing the dashboard and before wrapping up the things. So this is a product dashboard. So we have launched NCBP, as I told you, this non-contact blood pressure. This is the first of its kind in the world. So then we are coming up with a patch also, integrated patch. So wherein you will also, now we have 12 lead ECG. That will be a patch-based system also. Now, not all hospitals prefer 12 lead ECG, right? So we are also coming up with an patch-based ECG as well. Smartwatch, integrated glucometer by December. And we are getting a new type of computing that will be even more faster by March. And we are working also on the HF. We are doing studies with AIIMS and different institutes. So, and also sleep apnea, as I told, right? So we still have, it's in beta phase. We are doing certain studies, right? So actually our sleep apnea can be compared with the type 3 polysomnography. So the type 3 that is done at home, right? So based on that, you can compare, and it will give you the scoring and everything. So based on that, you can take a call. So before wrapping up, I'll show you the dashboard as to how it looks. Yes. So this is the dashboard. Now, this dashboard, there are two things. So we also integrate with the hospital systems, HIMS. So not all hospitals would want to use a dashboard. They can have their own dashboards as well. So this is the first page that you will see, wherein you will get the overview of all the wards. Now, this can be ward-based. For top management, it can be hospital-based. So that classification can be done here. Now, if I click on this, so you can see, I have clicked on all patients, okay? Ward-based also you can see. So this is the depot dashboard. So you can see the patient name, ID, bed number, due score, which is nothing but the mu score. Based on that, the triaging and the categorization of the patients can be done. Heart rate, respiration, SpO2, NIBP, and temperature. These are the first snapshot that you get when you open the, when you go inside that. And when you want even more, deuce is mu score, right? Yeah. So based on this, if you want even more detailed analysis, you just need to click on the patient's name. So wherein you will get charting like this. So you can see all charting, right? You can take the mouse pointer over here and you can see what was the patient's condition during night time, and you can see the different graphs being made, right? So this entire work is being done automatically, right? So that is the thing. And yeah, even post discharge also, we because according to the rules, also the data needs to be with the hospital for a period of 5 years for medical legal, all these cases, right? So yeah, this will be integrated and this will stay for 5 to 7 until you discuss. So that is the alerts. Now I was talking about alerts. Let me show it from here. So as I told, there are two types of alerts based on, as you can see, the dues over there. So based on that, the coloring will come. If it's a high risk patient, it will be in the red, orange, and yellow is. And the other type of alert is, yes, this is the conditional alert. So wherein you can now every patient, for every patient, the vitals are different, right? For me, a heart rate of 100 might be normal. For the other patient, it might not be normal. So you don't want all that alert fatigue, right? For so you can customize your own alerts. So based on which the alerts, these alerts, they go in the form of an SMS, right? SMS. They also come in the form of calls. They also come in the form of emails. So when it is a integrated one, it also comes in the form of a webhook based alerts as well. So yeah. So there'll be an alarm that will come up if you have a speaker. If the alarm will come up, or else there will be. You can also see. You can see the history of all the alerts also over here. Go on the alert section, you can see the history of all the alerts that have happened for all the previous patients. So you'll have a record, right? Like doctor was mentioning before, you need a snapshot of what has happened, why something has happened, right? Especially during when the patient has, tachycardia or something, yeah, deteriorated and all those things, you need a snapshot. So you'll get everything over here as to what was that particular condition that led to the deterioration of a particular patient. So this is about all those things that we have. So we are doing a demo over here. So I request you all to take time, and we are at different wards and second floor and third floor. So I request you all to have a look at that, and we would love to have your feedback. Thank you so much for giving us an opportunity to come and present a product. Thank you.
Thank you so much, sir. Now we'll move on to the last session. Now I'm requesting Ms. Srilata ma'am, MST RD Chief Dietitian at Medicare Hospitals.
Good afternoon, everybody. Post lunch, most of you are sleepy, I understand, but don't sleep for my class. Hi, madam. How are you? Good afternoon. And thank you so much for giving me this opportunity. ठीक है ना? So, what all the classes you have learned or the lessons you have learned since morning? Let's fresh up before you guys sleep deeply at different angles like this. I've seen few faces, so I'm saying that's what I was standing here first of all. I have a pic of them who was sleeping. I will share it in Madhapur operation. Huh? नहीं operations में करते हैं. Next time there will not be chairs so that you'll stand and listen. Good idea, no? Yeah. So one of you all can please, juniors can stand and let us know what you have learned since morning. Nobody has learned anything. अरे next time इन लोगों को NBM रख के class दे दो ना please. Or keep them on clear liquid so that they will be active through the day. Okay. Okay. हेमंत वो that's troubling हेमंत देखो ना. Wrong password नहीं कल भी ऐसे ही हुआ है. It is taking only Dr. Pragati ma'am. So, yeah. So, can anybody tell me about cardiovascular diseases, coronary artery diseases, so that we are awake for some time? Anybody for that matter. It keeps you awake. Nobody knows. No punishment, yeah, poor thing. They'll write imposition. My girls know it. Madam will give 50 times imposition. So nobody wants to say, GB and Miss Swati, please remember these two. Okay, they are going to write 50 times, all the participants. ठीक है ना? It's okay. They don't want to say. Don't want to say. Anybody from heart failure clinic or who deal with heart failure over here? Anybody who's from CTICU? No, imposition they will write so that it will be imprinted in. That's what okay, let us all stand for 1-2 minutes. Everything. Yes. Yeah, Mr. Sridhar will tell us like some stretches so that you all will get energized, so that you will understand and tell me the basic answers. Please be honest. All of you lift your hands. What she said is correct. नहीं अभी तुम खोलो ना जो है.
Thank you for your attention and a very great physical activity. Yeah. Thank you, Mr. Sridhar, for that. So I was given a topic about nutritional management in cardiac diseases, but I will be focusing only on two diseases because of lack of time. Fine. It's a really laborious talk. So I would try to wind up very quickly. ठीक है ना? Since morning you have been listening about coronary artery disease. So I wouldn't throw light on all these. So you pretty well know about all these things, right? I would directly go into dietary management of cardiac ailments. So mostly these cardiac patients, you have to set certain goals for their progression. Okay. If you don't have those goals, they deteriorate very quickly. So most important is to have a healthy body weight. How many of us have healthy body weight? Either we are underweight, overweight, or obese. So we should have ideal body weight, that is your height in centimeters minus 100. We are Asian Indians, so we have to do it 104. Centimeters minus 104. When it comes to patients suffering from diabetes with cardiac ailment, it will become more stringent that weight management is important for glycemic control as well as lowering the lipids and maintaining a healthy heart. Because as your weight goes on, your workload on the heart increases. So it becomes mandatory. So you have to keep your lipid profile under control. Can anybody tell me what are the parameters you have in lipid profile? You are in COVID, dear. Lactose dehydrogenase, it is lactose dehydrogenase, LDH. LDL, HDL, serum triglycerides. Guys, you have to wake up. Total cholesterol, yes. Triglycerides, total cholesterol, HDL, LDL, VLDL, HDL ratio. Guys, you have to learn a lot. Okay. Once if the patient is having a cardiac ailment along with that hypertension, they have to keep the blood pressures under control. They should be always physically active and they have to avoid substance abuse. What are the substance abuses? Yes, tobacco, alcohol. Substance abuse could be smokeless tobacco and smoking tobacco. Smokeless is your gutka, pan, and all those things, right? Tambaku, and most of them use snuff in their nostrils. So these are substance abuses. They cause vasoconstriction. Okay, that increases the workload on the heart. So you should be very careful. Do not have any substance abuse. Fine. And again, your smoking is very injurious. And alcohol again is very bad. We'll talk about it in further slide. So we all know about the treatment and complications which already have been dealt and symptoms of heart failure also. So when you have any patient suffering from heart failure, how do they look like? Just like us? Is there any difference? In terms of what? They have shortness of breath, lethargy, weakness, edematous, malaise. So they are not like us, right? They are physically very low. Their activity is very minimal. So all what we need to do is we have to aim at reducing the workload on the heart. That is most important in terms of physical activity, in terms of dietary management even. Okay, to reduce breathlessness is to take appropriate drugs to reduce the overload, pulmonary edema or fluid edema, whatever it is, you have to reduce in that way and put them on diuretics, ठीक है ना? And take proper diet therapy and drug therapy because most of them land up with cachexia. Cachexia is a condition wherein you have skin, very thin skin and bones. Usually you have cardiac cachexia and cancer cachexia. They end up having underweight, malnutrition. So this is most important. So any weight loss you have to manage. Give them a very good diet in terms of calories, in terms of protein, vitamins, and minerals. Okay. So regular follow-ups for heart failure patients is very, very mandatory, including the family and patients should have a thorough nutritional education. We have to screen the overall nutritional status of a patient and we have to improve the quality of life and whatever the disease severity symptoms, we have to lower them. Most important thing, if they have the severe symptoms, they need frequent hospitalization and then end up with bankruptcy. They will not have money for transplant even. So you should avoid infections, fluid overload, and anything related to the trauma to the chest or to the lungs. And most important is the dietary approach. You can manage easily the heart failure patients or the coronary artery disease patients with your diet itself. Okay, but there's a way how stringent the patient is following. So most often you have your Mediterranean diet and your DASH diet. Mediterranean diet includes whole grain cereals and millets, your legumes, beans, fruits, nuts. This is something very close to nature. Okay, it includes extra virgin oil, olive oil. It will not allow no other oils except this extra virgin oil. Okay, how many of you use olive oil for cooking? So it should not be used for cooking. It should be used for dressing. Okay. You cannot subject it to high temperatures. Okay. Because the smoke point is very less for olive oil. So these Mediterranean diets will be mostly raw food. So you can dress it up. That's how it is. Fine. Seafood is always good, but you all should know which seafood is good. Do you all know that seafood is rich in cholesterol? Which food is that? Prawns, shrimps, crabs, lobsters. These are very, very high in cholesterol. So we should know about it. Most of us think that seafood is always ideal, but no. It is fish, especially your fatty fishes, which are in your deep water. Fine. So again, poultry are allowed. Cheese again is allowed, but as a dietitian, I don't encourage cheese, butter, or anything like that because it has too much of fat, saturated fat. It has good amounts of cholesterol, which is very high in calorie. Okay. So patients who are already obese, suffering from diabetes, hypertension, and cheese also has salt. So I don't think any patient suffering from diseases should have cheese. Okay. Patients who are severely malnourished, cachexic, cardiac cancer patients can be taken because in small amounts they would get large amounts of protein as well as calories and fat which they are in need of. Okay. DASH diet is nothing but dietary approach to stop hypertension. Okay, it's an ideal way to control hypertension. You all know India is in which rank in hypertension in the world? Are we first or second? First. Okay. In diabetes, we are second. So the reason for this, Indians consume around 12 to 16 grams of salt every day. The recommendation for salt is 5 grams. But we overdo. That is the reason why we are capital for hypertension in the world. You all know how do we eat? apadalu, vadiyalu, jadi pacholu, all these sauces, ketchup. We don't spare any food from any part of the world. We eat foods of across the world, which are salty in nature. Fine. So DASH diet is something which is really good for non-hypertensive as well as hypertensive, because you can see that it will be very good source of potassium, an important mineral for your cardiac activity and muscle activity. And it has loads of fruits and vegetables which are rich in antioxidants. You will not have inflammation in the body. Once you take good amounts of antioxidants, the free radical damage will be lowered, or at a point of time it will be stopped. So your inflammation in the body is not there. If you have inflammation, you will end up with diabetes, hypertension, strokes, and may also cancer. So the most important is to stop inflammation in the body. So that's how you get good amounts of vegetables and fruits. Nuts and legumes are good source of protein and fiber as well. Whole grain cereals again are rich source of carbohydrate, moderate source of protein, and a very good source of fiber. Fish is an excellent source of omega-3 fatty acid, which is a heart friendly. Okay. If you think of this diet, it provides a synergistic effect of different foods. Okay. More or less, you will have same effect, all positive effect. There's no single nutrient which is going to disturb your functioning. Everything has a very good benefit. It provides a very good nutrients in terms of macro and micro. Okay. Will be low in sodium and cholesterol. I wouldn't go in depth. Okay. So medical nutrition therapy, you all understand drug therapy. A number of times I tell medical nutrition therapy is your simple hospital diet. Is most important. Never neglect any patient when it comes to food. Please convince them, request them, and make them to eat food which is served. Okay. So MNT for cardiac ailments is, it depends upon the individual. Diet is always tailor made. Yes, I cannot wear anybody's dress, right? Because my measurements are different. So, as your food intake measurements are according to your clinical condition, according to your BMI, and various other factors. So, most important is nutrition is tailor made. Fine. The patient may have edema, he may have SOB, he may have existing pre-comorbid conditions, and body weight and nutritional status, whether it's deficit of macronutrients or micronutrients or obese, we have no clue. So it is all individualized. To reduce the workload on the heart, you have to give small, frequent meals which are easily digested. One thing we need to understand, heart failure patients will be having fluid restriction. So you cannot give them liquids just because they get absorbed into the gut quickly. So it should be more or less in a semi-solid consistency or in a soft diet so that they easily digest. If you give them a heavy, large meal, they wouldn't digest it quickly as we do. Okay, because their movement is very less and they cannot sit for long hours like us. They may sit only half an hour or not more than that. So you should be very careful with heart failure patients. So consistency of diet may vary depending upon the tolerance of the patient. High potassium may be required for patients who are on potassium sparing drugs. Oh, can you name me any of the diuretics which are potassium sparing? Hmm? Aldactone. Hmm. Okay, you go with the brand name. Okay. I go with the composition name. Okay. So what it does is, along with the water, sodium, it leaches out the potassium. Potassium is important for us, right? So we should have adequate supplementation of it, around 3,600 milligrams per day. Okay. So choose a fiber-rich whole grains. Most important thing. We all eat white rice 2 to 3 meals, right? How many of you eat ragi every day? Jowar, bajra, foxtail millet, quinoa? Oh, occasionally. Paurnami Amavasya. Okay. So see, where are we standing? Understand in terms of nutrition. We are much behind. We all know what are cereals and millets, which is really good, but still we are not putting it in practice. So we all should understand that start it from dinner itself today. Okay. Try to replace your simple sugars or your simple carbohydrate with a very good complex carbohydrate. Okay. A variety of fruits and vegetables in diet. How many of you eat everyday salad and fruit? Salad? Okay. See, all sometimes, sometimes. Occasional, occasional. So please cultivate good habits. Okay. Okay. I will get Mr. Ranjan to teach us about because I'm not into catering. Yeah, good. So you should focus on a fat-free milk. Anybody over here uses a 0% fat milk or a double toned or a fat-free milk, skim milk? Oh, good. So it has every nutrient which milk should have except fat. Because already we are not loaded with fat. Somebody's fat is under the skin, somebody's fat is under the visceral organs, somebody's fat is in the blood lipids. Okay, few fats are hidden, few are not here hidden. You should be very careful with the fat. Okay, anybody who drinks 4 cups of tea coffee over here? Yeah, try to cut down 1 or 2 cups per day. Otherwise, you can choose black tea, black coffee, green tea, green coffee. Okay, how many of you are non-vegetarians here? ऐसे उठाते भाई हाथ ऐसे क्या कर रहे हो हाँ. Yeah, good. Quite number of non-vegetarians. How many of you are every week you take meat consumers, red meat, keema, mutton? Okay. Chickenitarians? Oh, all chicketarians. Okay, good. How many of you eat skinless chicken? Okay. How many of you eat country fowl chicken? Okay, country fowl chicken. So anybody can focus the difference between a country fowl and a poultry farm raised chicken? Oh, no, no, no. I mean pure in terms of nutrition, not taste wise, texture wise. See, when you take a country fowl chicken, the body size after you defeather it is very small. If you take a broiler or a layer or anything, it's so huge. What does that mean? That poultry farm fowls are weak. Okay, that country fowl is something like an athlete who has good amounts of mass, protein mass, who keeps running and doing exercise. So there's a difference, right? So always choose a country fowl if available. Okay. Don't go with the fowls which are raised in poultry farm again. The feathers are dark, so you don't pick it up. It should be having more of muscle mass and no fat mass. Okay, that should be again taken without skin. Okay, how many of you eat fish? Weekly once or twice? Susan Chechi, because she's a Kerala. Okay. Once, that's good. Try to again adopt this habit of eating fish, especially salmon, trout, tuna, herring. Okay, these are deep water fishes. They will have loads of omega-3 fatty acids. Okay, especially a very good source for pregnant women. Any pregnant nurse over here? Okay. For the brain development of the fetus, for the retina development, and for the immune system, it is excellent source. Okay. Choose poultry without skin and prepare healthy ways. Most of you eat chicken fried, chicken tandoor, chicken KFC, Kentucky, rice, fried rice. Okay. So please, that is occasional. If you are slim and fit, you can take it again occasionally. If you are lazy and not following healthy diets, please stay away from that. Okay. When you take red meat, it should be lean cuts. It should be light pink in color. It cannot be dark red or it cannot have thick layers of fat. It means that it is a matured meat. It has loads of saturated fat and also cholesterol. It would be very high in calorie even. Okay. The protein content in the muscle also will be depleted. The protein is replaced by fat. So we should be very careful when you go to a butcher's shop. And most important, we all are carbs eater, right? This much of rice, when it is tiffin box, it is small. At home, we eat large, right? So try to cut down your portion size. When it comes to the cardiac patients, they cannot eat more. The obese have to reduce the calories. The diabetics have to have the portion control. Fine. So most important is taking cereals and millets into diet is really important, which adds to multiple vitamins, minerals, essential fatty acids, and a very good source of complex carbohydrates and moderate source of protein. Okay. So once if you look at those, they are very husky, they are dark in color, right? They are not easily digestible. But when you see a white rice, it is very beautiful, slim, trim, and easily digested and yummy to taste. That's how it becomes a white poison. Okay. In limited portions, rice is never bad. Remember this, whether it's a diabetic, cardiac, cancer, or any patient, rice is never bad. But the processing and the quantity makes it bad. Legumes or pulses are excellent sources of protein, vitamins, minerals, and fiber. So you should include different varieties. How many of you eat all those colors of pulses and grams? So try to incorporate them. Fine. Usually, most of us eat them in split form, like your black gram dal, right? There's black gram whole. Dal makhani, anybody prepares here? Dal makhani? No North Indians? Okay. Dal makhani is a very good recipe. Nalla minumulto chestar, right? Thank you. So soya beans, double beans, kidney beans, chola, rajma, lobia, all these different kinds of beans have good amounts of antioxidants. Look at the colors. They provide you good amounts of antioxidants. And all the dark colors, orange, yellow color will provide you beta carotene. Okay. And this sort of pulses, a vegetable, protein, all of you listen carefully. Chatter matter, stop. Okay. So Miss Valli, that's the door. Okay. So vegetable proteins lower the acidity of the blood. Remember, patients respiratory failure, kidney failure will have acidosis. So if you take plant-based proteins, that lowers the acidity. Right? We give them soda bicarb tablets. How many of you know? Soda, nodosis, nocidos, water sobosis, all these, right? So instead of giving those drugs, if you take good amounts of plant-based proteins, you wouldn't require those soda supplements. Okay, na? You all should understand and know it. When somebody falls sick, Srila Takka, they will come running to me. You all should listen to such classes and learn a lot. Okay, na? So protein is important for cardiac patients. Post surgery, they would require up to 1.5 grams. CABG, you have to open the sternum. There's wear and tear of the tissue. There should be wound healing. There should not be any infections. So there is a graft on the leg even. So both the places it should be healed. So proteins play an important role in terms of soups, dals, or any stuffed paratas or cutlets or anything can be prepared. Your sprouts or boiled grams. Vegetables and fruits are excellent source of vitamins, minerals, antioxidants, and fiber. So more fruits and vegetables will keep your pressures under control. But the sugars go high with fruits. So if a diabetic patient is there, only a small fruit should be there. That too seasonal. It should be locally available. It should be fresh as whole as such. It can't be a fruit juice because that is going to increase the blood sugars. So milk and milk products are excellent source of calcium, vitamin D, protein, riboflavin, but you have to choose a fat-free or a skim milk. Okay, so that will be lowering the what do you call compiling of cholesterol and saturated fats. Okay, vitamin A is important for your eyes, skin, and your immune system. Okay, riboflavin for many bodily processes. So nuts and oil seeds are excellent source of monounsaturated fatty acids and omega-3 fatty acids. So walnut is excellent. The shape itself shows that it's related to brain. So pediatric population, somebody who is pregnant and lactating would every day require at least 2 walnuts. Okay. Again, we also would require because it is a source of omega-3 fatty acids. So flax seeds again are really economical. You all can buy it. Of course, walnut is very costly. Almonds are costly too. But flax seeds, chia seeds, everybody can afford. So if you try incorporate using them, 1 teaspoon every day, each of it would be of a great benefit. Do not make into any preparations, or you don't need to buy oils. Again, they're expensive. You can just prepare some chutney or curry powders or put it on your roti or anything like that. Okay, their nuts are rich source of magnesium, again cardiac friendly, calcium, zinc, iron, and very excellent source of healthy fats, protein, and energy. It lowers your bad cholesterol and improves your good cholesterol and keeps your satiety. That means you will be full after you eat a handful of nuts. Instead of eating samosa pakoras, you can always go with nuts. Cooking oil is really important for us. So it is always ideal to change oil. How many of us really change oils? Good, 20%. Okay. Let's all try to get different packs of oils. Okay. Anybody allergic to oils? Different kinds of oils? Oh, good. Fine. So outside fried items are fried again and again in the same oil. So they have something called as AGE products, advanced glycated products. They are very uh, bad for health. They are carcinogenic. ठीक है ना? The unsaturated bonds are broken and they become saturated. Hence, they lead to cholesterol production. So reused oils. You can use oil only 2 or 3 times at max, and it depends upon the temperature wherein you're boiling or frying. If you're using for a long time and then again you're boiling it, there is a chance of getting more carcinogens. Whenever you fry your oil, you filter it, remove the charred particles. They are nothing but carbons which produce carcinogens in the body. Second time you can use for cooking, not for frying. Again, if you're frying it, third time you have to use it for cooking, not for frying. These are the guidelines given by Food Safety Standards Authority of India. So we should be having a balance of using different kinds of oils, but do not mix them. Use one particular oil for breakfast and lunch. If you're preparing only once in a day, an alternate day basis, you can change your oil. Always limit your fats. So limit your saturated fat to less than 7% of your total energy and avoid dalda, which is nothing but your hydrogenated fat. Use always vegetable oils rather than your butter, lard, all this. How many of you all know what is lard? Lard is the pig fat. Pigs are hung to a hook and are given incisions. So under certain temperatures, they leach out the fat, the subcutaneous fat, the visceral fat. So that is collected and sent to all the bakeries across Hyderabad. You all eat Usmania biscuits, right? So that is prepared with that fat. So remember the biscuit and Srilata that time. Fine. So monounsaturated and polyunsaturated fats may help to lower the blood cholesterol. In moderation, it is always essential. Anything excess is always bad. Fine. So 3 to 4 teaspoons of oil per person per month should be excellent and do not exceed. And if a person is maintaining healthy body weight, he can take 20 to 25 grams of nuts, handful. Okay, no conjuicy. You can eat liberally. Fine. You need to lower your cholesterol, so reduce your saturated fat and zero trans fat for all the cardiac patients. Okay, I repeat, zero trans fat. Earlier it was 1%, now it is made to 0%. And cholesterol was earlier 300 to 250 milligrams. Now it is made to less than 200 milligrams. So lean cuts occasionally are allowed. That is fortnight or monthly once, not more than that. And we should have vegetable preparations along with the non-veg preparations, because you can see this chicken methi, palak methi, okay, vegetable combination, because non-veg lacks fiber and the food what you eat is rich in saturated fats and cholesterol. It gets deposited in your intestine and thereby into your blood cholesterol. So always try to take fiber which can bind with the fat and it comes out in the stool. So foods rich in saturated fat are your meat, poultry, bacon, sausages, whole milk, cream, and butter, right? And meat like pork and beef are very high in cholesterol. We should be very careful when we take those servings. Okay. Foods high in cholesterol includes egg yolk. Each yolk, the small one, will have 212 milligrams of cholesterol. Most of us eat two egg wala omelette easily, right? Please don't practice that. Trans fats are found in margarine, shortenings, and some fried foods and packed, which are made with dalda, okay, hydrogenated fats. So, non-veg is an excellent source of multiple nutrients. It's an excellent source of high biological value protein. It has trace elements, it has vitamins, minerals, and is really good source of vitamin A, iron, and all. Okay, so try to include fishes which are deep water, salmon, tuna, mackerel, and sardines. Trout, herrings also comes under this group. And at least twice a week, you have to include fish in the diet. Skinless poultry, focus on country fowls and egg even country fowls. This would add to beta carotene. It's a potent antioxidant for us. Red meat, which is very high in cholesterol, again high in sodium, high in saturated fat. So we should be very, very careful when you choose meat chunks. It should be pinkish in color. It cannot be red, over matured with the fat. If any fat, trim it off. So excess salt would increase your blood pressures, edema, and damage the arteries. It stiffens the arteries. It leaches out the bone calcium. How many of you know this? Salt eaters, all left side, they sprinkle or they put it with their fingers. So this leaches out the calcium from the bone, and it will make the person very close to the transplant. Okay, try not taking more of salt. Okay, you should always try to prepare and choose foods which are low in salt. Dosa batter salt, idli batter, puri dough, chapati dough, pesaratu dough, uttapam dough. Every food, everything salt is there. Try not to add in those batters and doughs when the patient is hypertensive, when they have cardiac issues or heart failure. Remember this most important, as it weakens the cardiac muscle even. Okay. If you are any diuretics, don't think that your hypertension will be stopped by taking drugs. Still, you should follow a low sodium diet. Okay. Sodium restriction will be better for the congestive cardiac failure symptoms. Once you reduce the sodium, you can find the symptoms to be fade away. Okay, not completely, but to a greater extent. So AHA recommends, what is AHA? Recommends 1500 milligrams for stage A and B heart failure patients, but you can go up to 2000 milligrams if it is a moderate failure. But always remember, in terms of layman talk, it is half a teaspoon per day for all hypertensive cardiac patients. Okay. So to mimic salt, we all are addicted to salt. So it imitates, like herbs and spices are there, vinegar is there, so you can add them. Okay. Sorry. You have the transplant patients, heart transplant patients, and your kidney diseases wherein they cannot excrete sodium out of the body. So you can use these salt substitutes for them. You can cook curries in milk or curd. Okay. That again gives a taste, which wouldn't require salt. So try to use low salt or light salt. Anybody hypertensive here? Nobody. So guys are lucky. Huh? Chechi, none. Okay. So I'm always careful. So this is repeated. So these all are our favorite foods, I think. Anybody who doesn't like? You don't like. Yeah, clap hands for a poor thing. सब लोग नींद में से उठ जाते हैं. Clap hands for her. You please stand, no? Please let us know somebody exists like this also. Please clap hands for her. That's why you are like this. Yeah. So you can see those colored fruit juices, processed fruit juices, chocolates, beverages. What do they have in them which are toxic to our body? Be careful. I'm going to ask you all questions. People who are sleeping, people who are talking. Carbonated. What does carbonic acid do? It leaches the bone calcium. It causes gastritis. Okay. They have high fructose corn syrup, which is really bad for us. Okay. Please don't depend upon such junk. And do not offer anybody also, if you're hosting any party at your home or in your workplaces, please don't offer such drinks. You can always call me. I will give you good beverages. Okay. Oh God. Mouth waters, huh? So they have loads of sugars, cholesterol, saturated fat. This is how you have to think, not mouth waters. Such a huge noise. Huh? And see that burgers, they are like king size. Like as we are growing in size, those are also growing size. When I know burger, it was only this size. How many of you know burger when it started? It was very small. It was very small. Now it is king size burgers with double stuff, cheese. What is that? Extra stuffing and all. Mayonnaise. Huh. See that all those things you can see. Huh. So these junk will give you high calories, saturated fat, trans fats, very high in sodium. They are added colors, stabilizers, preservatives, emulsifiers even, and they lack hygiene and sanitation and a very excellent source of infection. But still we crave to eat, right? So we should avoid foods which are really high in saturated fat, salt, and very low in FUFA and MUFA, which are heart friendly. Okay, they will be low in good nutrients and will be high in bad nutrients. So red meat, lard, and hard stick margarine should be strictly avoided in case of complicated cases. Pickles, papads, chips, savory items, cheese, butter, biscuits, bread, sauces, ketchups are excellent source of salt. Try not to eat them. For an example, I will tell you samosa. Samosa, the outer layer, your dough will have salt, soda. Inside sabzi will have salt. Again, your ketchup sauces will have salt. How much of salt do we take? No, we don't even understand and care for it. Avoid trans fats, sweets, and sweetened beverages. The first for that. So, packed or fresh fruits, whatever it is, fruit juices, you should avoid it. Aerated beverages, flavored fruit juices, squashes, thick shakes, sodas. Right? You have fruit sodas nowadays. Don't get carried away with the name. It has only the essence in that. It will not have any fruit pulp. Okay. And rich coffees. How many of you all drink this mocha, cappuccino, latte? So if you consider your latte, mocha or cappuccino, they give you somewhere around 400 to 650 calories. Remember this. It is more than your lunch or dinner. So something like this. Nobody eats, no? You eat that as well as this. Okay, I know that. This in small quantity, those in huge quantity. So unsalted, non-fried nuts. You don't choose salted pista, fried cashew, fried almonds. Please be wise and honest for your health. Okay. So whole fruits, cut fruits, excellent vegetable salad, sprouts, boiled grams, roasted grams. Boiled grams is your gugilu, barbatti, gudalu, right? And your roasted grams is your puffed one. Battilo adinchina senagalu, bunawa, chane, rajma, whatever it is. Then your puffed rice, veg bale, roasted puffed rice with chana or putana, whatever it is. Fine. You can even have roasted flakes, atukulu, murmure, chawal ka choda, anything like that. So healthy beverages, ragi malt, buttermilk, zira pani, pudina pani, amka panna. Anybody knows amka panna? That raw mango will be cooked and the pulp is extracted. Some zira powder is added and taken. That's a very good health drink. Green tea, green coffee, black coffee, tender coconut water, and homemade soup. It is homemade. It cannot be commercial because they have milk solids, saturated fats, cholesterol, and lot of MSG. What is MSG? Be loud, please. monosodium glutamate. I thought some nuts is telling me. Okay, they will have Chinese salt, Ajinomoto in that. Okay, because to give that flavor, that umami flavor, you get it in the commercial preparations of soups. So they are not really advisable. Also, they have different kinds of fat. If you see the codes on that, read the numbers and scan them, you will get to know what the preservatives and different additives present in them. Okay, we are like that. The person in the car. How many are outside the car? How many are inside the car? Most of us are inside the car, right? I know. So, see, you should take exercise every day, 30 to 45 minutes of physical activity, mandatory. Walking is an ideal exercise for all the age groups. ठीक है ना? So, when we consider these patients, caffeine is good to some extent. It's a refreshing agent. It secretes more of neurotransmitters. Anybody can tell me one or two neurotransmitters? Homework. ठीक है ना? You have to be careful, not more than 1 or 2 cups of tea, coffee. Sorry. Record your daily fluid intake and output, which is really important. Check your body weight in the morning before your breakfast and after urination, especially for the cardiac failure patients. They should be physically active, some sort of regimen, and they have to visit a therapist so that they would advise them depending upon their clinical condition. And stress is to be managed with some sort of activity. Okay, sleep proper, 6 to 8 hours, and they should avoid naps and big meals before night because they wouldn't tolerate it as their gut functioning will be lowered. Okay, always the feet should be up with the pillows. Okay, alcohol increases the blood pressure, weakens the heart muscle, elevates triglycerides, and leads to thiamine deficiency. What does it lead to? Excess alcoholism. B1 deficiency. Dietitians also can tell. Yes, Wernicke's encephalopathy or Wernicke-Kirchhoff syndrome, anything which leads to B1 deficiency. Okay, smoking is very bad. It damages the vessels and thickens the blood, causes high blood pressure, causes heart diseases, arrhythmias, heart attacks, strokes, peripheral vascular diseases. Okay, thank you for your kind attention. Okay, any questions? I would be happy. I know Miss Rani wants me to leave the dais. I totally understand her. Yeah, any questions? I would take. Yeah, please. Caffeine, I am speaking. We are talking about cardiac ailments now. For normal people, yes, 2 to 4 cups is okay. Our caffeine content per day should be less than 300 milligrams. 250 to 300 milligrams, that comes for 4 cups. But what happens is when you take a milk tea, you tend to add more of coffee powder and tea powder, right? When you take it as a transparent one, a decoction, so you would add very less of it. The content of caffeine, what you get will be pretty less, or it would be in the recommended amount. And they have good amounts of antioxidant properties, helps in weight reduction, and is good for cardiac functioning even. Hmm. They all came to our hospital. Don't worry, we had quite number of people. True, correct. No, no. If at all any crash diet, keto is never bad if it is given by a dietitian under her supervision for a short period of time. Let's say if a person obesity is 40 to 45 BMI, they have to lose 30 to 40 kgs at once. So with a normal stipulated diet, it wouldn't happen. So, but what American Heart Association suggests is anybody shouldn't worry about their weight. Once if you lose 10% of your weight, it would add to great benefit to yourself. So gradual sustained weight loss is always advisable. But if you still want any crash diet because of the erratic sugars or blood pressures, or it is causing compromise of one or two organs, then yes, they would go with keto under a clinical dietitian supervision for a short period of time. Yes. Chechi, your comments on that. So most of the researchers and studies says that it is rich in saturated fat. So let us not use it because of their vegetation, because of their antioxidants, what they take, and because of the fiber inclusion and the fish eaters. So they are not prone for that. We do not consume fish as frequently as they do. So it is always ideal that South state people go with till oil. How about till oil? Nuvul nune, til ka tel. That is excellent for cooking. You can go with groundnut, which is again rich in mufa. That is good for heart. You can go with sunflower occasionally. It cannot be regularly. Mustard oil again is excellent, but it has pungency. Okay. Thank you, Ms. GB, for giving me this opportunity. Okay. Thank you guys for your attention.
Thank you so much, ma'am. Really, it's like very informative session and interesting session also, especially food, right? Yeah, within 5 to 10 minutes, we are going to wind up this session. Now, I request Miss GB ma'am to give vote of thanks about this program.
Good evening. All are sleepy still? Backbenchers. Always my backbenchers is always sleeping. So I just wanted to say thanks to each one of you here gathered here since morning, especially the uh, coordinators and each and everybody. And since yesterday, there are many people are working for that. And since 2 days, everybody is practicing of this, what we have done our huh, role play. Yeah. So I would like to thank Dr. Sharad Reddy, those who, the managing director of the Medicover Hospital, to motivating us to do such a nursing workshop on World Heart Day. And I would like to say thanks, Dr. Rakesh sir and Ma'am Swati madam, for encouraging us to do such an activities. And I would like to say thanks the IP block center head, Mr. Madha Prasad and Dr. Anusha, to encourage us to do as part of this World Heart Day. Yeah, Dr. Madha Prasad. Okay, so the last and least, uh, so I just wanted to say I would like to thank the Dozy company people, those completely sponsor for that today. And last and but least, I would like to thank organizing people and the participants, housekeeping, and the canteen, FNB, and all the participants. So thank you. I forgot to say all the speakers. I'm really because there are since Monday last week we are back of some of the consultants to gather on the same platform, and those who are given in the morning hours, all the doctors in 3-4 days we are back of them to do a program. And Sridhar, I really forgot the speakers and Srilata madam. Every time we used to give her reminder, madam, reminder today is the 28, you have to do speak. So it went well. So thank you. Thank you all.
So thank you one and all. Behalf of Education Department, I sincerely thanks to Miss Swati ma'am and Miss GB ma'am for conducting this kind of workshop for nursing staff, to encourage the nursing staff, to motivate the nursing staff to learn the best practices at bedside, right? Thank you one and all.